Assalamualaikum warahmatullahi wabarakatuh. May peace be upon us all. Shalom, Om Swastiastu, Namo Buddhayo, Salam Kebajikan. Distinguished delegates, ladies and gentlemen, a very, very good morning. Selamat pagi. Another warm welcome to the beautiful and historical Yogyakarta special region. Last night, we've had such an inspiring evening at Sekar Kedaton, bringing us closer to the distinctive culture and cuisine of the Indonesian people. And this morning, we have embarked upon the opening of the second ASEAN Academic Conference on Disaster Health Management, taking place here in Yogyakarta Special Region on October the 18th and the 19th, 2023. First order of business, ladies and gentlemen, allow us to extend the warmest welcome and a very good morning from Yogyakarta to all of our distinguished delegates and guests, as well as esteemed speakers and participants joining us both in person here in the city and also virtually. And also would like to acknowledge the presence of our viewers joining us through online platforms out there across the archipelago from ASEAN member states and around the globe. Thank you very much for joining us and welcome. Delegates, ladies and gentlemen, this conference is organized to share knowledge and provide innovative scientific insights on the disaster health management, as well as strengthen networking among policy and decision makers, medical practitioners, and researchers, as well as academics. Delegates, ladies and gentlemen, to infuse culture into the opening ceremony of the conference this morning, may we present you with yet another taste of our beautiful culture here in Yogyakarta. This performance tells the story of a bright and dark sides of the journey of life that we must live with determination. The control of life is in our own hands. It is inspired by the natural movements of eagles, from the gaze of the eyes, the flapping of the wings, the speed of the flight, to the strength of the grip. The nature and character of the eagle is applied in the dance movement as an expression of determination. Ladies and gentlemen, please give a rousing welcome to the dance of Ksatria.
Kibaskan selendangmu, nyanyikan kidung dengan nurani. Jangan pernah engkau berhenti, yakinlah dengan sepenuh hati.
Ksatria Dance of Yogyakarta. Thank you very much, ladies. Another round of applause for the talented dancers, ladies and gentlemen. Thank you very much. Distinguished delegates, ladies and gentlemen, we are now honored to invite the welcoming remarks from the Dean of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Yogyakarta. Please welcome Mr. Yodi Mahendra Datta.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Distinguished guests, colleagues, friends, ladies and gentlemen, my job this morning is to welcome you. But let's do it a bit different. To pump up the energy in the room, let's make it a bit more interactive. So what I'll do, I'll call the ASEAN member states one by one. And if I call you country, please stand up. And the rest of you, please give a warm applause to welcome, okay? So in no particular order, Thailand, please rise. Delegate, give an applause. Sawadee, colleagues from Thailand. Thank you. Vietnam, please rise. Xin chào. Cambodia, please rise. Chum Repso. Laos, please rise. Sabaidi. Sabaidi. Myanmar, please rise. Minglaba. Philippines, please rise. Mabuhay. Singapore, please rise. Welcome. Brunei, please rise. Selamat datang. Malaysia, please rise. Selamat datang. Indonesia, please rise. Selamat datang, Sugeng Rawo. And the rest of the audience from other countries, friends of ASEAN, please rise. From the other countries, US, Fiji, Japan, Konnichiwa, Bon dia, a very warm welcome to the second ASEAN Academic Conference on Disaster Health Management. Distinguished guests, colleagues, ladies and gentlemen, the theme of our conference is Knowledge Co-Creation for Resilient Disaster Health Management towards one ASEAN, one response. So this theme highlights the pressing need for a united cooperative front in the face of escalating disaster threats. This theme also echoes the belief that synthesizing diverse knowledge, experience, and perspectives can forge a robust foundation for a unified approach to disaster health management. So in these next couple of days, through discourses and discussions, we aim to harness the collective intellect and creativity of Asia's finest minds on this stage, in this room, in the virtual space, to steer our region toward a more resilient, prepared, and compassionate response to disasters and health emergencies. I extend my deepest gratitude to each one and every one of you for your dedication to advancing disaster health management in the region. Your active participation and invaluable contributions are fundamental to the success of these conferences. May our deliberations in the coming days pave the way for a future where one ASEAN, one response become a reality, ensuring the health and well-being of our diverse communities. Thank you, and let us embark on this journey of knowledge co-creation and collaboration. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dean of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Yogyakarta, for the welcoming remarks. Delegates, ladies and gentlemen, allow us now to extend invitations to deliver his remark, Chair of the Steering Committee for the ASEAN Academic Network on Disaster Health Management, who is also the Secretary General of National Institute for Emergency Medicine of Thailand. Let us now say Sawadi Ka to Mr. Acharya Panga.
ดร. Yodi Mahendra Hatta, the Dean of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Indonesia. Dr. Sumaria, Director of Center of Health Crisis, Ministry of Health, Indonesia. Distinguished delegates, ladies and gentlemen. First of all, I would like to congratulate to Indonesia for the official opening of the AIDHM yesterday and hosted the second ASEAN Academic Conference on this occasion. I wish to see the growing of ASEAN Academic Network in ASEAN very soon. On behalf of the current chairperson of the Steering Committee of ASEAN Academic Network on Disaster Health Management, and on my own behalf of the Secretary General of National Institute for Emergency Medicine Thailand and Project Director of the ARCH project, I have to express my greatest appreciation to our keynote speaker, panelists, moderators, presenters, observers, and staff of joining the second ASEAN Academic Conference on Disaster Health Management right here in Indonesia. It is my hope that the second ASEAN Academic Conference on Disaster Health Management would be able to achieve its objective in providing effective forum for academicians, researchers, and practitioners to advancing knowledge, research, innovations relating to disaster health management for our global community. This conference has attracted participants that are not limited to the 10 ASEAN countries. We will hear almost 45 oral presentations. The subjects range from responding to the natural disaster, public health emergencies, preparedness, curriculum to human resource development. I am sure that the selected topics will provide you to a wealth of information and many opportunities for discussion. This conference means a lot. Not only that is the second forum for academicians to work together, but it also marks the beginning of many initiatives. We visited the Secretary Office of ASEAN Institute of Disaster Health Management, and we will hear about the ASEAN joint research that we are all waiting for. Thus, I believe that this conference has very special meaning to the ASEAN academic community. Talking about academic and the body of the knowledge, this would refer to the wealth and gifts of the humanities. Reviewing the existing knowledge is a good process of checking our understanding of the natural and human doing, but exploring new insight, building new body of knowledge, and synthesizing new theory that have never been shown to the world as is also necessary. As the famous philosopher of the ancient era, Socrates said, the secret of change is to focus all of your energy, not on fighting the old, but on building the new. So, I encourage you, young academicians and researchers, to explore your vast seas of the knowledge. I am confident that you will succeed your objective. I hope this conference will bring you the change for the better world, safe from consequence of disaster. Our community is now full of armed conflicts, which bring about chores and catastrophes. However, disasters are different. Our common goal is to better understand, prepare, and respond to it. Collective effort is the only way to be able to live with the deteriorating nature. Let us our gift to bring about change. Before I end my remarks, I would like to say thank you to our host country, Indonesia, who have worked really hard to make this conference possible, and also the Arch Project team in providing continuous support. I would wish you a very pleasant stay and productive and successful conference. Thank you.
Thank you very much, Mr. Acharya Pangma, for the remarks this morning. Distinguished delegates, guests, ladies and gentlemen, and now the keynote lecture session from the presidents of World Association for Disaster and Emergency Medicine, or WADM, who will be speaking about defining the discipline, advancing disaster health management in a changing world. Please give a warm welcome to Mr. Donald A. Donahue.
Thank you, Mr. Moderator. Excellencies, distinguished hosts, the committee, and esteemed colleagues, I bring you greetings from the World Association for Disaster Emergency Medicine. This morning I'm going to speak about the challenge of not only an emerging discipline, something that hasn't been defined, but an emerging discipline that's changing even as we sit here. Einstein once spoke about imagination. He said, it's important to understand, to know facts, to have knowledge, but it's even more important to know what we don't know and have a thirst for discovering more. So in disaster medicine, I get the thing to work. Whoop. What did I do? There we go. In disaster medicine, that indicates the need for what a colleague of mine calls professional pessimists. We have to try to imagine the unimaginable. In many ways, us being here today is built on visionaries and leaders, people who developed disaster medicine and emergency medicine. Rudolf Frey was an anesthesiologist in Mainz, Germany. He fashioned himself as a resuscitologist. They understood that we need to get better at saving lives, created what was then the Club of Mainz. Peter Sattvar invented CPR. Peter Rosen is the fellow, the founder and the father of emergency medicine. Professors De Backer and Della Corte created the Masters of Disasters and Emergency Medicine. Donna Barbish is a nurse I worked with at the Pentagon, a general who was talking about this 30 years ago. Skip Burkle is a leader and a mentor to many of us. Kobe Pellig also. Dr. Otomo from Japan, and last but not least, Dr. Greg Ciatone, who's my predecessor as president and the editor of what's arguably the definitive book in disaster medicine, Ciatone's Disaster Medicine. As was indicated, if you were here yesterday, the variation and the amount of disasters is endless. and they're getting worse. If it seems like there are more and more disasters, it's true. It's because there are. And so I decided, then we have the human dimension, the fact that humans can create disaster risk, and in some cases, war, terrorism, industrial accidents, and my bottom bullet there was we learned in Haiti, sometimes our best intentions can cause other problems. We can bring problems with us. So I decided to look back about 6 weeks and see what's happened in the last 6 weeks since the beginning of September. So we had an earthquake in Morocco, a flood in Libya, an explosion in Uzbekistan, a club fire in Spain, a suicide bombing in Pakistan, flooding in New York City. This was significant, 22 centimeters of rain in less than half a day. This caused, while nobody was killed, this caused the hospital, one of the hospitals there, to have to evacuate. The power went out, their backup generator kicked in, but then in order to restore the power company said, you have to empty the hospital so we can recover. So, huge challenge. Church collapse in Mexico. At that point, an earthquake in Afghanistan, followed by another, and another. They had 4 earthquakes in a week. At about this point, I decided to give up. The pattern was clear. I would be remiss if I didn't acknowledge, in this region, two of arguably the disasters of historic and epic dimension. So disasters are not unusual to this part of the world. Here I would introduce a concept that one of my French colleagues developed. If you look at rather than a 4 chart, you look at 3 axes in each direction. Can the community withstand a disaster? Is the community overwhelmed? Other indicators. So we know emergency medicine kind of falls into that location. Generally, we respond well, everything's organized, casualties are limited. Humanitarian medicine sort of drifts a little bit more to the right. Things get a little unclear. The supplies get a little rarer. Military medicine, even more so. The malintent of an adversary creates uncertainty. Disaster medicine, all the way to the right. Nothing works. There's not enough of anything. Mass chaos, multiple casualties. But it's not your grandparents' disaster medicine. What we did a century ago or even 50 years ago is very much different. We have great technological and scientific advances that we can model. We have algorithms, we have medicines, we have firefighters with drones that can surveil areas. But there's also some concerning facts. Last 5 years, or more than that, 7 years, were the warmest years on record. Sea levels reached their historic highest in 2022. Over 630 million people live at an elevation of 10 meters or less of the sea level. We have, for the first time, an airborne transmission with a R0 greater than 2 emerged in the time of modern air travel, when within a day and a half, you could be anywhere in the world. Large-scale active warfare in and around nuclear plants. AI-empowered weapons. There are now drones that can search you out and kill you without human intervention. Entire healthcare systems, IT, we were discussing this yesterday as we were touring the campus. Denial of service, ransomware. Entire health systems can be neutralized by the loss of their healthcare records. And chemical weapons, can kill tens of thousands, hundreds of thousands, maybe even millions, can be purchased on the street or ordered online and delivered right to your front porch. So, in many ways, we have a crisis hiding in plain sight. Today, there are over 110 million people who do not live in their home. If that was a single nation, a unified nation, it would be the 14th largest nation in the world, larger than Germany, larger than Turkey, larger than France. 40%, almost half are under 18, and there's internally displaced people who have not left their nation but still do not have a home. These are incubators for health problems. And Yesterday, they talked about the definition of a disaster. You can read it. Serious disruption that exceeds our capabilities. If you look at the picture, and this is from IFRC, we tend to look at disasters as something sudden, something unexpected, and something immediate. We were very much disavowed of that over the last 3 years. There's a strong argument that COVID was a disaster. It was a slow-moving disaster, but it was a global disaster that impacted every one of us in different ways and continues to impact every one of us. The pandemic may be over, but last Thursday, I attended the funeral of one of my neighbors who died of COVID. And COVID is maybe a prelude, past the prelude. 2007, summarized, the 2007 World Health Report said that more than one novel disease has emerged every year over the past 40 years. That's now the past 50-some years. Faster than ever in history, diseases are coming out. And I won't delve into comparative fatality rates, case fatality rates, but anecdotally, the 1918 so-called Spanish flu that killed between 50 and 100 million people in the world in a population of 1.7 billion had a CFR between 1 and 2%. COVID hovers, statistics are inaccurate because we don't gather them well, between 1 and 3%. My veterinary friends who are watching at H1N1, which is clearly relevant to this region, for the humans who've succumbed to H5N1, between 50 and 60% of them have perished. If that virus jumps to humanity, we have a challenge on our hands. So, impact. This is a complex slide, but climate change is more than just rising seas. It impacts disease vectors. It impacts pulmonary function. You can read that. It cuts across the board. It greatly influences negatively human health. And I talk about imagination. Well, unfortunately, others can have imagination too. On the left slide, you'll see a depiction of, those are lethal doses of heroin, fentanyl, and carfentanil. You'll see that it's much smaller. That little, you can almost barely see the speck of carfentanil. That's a lethal dose for a human. On the right side of the page, you see some technology, commercially available technology. My colleagues at Boston looked at this and they said, you can go online and buy a drone that's designed to be a crop duster. And you can see the yield there, 21.3 hectares per hour. That's a lot, that's a big spread. That's a lot of stuff. They looked at this and they went to one of the stadium near Boston and they ran an exercise, an analysis. And it's their statistics, so I can't delve into it. But what they found out is even before an event, not before everybody gets in the stadium, when people are queued up, waiting to get into the stadium, you could fly it, if you flew a drone over there and spread fentanyl or carfentanil, I'll come back, 1 kilogram, that's nothing. I'll aside, human nature, you're standing in a queue, you're getting ready to go see a World Cup game or a concert, and a drone comes over, what do? You wave. You look up and you wave. So the results of that analysis, over 12,000 casualties at that one spot. And you could have all the naloxone, all the antidote in the world. You could have rail cars full of it, and a battalion of medics waiting to respond. There's no way you're going to treat 12,000 people within that 5 minutes after exposure. This causes chills. The risk of radiological disaster is on the rise. I alluded earlier to the conflict in Ukraine, but it has happened before. A significant event, probably not well known, was in my Portuguese is bad, Goiânia, Brazil. There was a hospital there that closed, and they abandoned the facility. Sometime later, some scrap metal hunters came. They found a bunch of scrap metal, and they found a canister. that was really shiny. They took it home. They thought it was interesting. As they disassembled the canister, there was a strange glowing blue substance inside it. They thought it was pretty. Some people, the wife and one of the daughters, put it on as makeup. 4 fatalities, multiple amputations. Why I raise this is when the announcement went out that there was a radiological incident, 130,000 people presented for evaluation, 10% of the entire population. You don't have to answer, but I would guess that almost nobody in this room, your hospital, your health system, could deal 10% of the entire population all at once. 112,000 were examined, you see that, and only very few had radiation sickness, but it was a warning to us. And then there's artificial intelligence, the brave new world that we really don't understand. This is courtesy of Dr. Ciatone. He looked up what is disaster medicine. You can sort of scroll this. This came from ChatGPT. This was defined, and it's pretty accurate and pretty scary. So while it's a tool for enlightenment and for knowledge, it could also be a tool for the other side of the fence. What are the bad things? Greg did this too. We can weaponize AI. We can create discrimination. We can violate privacy. We can spread misinformation. Something truly scary. So you might say that we've learned our lessons. And then again, maybe we haven't. The left-hand picture is from 1918. People wear a mask. People would go to jail if they didn't wear a mask. Varying countries on the right and more recently. Different countries had different responses, different level of responses. It boggles my mind that people would not wear a mask, but lots of people didn't. We need to focus on our core skills. One of my pet peeves for years now, we write doctrine, and we talk about chem-bio operations. There's no such thing as chem-bio. For the clinical, one's a pathogen, one's a toxin. If they show up in the ER, they're entirely different responses. We need to abandon that military construct and move to something better. We also need to understand reality. Reading the sub-bullets there, your victims are not going to stand around waiting for EMS and civil protection to get there. They're going to go to the hospital, any hospital. They're going to come to your hospital. They're going to come to your clinic. I actually had an incident as an ER administrator in New York City where there was an industrial accident. I happened to be walking by during the handover, and I heard the fire and EMS tell the triage nurse, this happened. They explained what happened. There was a gaseous cloud, and the 2 gentlemen went into pulmonary arrest. And I stopped and I looked and said, they went into pulmonary arrest, and you were there to help them? And they said, yes. I said, so whatever that gas was is all over you. And they looked and they went, oh yeah, I guess so. Now, this was standing in the middle of my emergency department. We have to be ready for issues like that. We need to emphasize core skills that we're missing. There's a wonderfully diverse and expansive urban search and rescue system. My challenge is, what do you do while you're waiting for urban search and rescue to show up? How do you save lives? Lots of people did things in Haiti. Retrospective studies said there were far more amputations than were clinically indicated. So what we did, in trying to do good, we created a lasting legacy of problems for the people that we tried to help. Risk communication, we're universally bad at that. Mental health, veterinary and One Health. Understanding the cross-disciplinary applicability of what we talk about and what we lean, and other matters. True experience. When I was in the Pentagon, we designed and ran a training center that trained urban search and rescue and military medical folks. And at one point we had USAR and military medics in a simulated collapse structure. At that point, the cadre, the director of the course, pulled out an air horn and blew it. Bump, 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 bump. If you've served in, I'm sure it's universal, because in NATO in the US, the intermittent horn blast is the indicator for a chemical or biological attack. So you stop where you are, you put on your protective mask. For urban search and rescue, it's the signal for an imminent building collapse. The faculty stood there stunned, realizing that if that had been an actual situation, one of those teams has a huge problem. One of those teams probably isn't going home. We also have things we need to learn. At the Mira office building in Oklahoma City, when it was bombed, you see 168 people lost their lives there. The 168th was a lady named Rebecca Anderson. She wasn't in the building. She was a nurse across the street. She entered the building to try to help people. She lost her life trying to do that. We need to train not only how to save others' lives, but how to preserve our own lives. We have vexing phenomena. There were some allusions to some of this. Disaster tourism. The morbidly curious are going to show up to watch this. That's this unbelievable human tendency. The suspect provider. The provider has been barred or lost his or her license is going to show up because it's a chance to be a hero. It's a chance to get access to supplies, maybe even the money. How do you vet? How do you know the people who are volunteering know what they're doing? Immediate responders. That's a concept I got from a physician who was at the Boston Marathon bomber. And I find it fascinating. Not your first responders, but the people who are on site and not only are responders, but are impacted by the incident. That's an unusual double trauma. We rarely take care of them. We rarely go back and see to their mental health. PTSD goes without saying. Systems failures. When everything goes wrong, everything goes wrong. Logistics constraints. Do we get the right amount of supplies? Do we have the right anything we need? Do we have transportation? Too much of a good thing. After the earthquake in Haiti, 3,600 NGOs showed up. It was chaos. You know, supplies fly in. It was interesting. In Nepal, for the earthquake in Nepal, the Nepalese government said, if you're sending supplies, I want a list of where to come from, who paid for it, who's receiving it, when are they receiving it, and what's the intent. They effectively managed the flow of supplies into their nation. And the vulnerability of technology. So we see it in cyber attacks. I moved to an electronic system. I moved to electronic monitoring. When that technology fails, we have to revert to basic old skills. So we need to provide advanced disaster education across disciplines. 500 years ago, Copernicus defined, got a little ahead of myself there, defined knowledge as medicine, physics, chemistry, and math. It's worked well for 500 years. Now, I'm going to move these forward. Now it can be argued that we're medicine, physics, chemistry, and math. We build on our base of knowledge, and the advances come at the top level as we create more. Similarly, disaster medicine, there's a Greg Ciatone slide, so they go slowly. We have disaster risk reduction. We deal with casualties, we deal with response, and we deal with recovery. Similarly, the advances we make in disaster medicine are going to come at the top of those pyramids as we push the boundaries of our knowledge and our education and our collaboration. Again, I think they post these slides, the future of disaster medicine, courtesy of artificial intelligence. Truly scary. So, at Wadham, and I would propose across the room, we have an advocacy agenda. We need to develop core curriculum. What curriculum applies to the physician, the nurse, the dietitian, or the veterinarian, the dentist? There's a lot of skills out there. Sort of an aside, your best diagnostician you've ever met is a veterinarian, because their patients are diverse and the patients can't present with a problem. You have to diagnose. Dentists have great skills. They can suture, they can immunize, they can triage. We need to get better at training across boundaries. We need a common lexicon. Go back to the operational parable, two different groups using two different terminologies. We need to expand and enhance our education, training, and planning to make it multidisciplinary, interdisciplinary, and transdisciplinary, slightly different construct. We need greater information sharing. That's already been addressed in this room. Sharing information back and forth. We need expanded medical intelligence capabilities, poorly understood realm. But wouldn't it be better? Epidemiology is wonderful, but it's retrospective. Wouldn't it be better to identify disease before it outbreaks based on early indicators and indices of suspicion? We need to increase our organizational collaboration. Here we are. And we absolutely need to promote research and publication. You know, the research and publication in disaster medicine is truly in its infancy. And tongue-in-cheek, I said one of the challenges we have is the control group always complains they're not happy about their classification. But we need to get better at that, and we need to share information. And that's Pre-Hospital and Disaster Medicine is Wadham's sponsored journal. We do this through promoting global integration. We have regional chapters in Wadham. They coordinate and collaborate. They conduct educational events. You can see they share information and they provide advocacy. That's the regional focus. We also have special interest groups, sort of a matrix design. So it's something that's topic focused. So people are all interested in mass gatherings. At the end of the month, I'm speaking at a conference in Riyadh. You know, so it allows us to talk about topics and functions that not limited by geography. Innovation, representation, professional development. I'm not sure why UPO popped up there. We have a large network, not large enough, of affiliate organizations. The American Academy of Disaster Medicine is a board certifying. We have universities, the Beth Israel Deaconess Fellowship in Disaster Medicine at Harvard. We have other affiliates. Plus, we do work. We have done great work, and we are expanding that with the World Health Organization. Over the last couple of months, I've spoken to the Universal Access folks, to the EDRM folks, to the Risk Communications folks. It's no news to everybody here, the amazing, huge bureaucracy, so you can talk to lots of different people. We have a strong relationship and is expanding with the EMT program. We're a member of the Health Cluster, Global Health Cluster. And significantly, since assuming presidency of WADAM in May, we've signed an MOU with UNITAR. When they reached out to us, I had never even heard of UNITAR. It's the United Nations Institute for Training and Research. It's on the Peace Division. It's not within WHO. To me, that's a wonderful conduit to reach out to nations and promote what we do by talking at that level. We need a new culture of global health and healthcare leadership. You know, understanding that in many cases the old rules just no longer apply. Interdisciplinary engagement activity is necessary. You know, our disciplines, other disciplines, cultural anthropology. I use it as example, the 2014 Ebola outbreak in West Africa wasn't a clinical challenge. Ebola is horrible, but it wasn't a clinical challenge. We know what to do clinically. It was a cultural anthropology challenge. Until we got the people to change what they've been doing for generations, that disease was never going to abate. Urban planning and architecture, the human factors, engineering, communication, religion, and international relationships all play a role in what we do. Yet rarely do we talk to those communities, or if we do talk to them, I believe we don't talk to them enough. Some more healthcare broad, servant leadership, cultural competency. Do we understand the people we're trying to help? Do we understand what motivates them? Do we understand disruptive innovation? I mean, I could have a physician in Paris doing surgery in Afghanistan be a robot. How do we leverage that stuff? Leverage that. Promoting resilience and resourcefulness, and always, always, always expect the unexpected. The goal, therefore, is to assemble teams that have different functions, but that can pull together and work collectively. And I never tire of watching this Formula One video. You know, within a second and a half, tires are changed, oil's put in, cars refueled, and the driver's on his way. We need to strive for similar efficiencies. So, in closing, on the 12th of September 2001, I was sitting in my office, my workspace in the Pentagon. Only a colonel, you don't get an office. But I was sitting in my workspace at the Pentagon when a historic event happened. Nothing that any of us in the building would have anticipated. the government formed a commission to examine what went wrong, what caused what we call 9/11. The commission's conclusion was that there were four kinds of failures. The first one, imagination. We failed to imagine our risk. We failed to imagine what other actors would do. And then policy capabilities and management are all driven by that imagination. So once again, I believe it's time for that professional pessimist. Try to think the unthinkable, work together. And I must say, editorialize, I've been truly impressed. The collaboration, the spirit, and please, ASEAN, keep up the good work. And I hope to see you at our biennial conference in Tokyo in May of 2025. Thank you very much.
Thank you very much, Mr. Donald. Please kindly remain on stage. Sir, kindly remain on stage as we would like to use this opportunity to present with you our tokens of appreciation. And may we request Dean of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Yogyakarta, to present the tokens of appreciation, inviting Mr. Yodi Mahendra Datta. Such an insightful and eye-opening keynote address, ladies and gentlemen, from the President of World Association for Disaster and Emergency Medicine, or WADEM. We present our token of appreciation. Please. Thank you very much. May we now invite Mr. Yodi and Mr. Donald A. Donahue to return to their seats. Thank you very much indeed. Distinguished delegates, ladies and gentlemen, please bear with us as we await connections with the Secretary General from the Ministry of Health of the Republic of Indonesia for the opening remarks. The last word that we received from the ministry is that currently the Honorable Secretary General is in a meeting ongoing right now with the Minister of Health of the Republic of Indonesia, and we are waiting for moments for the Secretary General to join us to officially open our conference here in Yogyakarta. We hope to have him on the screen very, very soon. Ladies and gentlemen, may we now invite the Secretary General of the Ministry of Health of the Republic of Indonesia to deliver the opening remarks. Please welcome onto the screen Honorable Mr. Kunta Wibawa Dasanugraha.
Okay, thank you. Sorry for late, because I have another. Good morning, Excellency, Chair of Regional Coordinating Committee on Disaster, the Steering Committee of ASEAN Academic Network on Disaster Management, College of ASEAN Member States, Chief Advisor of Japan International Cooperation Agency, or JICA, and the ASEAN Regional Capacity on Disaster Health Management team, representative from Health Division, ASEAN Secretariat, representative from ASEAN Coordinating Center for Humanitarian Assistance on Disaster Management, representative from the World Health Organization, representative from the United Nations Office for Disaster Risk Reduction, and President of the World Association for Disaster and Emergency Medicine, Rector of Gajah Mada University, Dean Faculty of Medicine and Public Health Nursing of the University of Gajah Mada, and distinguished ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. So it is my pleasure to welcome you to the second ASEAN Academic Conference on Disaster Health Management. Let me take this opportunity to express my appreciation and gratitude to the ASEAN Academic Network on Disaster Health Management, the ASEAN Regional Capacity on Disaster Health Project, Japan International Cooperation Agency, and the Government of Indonesia for hosting this conference. This conference aims to strengthen academic network cooperation and enhancement among disaster health management programs, conduct research and extract lessons learned from disaster health management in multiple events and countries, and support the development of new solutions and innovation. ASEAN is one of the world's most disaster-prone regions, accounting for 1 in every 10 natural disasters during the past 120 years. This region is highly susceptible to a wide range of natural disasters, including earthquakes, tsunamis, typhoons, floods, landslides, volcanic eruptions, and drought. Within the last 2 decades, the destructive and monumental scale of disasters, including the massive tsunami that struck in Indonesia and Thailand in December 2004, Cyclone Nargis in Myanmar in 2008, Typhoon Haiyan in Philippines in 2013, the earthquake, tsunami, and liquefaction in Central Sulawesi, Indonesia in 2018, and recently, COVID-19 pandemic. All of these disasters had an impact on the well-being of communities and countries, as well as increased the number of deaths and disabilities. The reasons behind Southeast Asia's susceptibility to natural disasters include its location along major tectonic plate boundaries, such as the Pacific Ring of Fire, and its exposure to monsoons and cyclonic weather systems. As a result of this vulnerability, it is important for ASEAN regions to take urgent action in strengthening the disaster health management system to improve the region's resilience and ability to respond effectively to disasters. Ladies and gentlemen, knowledge plays a critical role for better disaster health risk reduction. Research is crucial for developing effective strategies and policies, problem solution, innovation, and technology development to mitigate the health impact of disasters. There is a need for the government, public and private sectors, and civil society organizations, as well as academia and scientific and research institutions to work more closely together and to create opportunities for collaboration and for business to integrate disaster health risk reduction into our management practices. First, ASEAN Academic Conference on Disaster Health Management was successfully conducted virtually, hosted by Thailand, and project for strengthening the ASEAN regional capacity on disaster health management in December 2021. Today, in the second academic conference, we will share knowledge and provide innovative scientific insights on the disaster health management, as well as strengthen networking among policy or decision makers, medical practitioners, as well as researchers and academics with the theme knowledge co-creation for resilient disaster health management towards one ASEAN, one response. Ladies and gentlemen, I am delighted to announce that starting from today, ASEAN Institute for Disaster Health Management is officially operational. We would like to express our gratitude to the Chair of the Regional Coordination Committee on Disaster Health Management, Project Secretariat Thailand, ASEAN Member States, and the ASEAN Secretariat for your continuous support. The establishment of the ASEAN Institute for Disaster Health Management also reflects our commitment to excellence in supporting policy and research in disaster health management. I would also like to extend my appreciation to our team from the Ministry of Health and University of Gajah Mada on their hard work and dedication to prepare and conduct this event today. Additionally, thank you to all the participants who joined us today. I strongly encourage you to share your experiences and discuss further steps for disaster reduction in our region. Let us continue to work together and support each other to build a safer and resilient ASEAN region. Thank you.
Thank you very much, the Secretary General of the Ministry of Health of the Republic of Indonesia, Honorable Mr. Kunta Wibawa Dasanugraha, for the opening remarks. And with the lights off, ladies and gentlemen, we now invite you for a 10-minute coffee break. Your delicious coffee, tea, and delicacies are prepared outside. We hope to see you in 10 minutes for the exciting session 1 of the conference. Thank you.
can bend them.
Delegates, ladies and gentlemen, due to time constraints, may we now invite our participants of the conference to please join us in the conference room. You are more than welcome to bring Distinguished delegates, ladies and gentlemen, welcome back. Session 2 is now in order. We will talk about disaster and public health. Allow me to introduce our esteemed moderator for the first session of the conference. He is a member of a steering committee of ASEAN Academic Network on Disaster Health Management and an ISAT coordinator for the network toward unity for health. It is my utmost delight to welcome our moderator of the first session, Mr. Datu Respatika. Please welcome.
Good morning, ladies and gentlemen. Hopefully, the coffee break will make us all refresh a little bit. And today, we will start this session 1 about disaster and public health. This session is actually have an objective to identify the potential activities on public health which should be tackled in disaster health management through sharing cases from each ASEAN member state that probably appropriate for actual practices of the public health conducted during the disaster responses and also applicable for the knowledge or experiences of disaster health management to the public health emergency. We will have 9 distinguished speakers in this session. And I would like to ask all the speakers, we have 15 minutes for each topic, and we will have a presentation around 11 minutes and 3 minutes for discussion after each topic, and 1 minute to change from one to another speakers. So I will ring the bell. It means you have 1 more minute left to finish your presentation, and then we are follow with discussion. Okay, without further ado, I would like to invite our first speakers from Malaysia. Please welcome Ms. Suhaida binti Muhammad Sidek.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning to all delegates, ladies and gentlemen. First of all, I would like to thank the organizing committee for the second Asian Academic Conference and Ministry of Health Malaysia for giving me this opportunity to share my experience in managing landslide disaster in my district. Therefore, I'll be presenting on a novel model for management of well-being and health of search and rescue, which is SARS team in public health response to emergency and natural disaster during COVID-19 pandemic 2022, the Batang Kali landslide pilot. Okay, Hulu Selangor is the biggest district in Selangor, Malaysia. It's famous for its picturesque landscape and thriving ecotourism. If you ever been to Genting Highland, this is an alternative way to Genting Highland, which is now closed. Okay. In the wee hours of 16 December 2022, at about 2 a.m. in the morning, the landslide happened, which displaced 16 million cubic feet of soil occurred in glamping site in Batang Kali. As you can see in the slides, this is the glamping site before the incidents. Therefore, the rescue operation may expose the search and rescue team to have risk and inflict traumatic experience upon them. Therefore, our concern is to address the psychological and physical health risks to the pandemic. Okay, this is our usual response towards any disaster in Malaysia. In the ministry level, in the national level, we have Ministry of Health. In the state level, we have Selangor State Health Office, and for my district, we have Hulu Selangor District Health Office. And for the emergency response team, it consists of MERT, Medical Emergency Response Team, RAT, Rapid Assessment Team, RRT is a Rapid Response Teams, and also we have additional team of Mental Health and Psychosocial Support Teams. And also for the administrative, we also have team for logistic, human resource, and finance. We do the planning and also the administrative management. For the MERT, actually, the team is coming from the nearby hospitals, and for the RAT is coming from our district health office, and for RRT is coming from our clinics, okay? And also the HPSS team is actually our trained psychological first aid professionals, including our medical professionals, our psychologists, and also our paramedics. They provide the psychological first aid intervention to the victims. Okay, actually in the incidents, there is a temporary relief center set up at the nearby police stations. And the MHPSS team will provide the intervention towards 15 adults and also 7 children on the first day of the incidents. Because the relief center is it's not a relief center, we call that a relief area. It's only open about
Recording
a day.
in progress.
Okay, how we get there? As you can see, limited chance of finding the survivors, shift the disaster impact to the SARS team, working non-stop in the 10 days. It's actually happened when the disaster prolonged, the rescue operation prolonged from 3 days to 10 days. Okay, as you can see in the picture, this is the ground zero. Okay. There were also reported cases of malaria, leptospirosis, and risk of melioidosis in the area, posing the health risk to the SARS team. Amid the ongoing pandemic, this is also crucial to take the precaution and preventive measure. Okay, what's new? Okay, there is a new role of our RRT on the SINS command post, which we expand our public health activities on the OSCP by establishing health base at the OSCP. Okay, this is, I will explain to you all our public health activities. Okay, this is the public health activities on the side of the incidents, which are mainly in the green zone. Okay, to manage the infection risk of food and waterborne disease, our team monitored the donated food and beverages. There is a lot of donated food. Okay, and we also conducted a regular checks on appointed food operators and also premises. We advise them on food preparation and food consumption, means they have to consume the food within 4 hours. This is to prevent the incidence of food poisoning at the incidence area. Okay, the other one, our team is also monitoring the cleanliness, sanitization of the area. So our team ensure that a sufficient and regular supply of clean water is delivered. The toilet is actually a mobile toilet, as you can see there. I think after the pandemic in Malaysia, this is a usual setting for any maybe future disaster also. This is actually set up by our local authority and managed by our local authority. And sewage disposal also managed by our locality. Therefore, our team will go there and do the assessment and also monitoring and give the feedback to the respective agency. Okay, this is another additional health services at the OSCP where we develop pre and post-deployment screenings. Actually, we conduct for the SARS member addressing the health concern like hypertension, hypoglycemia, heat exhaustion, and also their mental health status after an adverse and long rescue operation. Those with temperature and COVID symptoms also tested on the site. It's actually when they have any mental health issue, they will refer to us for intervention. This is actually our MHPSS team, our mental health and social support team activities. As you can see there, they handed the first aid to the psychological first aid to all the head of agencies, because I think this is a new service that we provide at the incidence area, so we need to approach all the head of agencies. We also give the awareness about importance of mental health, especially among the SARS team, and also we do the intervention for the survivors, family members, and also a SARS team. Okay, for prevention of infectious disease, our team distribute also insect repellent, because as I mentioned earlier, this area is a malaria or malaria knowledge prone area. We have the case for the past few years prior to the incidents, and also this is a leptospirosis prone area. And as you can see in the first slide, there is also a risk of melioidosis in addition to the COVID-19. So we advise them also, if they have any symptoms, they could come to early to our nearby clinics to get the treatment, even up to 1 month after completing the operation. Okay, we also developed a new assessment tool and report that adopt the approach as the flood preparedness guideline MOH Malaysia 2008, but prioritizing the well-being of the SARS member. This is the guideline, and also this is the assessment tool, and this is the report. Okay, as we know, during managing any disaster, we will face a lot of challenges, but I only listed the 3 big challenges that we face during the disaster, which is, I think, the common one will be the inter-agency communication. As I'm being there for just 6 months, actually, I'm new in this district as a district health officer. So it's not easy for me to get I have a challenge in the first place to get their commitment and their collaboration, especially for public health activities, because everybody in a tension and stress condition. Their objective and their target is to rescue. But however, when the operation prolongs, so we need to have a good communications with them. And another issue, I think the most important is internet access, especially on the first day, because we need to communicate and share our data and information to our operation room and also the CPRC. However, it was dissolved after the Malaysian Communication and Multimedia Commission provided a coverage on whale. And it also is a new things for me. And for logistic issue, to resolve the logistic issue, we have established our health base at the OSCP. Okay. And finally, for the conclusion, I think the disaster response must follow the disaster paradigm to minimize the impact of the disaster itself, and also to ensure the function of the health-based and effective rescue operation. The focus should be on improving the mitigation and interagency coordination. The approach of managing well-being and health of SARS team can be applied in future incidents, especially during pandemic. With that, I end my presentation with thank you, and this is all my team members.
Okay, thank you, excellent. Please stay at the podium.
Alright.
Okay, now I would like to invite all the participants inside this building. Do you want something to ask to Ms. Suhaida about the novel management of well-being and health of SARC team during the emergency responses? Is there any question from the floor? Okay, if not, I would like to ask you about, so first, I saw that there is a pre and post deployment screening that conducted to the SAR members during their responses. Yeah? Is this screening also going on regularly throughout the year? So, I mean, if you have emergencies or disaster, then the one that really healthy and ready will be sent, something like that?
Yeah. Actually, this is our first experience doing this public health intervention towards the SARS team. It's actually, they are very fit, but after long hours and long days of working, some of them actually we found to be like, it's not not fit, but they quite tired lah, being tired, and also the mental health issue, I think, is not a very significant lah. Maybe they a bit stressed because pressured by the higher level of management to finish the operation earlier.
Okay, so thank you for that. Is there any question from the floor? Okay, if not, I would like to ask one more question. Actually, this is pretty interesting for me because, yeah, of course, if we want to help somebody, then we need to make sure that we are ready to help and healthy. I mean, so is there any specific treatment for the SAR team from the government, for example? They provide something, for example, how to say, food and beverages, specific food and beverages, so therefore they did not need to worry about, this food is good, and something like that. Okay,
thank you. I think the food and beverages is a must that provided by our local authority. It's actually managed by our district office under the disaster management committee, district disaster management committee. However, during the disaster, because this disaster has what we call that, the concern from everybody. So they have a lot of food donation. They donate the food there. So food, I think, is not a problem. And for the others, even if you can know, they actually have like an area for relaxations. They got a massage area. That's towards the end of the operation lah, because I think they are physically also exhausted. So the government and the state government actually provide the service for them.
Okay, thank you very much, Ms. Sohaida. It's very interesting talk about the management of the well-being and health of the SAR team from Malaysia. And I would like to invite our next speakers from the Philippines, Mr. Alfonso Dana. And he would like to talk about the response of the Philippine Emergency Medical Assistance Team to the natural disaster in the midst of COVID-19 pandemic. Please, the floor is yours.
Thank you, Mr. Datu. Good morning. I would like to thank the organizing committee of the Second ASEAN Academic Conference on Disaster Health Management for giving me this opportunity to represent the Philippines in discussing to you the EMT deployment in response to natural disasters during the COVID-19 pandemic. I'm Dr. Alfonso Danak from the Jose Bilingad Memorial General Hospital. I have no disclosures. My task this morning is to introduce to you the Philippine Emergency Medical Assistance Team and its operations, to describe the deployment process being done by the PMAT, and become aware of the local and international deployments of the PMAT, including its best practices and challenges during the COVID-19 pandemic, enumerate the infection prevention and control protocols of the PMAT for healthcare workers and patients. The PMAT, in the Philippines being #1 in the World Risk Index, developed the capacity for national first responders following the global standards. What we have organized is a team composed of doctors, nurses, and allied health workers social workers, drivers, cook, electrician, logisticians, data manager, and administrative staff that provide medical and public health services in times of disasters and public health emergencies within the country and for deployment internationally if the need arises. Daytime outpatient services for initial care of injuries and other healthcare needs and referrals from a fixed location with at least 100 patients a day can be seen. You also provide a 24/7 on-call team available to provide life-saving emergency care. It follows the principles of the PMAD standards. Next slide, please. Principles of self-sufficiency, team welfare, conducting daily meetings, logistical support, having a complete staff complement from administrative to logistical personnel and clinical personnel, and members undergoing EMT basic induction course with drills and exercises. The deployment process starts with an activation where physical and mental health screening is done, a team briefing and orientation, preparation for logistics, then mobilization, followed by reporting to the EMTCC or the LGU or its equivalent, and then having the SCAMP set up in operations. Then after the 14-day operation, we do the demobilization and turnover, and then do the team debriefing. As part of the COVID-19 protocol, we started doing RT-PCR testing for all our healthcare workers before and after deployment, and those who turn positive will require to undergo the isolation. We started our local deployment even before the start of the pandemic. While we have been deployed for other disasters in the past, the first time that we were deployed as a PMAT is for planned events like the 30th SEA Games held in the Philippines and other public health emergencies. Our first deployment as a PMAT was for a volcanic eruption in a province south of Metro Manila due to the Taal volcano eruption. It was a 16-day deployment, which requires a 14-day operation, and travel was through land. We had two teams coming from two hospitals who were assigned to two different areas, and we saw 2,842 patients. But we were fortunate to use existing structures such as the gym and evacuation site, and our personnel were augmented by those coming from the hospital. We were able to provide areas like breastfeeding, child-friendly space, shower tents, and it was the first time we implemented a quality assurance visit with the help of WHO representatives. The major challenge was, of course, the transportation with the damaged roads, severe asphalt, and smog that were hindering our transportation. And unfortunately, 3 days after our demobilization, we had to again mobilize this team to establish the first quarantine facility of the country because of the start of the SARS-CoV-2, which will later on become the COVID-19. Our second deployment was in Siargao Island and Dinagat Island, Surigao del Norte, after Super Typhoon Rai, also locally known as Typhoon Odette. This was the second costless typhoon in the Philippines after Typhoon Haiyan. We were deployed for 17 days for a 15-day operation, and transportation was through air, but because of the damaged airport, it was done through a Cebu Pacific Cargo Mercy flight, a commercial airplane. We had 44 members of the team coming from 3 hospitals, and one team was deployed in Siargao Island, the other to Dinagat Island, with a mobile mental health psychosocial support team. We saw 1,216 patients, and we were able to, unfortunately, when we landed in Siargao Island, all our logistics were gone because the cargo plane failed to load it. And we had to utilize the damaged health facility. And because of the availability of biomedical technicians in our team, we were able to recondition damaged equipments from the typhoon. And we were able to set up a field hospital in the newly constructed damaged health facility. With close coordination with the local government, we were able to support our logistics. And this was the first time that we started to use the EMT MDS as part of our usual operations in recording the patients. The major challenge is, of course, the damaged airport, the delayed cargo, the scarcity of food and water, and the difficulty in exiting the island due to the continuous rains. This was the height of the Omicron variant, and 27 out of the 44 personnel tested positive and required isolation post-mobilization. Then we were deployed for a magnitude 7.70 earthquake in Bangued, Abra, a province north of Manila, for 14 days, But fortunately, we had only 11 days of operation. Travel was by land. This was the first time we had a composite team composed of 57 people, which allowed us to have a complete setup of our camp. And this was also, we continued to utilize the EMT MDS as a standard operation procedures. And we pilot tested our PMAT information system as an IT support for our operations. The major challenge was the long travel time and the frequent aftershocks that was experienced with the team. Fortunately, all the team members tested negative before and after deployment. This gave way, all our local deployment paved way for our international deployment when we were deployed in Yemen, Turkey for the magnitude 7.8 earthquake in February to March 2023 for 21 days for a 14-day operation. We were transported by air through Turkish Airlines, but we were required to reduce our cargo from 16 tons to 10 tons. We had 30 personnel, and we were able to see 1,022 patients. This local deployment allowed us to be able to handle the online EMTC meetings, the numerous quality assurance visits, and being recognized despite not being verified internationally allowed us to be present, show our capability. We conducted regular daily briefings and debriefings, team welfare activities, and adjustment in concept up due to logistical limitations, with close coordination with the community and the local authorities. The major challenge was, of course, extreme cold weather, language barrier, closed stores, scarcity of water and firewood, and reduced logistics due to the courier limitations and long travel due to the distance. Fortunately, again, we tested, all team members tested negative before and after the deployment. All team members, because of COVID-19, had to follow the infection prevention control protocols in deployment. Team members undergo RT-PCR testing before and after deployment. The wearing of face masks, frequent hand washing, the use of alcohol-based hand rub during operations was encouraged, and the team members should report immediately when they are symptomatic. For patients, we had a provision for isolation tents, screening for COVID-related signs and symptoms, the provision of masks for patients, the use of alcohol-based hand rubs and hand washing area, rapid antigen testing for symptomatic patients, and referring patients to our facility if they have COVID-19 symptoms. In summary, the PMAT follows the core principles and standards of the WHO EMT initiative. Deployment process in the year of COVID-19 pandemic remains the same. The provision of services during disasters and public health emergencies must continue amidst the challenge of a pandemic. Healthcare welfare and patient safety is enhanced with regular screening for COVID-19 before and after deployment. Partnership and linkages play a vital role in the success of the deployment. Camp operations will require provision of isolation tents and referral mechanisms for transfer. The experiences in local deployment prepared the PMAT for international deployment. And lastly, the PMAT's experience in international deployment provided an opportunity for the team to further enhance its capabilities and prepare for WHO certification. With that, we thank you very much, and a pleasant good morning to everyone.
Thank you very much, Mr. Alfonso. Please remain in the podium. I would like to invite all the participants from the floor. Do you have any question? Okay, please, Mr. Ikeda. Okay, from the technical team, can you please help Mr. Suizi Ikeda to turn on the microphone, please?
Dr. Danak, and I have the one question, the clarification for your case. During the deployment of the IMT or EMT locally, if some kind of the positive case happen, especially for your staff, your member of the EMT, how you deal about that? Those members shall be isolated. He cannot join for the works.
You mean the team members who get symptomatic? Yes. We had one instance in the Siargao deployment where one member of the team became febrile, and we had to isolate them, keep him in a separate room until he becomes asymptomatic. Fortunately, we were able to do we had a rapid antigen test kit with us, and the healthcare worker tested negative. So after the symptoms, we allowed him to join the team again. But during that time that he was febrile, we had to separate him and only assign one healthcare worker to attend to him. And that healthcare worker was also tested for rapid antigen tests.
Okay, thank you. Do we still have any question from the floor? If not, I would like to, oh yeah, please. Go to the nearest microphone. Please introduce yourself and ask your question. Okay, I need help from technical team to turn on all the microphone, microphone, please.
Okay, thank you, Dr. Danak. Interesting presentation. I'm Arthur from Indonesia. I have two questions for you. So the first question is, did you have your members to be vaccinated before they were deployed to the place? The second question is, for how long will you intend to check for the RT-PCR? I see your presentation that you already still doing it until March 2023. And how about next? Will you still intend to perform the RT-PCR for your team members? Thank you.
Okay, so the first question is, thank you very much for that. The first question is, how long do we intend to quarantine our healthcare worker after deployment?
No, I mean, did you vaccinate, do your team members have vaccination before
Yes.
they were deployed to the location?
All team members are required to undergo the COVID-19 vaccination, both for the primary dose and the booster shots, at least 2 booster shots before the deployment, and whatever is required by the government. Now, for the second question, it's about RT-PCR testing for the team. The public health emergency was only lifted in July 2023 in the Philippines. And that was the only time that we did not do any more the RT-PCR testing. But before that, all team members are required to do RT-PCR testing before and after each deployment. But for now, what we implement is that we do RT-PCR testing only for the symptomatic individuals.
Thank you for the answer. Thank you.
Okay, thank you very much, Mr. Alfonso. And please go back to your seat. And I'd like to continue to, I'd like to continue to our next speaker from Vietnam, Mr. Nguyen Tien Dung. He would like to talk about the Health Needs Assessment, or HNA, after the tropical storm in Linh Pha in the central province of Vietnam. Please, the floor is yours.
Good morning, everyone. I'm Dr. Nguyễn Tiến Dũng. I work at the Un Healing Center, Vietnam National Burn Hospital. And I am on behalf of the Vietnam teams will present the topic health needs assessments after the tropical storm Linh Pha in the central province of Vietnam in October 2020, using the ARC project health needs assessment toolkit. Instructions in Vietnam's natural disaster, mostly floods and landslides triggered by storm. Natural disaster killed 132 people and injuries 207 as in Vietnam in 2019. Tropical storm Linh Pha was the 6th storm to form in the East Ocean and made landfall over Central Province in Vietnam on the 11th October 2020. On the screen, you can see the satellite maps image of the tropical storm Linh Pha. Only in just 5 days from the 11th to the 14th October, storm Linfa caused heavy damage to five central provinces: Hà Tĩnh, Quảng Bình, Thừa Thiên Huế, Đà Nẵng, and Quảng Nam province. The first ones of the many action, EMT action, this is a health needs assessment. Health needs assessment is necessary in the responding to the natural disasters. The arts project that Vietnam country is involving have developed one toolkit for the health needs assessment. Aim of this report was evaluate the abilities to apply and effectiveness of this when Vietnam is experiencing a serious floods and storm Linfa in the central regions of country during COVID-19 pandemic affecting national in October 2020. The materials and methodologies. Materials, toolkits for health needs assessment of art projects was revised and translated to Vietnam. Methods, the studying designs, prospective, descriptive, cross-sectional study was conducted by the working groups of 9 people. Studying location. 5 central provinces in Vietnam: Hà Tĩnh, Quảng Bình, Thừa Thiên Huế, Đà Nẵng, and Quảng Nam province that suffered the most damage after the tropical storm Linfa. The research process. Immediately after storms Linfa, 24 hours, Vietnam Minister of Health established a working group of 9 people to assess medical needs in 5 central provinces. Before coming to censor, working groups was changed on how to use and structure of the toolkit art project. The working groups divided into 2 teams. We apply the art project health needs assessment toolkit for perform this survey. Data collection methods. We collect data from the 3 sources. The first one is collecting secondary data through the official media updates daily. The second one is the in-depth interview. We interview authorities, medical staff, and local people. The third one, this is direct observation at the health facilities. The data collected follows the structures of the art project toolkit. The first one is we observe general situation on site, pause number and main cause of death, number of injuries or 6 persons, number of persons with chronic disease, risk and epidemic outbreak. And the second one is the community health. We observe information related to the water source, medical sanitation, food and nutrition safety. Oh no. The next one, we observe the health facility and service. The impacts on health facility and their operation, infrastructure. The last one is a situation of field stand. All the results of survey will be recorded and codes analyzed by using Microsoft Excel and Stata 12 software. The results, general situation on site, a total of 109,034 houses have been flooded in the 206 communes in 5 central provinces. 382 homes have been completely destroyed. Flooding have also forced 26,359 people have evacuated their homes. This is a map. The central province have influenced of the Linfa storm. The storm Linfa left 148 deaths and missing. We share the two costs, direct deaths and indirect deaths. Direct deaths includes drowning in storm surge, fresh weather, flood, and rains or storms driven away. Indirect death, with the cost of direct death, we offset 37%, and indirect death, we offset the head attacks 12%, vehicle accidents 22%, and phone from Europe up not the 14%, and missing people have 20 persons. And total is 148 people. And 384 persons have injuries and hospitalization. The cost of injury and hospitalization, the highest number that is fracture, 21 persons, and acute disease, 17.97%. That is acute diarrhea, dermatitis, eye conjunctive appendix. The chronic disease, for example, pneumonia, COPD, cardiovascular disease, diabetes with 15%, and other 2.6%. The community health, we observe weather shocks, medical sanitation, food and nutrition safety. The most rural coastal area completely lost clean weather shocks due to floods and food supply, notably poor hygiene. Increase of reports of some infection disease. For example, the eye infection, skin and soft tissue disease, and risk of disease outbreaks such as dengue, fever, hand, foot, mouth disease. 13 cases recorded in Hue and some nearby province melioidosis. And health facility and service. 77% district hospitals and 75% community health station had damage at various levels from flood to damage to the construction. 35% of district health hospital was flooded and had to move a patient to other facility. Most of the equipment and record of the commune health station was damaged and difficult to restore. 26% of health workers had to receive medical support while on duty. 19.5% of district hospital and community health station stopped operation. On the pictures, you can see here, the first picture, it is the community health station with the flood and the ambulance into the water. The situation of few stands, most local people in flux area was evacuated to state facility. Just as no statistic on the number of facility receive evacuees. Conclusions. The last. Typhoon Linfa in October 2020 caused heavy damage to 5 central province of Vietnam. Health needs assessment toolkits was really helpful because at the present toolkits like this disaster health management is not available in Vietnam. Additional, this toolkit is comprehensive, able to collect to inform of health activities and as well as impacts of environments in the affecting areas that we have never done before. Thank you for attention. Thank you so much.
Okay, thank you very much, Mr. Nguyen Tin Dung. I would like you to stand still in the podium, and we would like to, okay, please. I'm sorry, I want help from technical team, please, to turn
okay.
on. Okay.
Thank you very much. My name is Shinichi Egawa from Tohoku University in Japan, and I'm a professor at university and a researcher on the health needs in disaster. So my question for you is, when do you, when you count the indirect death from the disaster, from when to until when do you count the number of people as an indirect death of the disaster? For a heart attack, did they die on the day of the landfall, or a week later, or a month later?
Before the come to sense, the working groups of nice people, we was trained to on how to use the apparatus and the insurance, the conditioner of the lines of the sand. We connect the local health department for the help when we working at the sand. Yes, many actions before we come to the sand. Connect. We only one day, so 24 hours after the storm, we formed the working groups for the health assessment, need assessment.
Okay, you mean the days, one day after the storm left?
Yes.
So you count the number of deaths within that 48 hours.
Yes.
Thank you very much.
Yes.
Okay, thank you very much for Mr. Nguyen Tin Dung. I would like to ask all I'm sorry, I think we have finished, we cannot have another time, maybe another question for another. Okay, please give a round of applause for Mr. Nguyen Tin Dung. And we would like to proceed to our next topics. It will be the case study of EMT contribution to the COVID-19, and our colleague from Brunei Darussalam, Ms. Nosralina Rahman, will present about the emergency medical team contribution in the COVID-19 response, a Brunei experience. Please, the floor is yours.
Thank you very much. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi and a very good morning to all respected delegates. And thank you very much to AAC for kindly inviting me as a representative for Brunei to describe and share our experience in particularly on EMT contributions to the COVID-19. So I myself is an emergency physician, and I'm chief clinician for the pre-hospital service for the emergency medical ambulance service. And I was also the medical commander that helped establish the isolation facilities But other than that, I don't have any relevant financial or material support to disclose. Okay, so I'll just describe the Brunei context just to have us to set the scene for my subsequent slides. So Brunei is this tiny dot just on the north part of Borneo island, and we are surrounded on the south by two big states of Malaysia, and on the north we have the South China Sea. Our land mass is very similar to Bali, but our population is much smaller. We are about 400,000, which is under 500,000 population. And we are in a part of an area where we are quite fortunate to be protected from natural disasters. So we don't have any experience in managing big disasters. We have seen flooding, but not to a large scale to call it a disaster. So we are very fortunate to have that. Our emergency medical service are quite well established, but we have a small fleet. We have only 38 ambulances that are spread throughout the nation and 122 paramedics. Our hospital system, our health system are organized as primary, which we have governmental and private healthcare services, healthcare clinics and centers that are spread throughout the country. And we have 3 district hospitals that cover each of the different districts. And we only have 1 tertiary hospital, which is located at the capital city in Bandar Seri Begawan, the northern part, which is the light yellow area. So this functions as our tertiary, one and only tertiary referral center, which has all the specialties. We also have our National Isolation Center, which is actually a restructured district hospital, which is located in Tutong district, the yellow district. And additionally, during COVID, we established 7 community isolation facilities. So during COVID, the referral structure is from primary to secondary hospital to either the tertiary hospital or isolation hospital or community isolation facilities. So just to give an overview of the COVID-19 pandemic in Brunei as a whole, so we started to have our first case of imported COVID-19 in March 2020. And following that, we had a long period of time where everything was basically as normal when the rest of the world was already impacted by COVID-19. So we didn't have community transmission for a good period of time, and apart from the sporadic imported cases. So only in August 2021 that we had our second wave of COVID-19, and this impacted us very heavily. So, because at this time, the population that was vaccinated was only less than 50%. So there were strict restriction measures that was taken to help contain the spread of COVID-19. All positive patients had to be admitted to hospitals. So very quickly, the EMS and the hospitals was overwhelmed. So this is the period of time when we had to establish COVID community isolation facilities. The third wave affected us soon after, in February 2022. Fortunately, during this time, most of our population has been vaccinated, but with close to 5,000 population affected per day, this also has impacted our healthcare service very significantly. So, but we were lucky that most of the patients that were positive at the time was presenting with minor symptoms only. So as you can see, throughout the episodes of the pandemic that we experienced, although there were different, the pattern was different throughout the different waves, but the impact on the healthcare system was still quite significant. So the EMS response during COVID, our ambulance service, which, as described, is manned by our paramedics, they still, during this time, had to see the usual emergency cases, the usual emergency 911 calls, and attending to all those MIs, strokes, and accidents. But additionally, now they are seeing this different cohort of COVID patients who are sick and requires transportation from the community to hospitals or from hospitals to isolation hospital or facilities. And they also work under very difficult conditions, wearing full PPE, especially at the start, in hot Brunei climate. And they are also burdened with a large number of staff sickness and burnout. So their system was overwhelmed very, very quickly. The bottom right picture is depicting our call center, which was extended to an administrative area just to help take up the burden of the calls, which was increasing in volume very, very quickly. So with the increasing demand, the increasing calls, this puts a lot of burden and become part of our challenge in the workforce shortages. So the first picture is depicting Kampung Air, which is our water village. It's in our capital city. It's one of the historical villages. It still houses 8,000 it has a population of about 8,000 population. It's very difficult to access, and it's very weather and tide dependent, and you need boats to get there. The other two, some of the pictures from remote and rural areas, which is difficult to access because of the geography and some of the poorly constructed land and road infrastructures, and some of them can be flood prone as well. So although this can be our day-to-day challenges, but during COVID, it adds to that challenges even more. So this is some of our training package that the paramedic training team did, mostly as a just-in-time training during the start of the COVID. So we had to do this, cover all the paramedics throughout the nation to ensure that they are safe and to ensure that they are capable to respond to all the COVID cases. But later on, their role as a training team also shifted to training the other healthcare workers that, particularly from the non-acute setting, that are redeployed to cover isolation facilities and help out with other COVID activities. So this describes some of the shift of the burden of the paramedics and the emergency medical service. So we had a lot of support from many, many agencies, including the military, the non-governmental organizations, and some volunteers, and also university staff and students as well. So they help to take up some of the tasks, the non-clinical staff particularly, looking at the logistics, resource mobilization, etc., so that the paramedics can then focus on the more emergency and acute patient care. The call centers, we also utilize a lot of different agencies. One of our major contributors for this is our Royal Brunei ground team, using their call centers, and they help in taking up a lot of the calls for COVID patients, and with standardized templates of questions, they help call patients and help screen those that can be safely kept at home versus identify those patients that need to come in to isolation hospitals. And later on, as many more patients are kept at home for home quarantine, we also develop an additional patient monitoring call team that also uses a standardized template to call patient at home and check if they're okay and identify those who needs escalation of care. COVID isolation facilities was established during the second wave to take up some of the burden from the hospitals and the COVID isolation hospital. So there were 7 that was established throughout the period, and the one in the picture is the one that I was involved in. So I was part of the team that helped establish some of the government facilities that was very quickly converted into isolation facilities. So this center was a boarding school, a boarding religious school that that eventually became a 1,000+ bedded facility that was initially opened in less than 72 hours. So one of the lessons that we learned from disaster health management is to incorporate the principle of command and communication very early. We have multi-agencies involvement in this, utilizing military to help command the center, whilst myself, as the medical commander, we look after the clinical aspect of patients. Planning operational workflow, also we use the principle of, although we've never operationalized our activities as emergency medical teams, but we use the same principle to help plan our operational workflow and establish the facilities. We take into consideration the infection control procedures, safety and security, how we plan our screening, triage and isolation, and also our clinical management. Just some additional roles that was taken up by the EMS is supporting the vaccination drives and also involved in patient screening for those high-risk clusters. So some of the important lessons I feel that we learned from the COVID-19 was we have to be prepared. So with disaster preparedness, if we understand the concepts and we train our people, we are able then to adapt to the changing situations. Good leadership from the executive level to the ground level helps to clarify those decision-making. And we were very fortunate to have multi-agency stakeholders that are very committed to help us. And I think that was our, one of our positive and our highlight of the COVID-19. Establishing clear communication chain, especially when you're working with different agencies, is, is very vital to help with more effective management. So that's it from me. Thank you very much. I'll happy to take any questions.
Okay, thank you very much, Ms. Noraslina. I would like to invite, please, question from the floor.
Thank you for the opportunity, and I would like to thank you as well for the very informative presentation. I'm Rosa, I came from Aceh, Indonesia, and since I've observed that, from the previous presenters as well, and there are problems in communication, and collaboration, not only in Brunei case, but other cases as well. And I'm wondering if Brunei has been established inter-profession education in healthcare professions, because this is one of the ideas that we are working on in Aceh. Thank you very much.
Okay. Thank you very much for the question. Do you mean specifically, if I can understand your question correctly, do you mean specifically in COVID or training for multidisciplinary teams in different contexts as well? In different contexts. Okay, so for the government facilities anyway, so we have training programs for doctors, nurses, allied health professionals. That's at different various levels of education in the country, within the country. So the University of Brunei Darussalam conducts different courses for different professions, but some of our healthcare workforce is also trained overseas as well, particularly doctors. But we do have some training programs established for all allied health professions as well. Hope that answers your question.
Okay. Okay, thank you very much, Ms. Noraslina. I think this is it for your session. And please, a round of applause for Ms. Noraslina from Brunei Darussalam. Okay, moving on to the next presentation, I would like to invite our colleague from Vietnam, Mr. Nguyen Duc Chin. He will also talk about the case study of EMT's contribution to the COVID-19. And his talk is about the EMT contribution to COVID-19 response and practical application of knowledge on DHM to the COVID-19 response in Vietnam. Please, the floor is yours.
Thank you so much. So, good morning, everyone, ladies and gentlemen, colleagues. I'm very happy to be here right, on behalf of the Vietnam side to give presentation on the EMT contribution to COVID-19 control in our country. So thank you very much for that presentation from Brunei. You learn a lot from you as well. And thank you very much from the committee and organizing and also from Arch Project to give me opportunity to be here join this project from beginning as well. And of course, I think your own country, you had very good experience. So from my side today that I give you some figure about the COVID-19 happen in our country, also the experience, how you can control by this one. But very small one compared to the Brunei report that only one report focus on Hanoi City, that the capital I come from. Okay, so you know that between two years that from beginning 2020 and also to 2022, of course at that time you control, but more serious that happened COVID-19 in our country, that the same in worldwide, that in 2021. Total COVID-19 happened, so you can imagine that right now Vietnam more than 100 million people. By the end of 2022, that 30,000 people died due to COVID-19. Of course, that not official statistics as well. And because many people die from rural area or maybe remote area, something that you cannot control and get statistics, something like this. And transportation, also primary care, that are very important for fighting COVID-19. Let's talk about the pre-hospital emergency care in Vietnam. So right now operated by 115. So we die that a number, of course, like ambulance they come over. That from one emergency area, like from EMT, that important. And you do both that from transportation, also provide some primary care as well. So during COVID-19 pandemic, affect in our country, national. The 115 center Hanoi, you can certainly it 115 HN, that has contributed much in controlling situation and saving the patient life in Hanoi, one of most crowded city in Hanoi, compared very big city in our country, Hanoi and Ho Chi Minh City as well. So it is objective for this presentation is to share experience through the operation of 115 HN during the most serious affected period by pandemic national in 2021 and also to first, the normal activity upload to situation. And second, in response to COVID-19 pandemic management as well. And first, give you some figure. You can imagine about the 115 in Hanoi as well. Here, Hanoi 115 is located in the downtown, that is in the city. And pay attention, a lot of forms of people that from director of 115, also director of Hanoi Health Department, always they come to check over about the activity as well. And of course, they check over from ambulance, car, equipment, material, something like that, to assure that for activity from the 115 that can respond for both normal activity to the patient need, and also for the control of COVID-19 situation. And the data you connect from the 115 HN record on routine professional activity and handling of the patient with COVID-19 during COVID-19 pandemic. And also we interview some people in charge of this, like from the director of 115, also some people that time they check patient as well. And research from 115 that focus on only to one center in our country. In the time that from January 2021 to December 2021. And here you had some result from the REACH report that the total where you had until this time that are 14 teams that are for 10 million people in Hanoi City, as I mentioned earlier, problem is very crowded with the people. So it is to get to speed that COVID-19 transmission as well. And also to remember well vaccinated and well trained on how to manage a COVID-19 patient accordingly. And at that time, we had about nearly 40,000 that ambulance deployed to manage nearly 40,000 patients. That patient did in the outside the hospital. You call that pre-hospital care, and account about more than 93,000 outpatient. But also you can do some kind of the pre-hospital care, like also CPR we perform successfully to save lives about 37 people. And additional, more than 1,000 ambulance chiefs were deployed by the medical facility in area in Hanoi and outside Hanoi as well. Here you can see that on the map that important this time because only Hanoi 105 cannot respond for that situation. So you get very good cooperation with some that medical facility in our area, and also you get the network from this one to respond. And this time it's very happy because you get very good response and cooperation from our college and also from our facility. And the hospital I work also respond to Hanoi 105 at that time. And here you can see some data picture that from Brunei for the transportation. It's very important that we send observation to the hospital. And also we send observation get home something that also people that, like a health worker, they should wear, PPE, and also they would travel on how to control and also prevent that COVID-19 transmission. And here also very important things that you are talking about EMT response for COVID-19 pandemic and control as well, and management at COVID-19 patients that dispatch more than 1,000 ambulance chiefs from 84 that medical facility, and also emergency treatment and transportation patient equivalent to 4.6% of total number of patients transported by Hanoi 105. And very important that the communication at that time you get more equipment, strengthening and increase that transmission line from 4 to 24. And management of COVID-19 patient also that problem in Hanoi we have because Hanoi it's very crowded, also very narrow route, something that so ambulance should come over difficult also to get in that of the patient or how to nearby. And of course you can see that from first PPA that are uniforms for staff working in this area. Also, we had a ship worker turnover that problem that we are talking later on. And fortunately, you are so happy because by the end of this activity controlled by COVID-19, no staff workers that died due to COVID-19 that time. And we actually, for this activity from Hanoi 105, we had some opportunity, also from challenge. But opportunity, very good experience with the staff. Exactly, that happened in Hanoi. Also the same problem in 2003 until right now we have some, lesson learned from this. And very strong support from Hanoi. People, committee, and health department developed some procedure for caring and the COVID-19 patient based on who WHO highlight and for Ministry of Health and good cooperation and collaboration among the medical facility in Hanoi. And about learning, and I remember last time you had a lot lighting, it's from the meeting, and you learn from each other among the ASEAN country. Oh God, we had a lot, challenges that we are facing. I think all the country, you had the same problem. First one is lacking of experience on the responding the pandemic COVID-19 worldwide. And lacking material vaccination equipment. At that time, it's a big problem in Hanoi as well, vaccination. You had to add many countries, not in Vietnam, because the vaccine that they import from another country, that big problem for on earth. And procedure guideline change very quickly. Only, it's a PPE wearing something that change very quickly from day to day. That make us very confused. Because in my case also, I had to use that, to care the COVID-19 patient. And no sign for the contamination of staff. That big problem also from Hanoi 115 center. Because the small one, we had no sign for this. And I go now to the conclusion that also forms a very challenge that, 115 Hanoi good, very good job in concluding for COVID-19 pandemic as well. And first, we had some lesson learned from that a group prepared and developed a new procedure approached to deal with station, much the efficient operation and response as well. And also the strength that international cooperation expected that we learn from each other. So I think one project like the art project is very helpful for all of us, not only for COVID-19 control, but also for disaster health management as well. So I would like to end my presentation. Hopefully it's a good time, right? That sharing it, the one, that the police, you can imagine many, places that at time COVID-19 happened. Also in my case, because I just did some operation for COVID-19, also the same situation. So you had no time to sleep that between two operations as well. Thank you very much for your attention.
Okay. Thank you very much, Mr. Nguyen Duc Jin. I'd like to invite a question from the floor. Okay, please.
I'm Dr. Igarashi from Nippon Medical School. Thank you for showing us much data about Hanoi emergency patient. I ask you to, do you have any data or idea to the emergency patient outcome? For example, cardiac arrest, the survival rate is similar or decreasing before the COVID pandemic?
Talk about, it's a 115 that you respond for two things that, activity. First, transportation. Also, you can provide some first aid, something like this. And of course, that from outside, at that time, I think it's communication. It's a very important thing that you try to connect with, from the network. Also, you add, support from Ministry of Health, also from Health Department at that time. And from outside the patient, something that you can set up, like from the field hospital. That not the patient you send to that hospital in the city. Also, you send from the field hospital as well, something like that. So in my case, also, from my hospital, we had the mobile team that, the doctor, two doctors, one surgeon. When a nurse to do it, one nurse, and also should be one driver to drive the ambulance to come over. We get the call that help from outside as well. Thank you very much for your question.
In Japan, the survival rate is increasing after the implementation of AHA CPR guideline in 2005. But now, after the COVID pandemic, our survival rate dropped to the same level before 15 years ago. And I think this is the next challenge for us.
Yeah, that is good. I remember that 15 years ago, right? Something like that happened. So I mentioned earlier about that, from the SARS that happened in our country. At that time also, I remember that Vietnam, one first patient, they traveled from Hong Kong country. So that affected many people. At that time also, a lot of health staff, you know, in our country that died due to that happened, right? Something like that. So from that time, you learn some lesson, learn from before that you can implement for this time, something like this. Not only for PPE or procedure, something, of course, they change a lot, you know, due to COVID-19 stronger than that, you know, the 2003. But you can base on experience at that time that you learn from. Thank you very much for your question.
Okay, thank you very much, Mr. Nguyen Duki. I would like to give a round of applause for Mr. Nguyen Duki.
Thank you so much.
And now I would like to invite the next speaker, our colleague from Cambodia, Miss Lakmu Singh. She is presented case study titled the Case Study and Situation Report on PHP, for example, Community Preparedness, Emergency, Public Information Warning, Responder, and Health. Okay, the floor is yours.
Yes, thank you very much, ASEAN Academic Network Committee that invited me to have a presentation. My name is Dr. Lam Mui Sing, representative from Team Cambodia, and I work at Ministry of Health, responsible on disaster management in health. I would like to present my slide. See, this is the logo of Ministry of Health Cambodia. The first of all, I bring you to know about the Cambodia profile. Cambodia profile, southeast, the border with northeast with Thailand, and east with Vietnam, north with Lao PDO, southwest with Sikot, and land area 181,000 kilometers square, capital of Phnom Penh city, and population now 17 million, over 17 million, female 51. And tropical monsoon climate change, rainy season extends from May to October. ASEAN most disasters prone with flood. Almost every year we face with flooding and other natural and man-made destructive storm, drought, fire, traffic accident, and disease outbreak. This is the mapping in Cambodia. We have faced with flood and river flood. To say, flood at the north of country and river flood at beside the Mekong River. The background, you know, Cambodia, 2020, Cambodia faced with the flood at the north of country, was killed 58 people, and impact of 24 provinces, include 25 municipal and provincial, impact 24, and over 222 have evacuated and affected school, 943, and health facility affected 36. Yeah. This is the picture that we evacuate from the affected area to safe place. And we have with the storm, drought, and lightning. You know, lightning now can kill people between 50% to 90% a year. Lightning, with lightning. Ministry of Health management structure on disaster. We have Ministry of Health Disaster Management Committee and Provincial Health Department Committee District Health Disaster Management Committee. Under the central level, we have Preventive Medicine Department is the Secretariat of Ministry of Health on Disaster Management, and Communicable Disease Control Department of Hospital Services. And National Program and National Center for the member of central level. The mechanism of management in our country, we have this Disaster Management Committee. We have focal point, all the province and municipal and provincial on disease management, disaster management, and Disaster Secretariat for Health, National Strategy Action Plan of Disaster Risk Management for Health, Climate Change Strategy Plan for Public Health, National Action Plan to Climate Change and Public Health, Contingency Risk Management for Health, National Curriculum on Climate Change for Health. Health Emergency Team. We have not yet the IEMT team. We also have EMS team for daily health emergency incident. We have 119 for online for health emergency call, and we have rapid response team. We set up all provincial department operational district. This team composed of physician and health technician. The role of team, especially on disease outbreak, response in investigation. Yeah. The activity on preparedness and response for the response coordination with all institutes, for example, IO, NGO, or ensure safety supply, and ensure help us mobile team to take care of the affected people in the safe area, and ensure hygiene, safe drinking water supply all affected people, ensure to have stock necessary equipment and drug supply to provincial, diarrhea kit, blood kit, serum antivenom. You know, in Cambodia, we have faced with snake bite management when the flooding. For example, in 2022, we faced with snake bite, over 2,000 people affected with snake bite. So all the province concerned about snake bite, they request to Ministry of Health to have antivenom and to provide the training more to the doctor or nurse that take care at the hospital. For preparedness, also give instruction to provincial department on measures to be undertaken prevent impact of disaster health management, and all level responsibility must be ensured to have annual disaster plan training to enhance the capacity of health staff, ensure community participation in planning process, health group meeting provide emergency information, and strengthen the early warning system is very important for preparedness and response. Provide information through media and Facebook, Telegram, television, and the Committee of Health System. For responsible at the central level, we are initial assessment, given instruction to local level, and assist provincial district health center team to effective disease surveillance, supply necessary medical equipment and drug required by local affected area, disseminate information and compile data analysis. For the responsible on the provincial department and district assessment, we have to conduct with central level cooperation, provide basic medical care at affected people in severe and affected village, health education before, during, and after flooding. Yeah. Ensure safe water supply, distribution, amine and chloramine for hand hygiene and water hygiene. In the community, respond, find and evacuate victim and victim to safe flood area, for example, like this. Provide first aid, medical transportation, injury, provide shelter and sanitation, re-establish line and plan, pay for recovery plan. Coordination, all level coordination. A recovery place, we establish the line, water, sanitation, hygiene, plan, pay for recovery and reconstruction, repair, construction of health center facility, and what was impact damage. Disease surveillance, provide public health care, education, and post-disaster. Challenge, limit human resource and logistics, gender imbalance, disease, in disaster reduction, need support from politicians for develop EMT, IEMT. The conclusion, considering security essential part of human security, not standalone, focusing natural human include disaster. First essential step achieve at all hazard disaster risk management, build on existing national mechanism on framework and hazard. Thank you very much for your attention.
Thank you very much, Mrs. Lakmuseng. I would like to ask a question for the floor. Is there any question from the floor? Okay, please.
I am Rick Andri, emergency physician from Serang, Banten, Indonesia. I will ask, is there a disaster rapid reaction team that can be immediately dispatched to the disaster site or join the army? Is there in the central level have a special organization that has asset to be able to move on to the site? The central have asset transportation and logistic, so he can move to the location by himself. Thank you.
The question you want to know about the logistic transportation, right?
There is any institution have logistic and transportation like big organization have both logistic and transportation like plane, helicopter, whatever. So if there's something happen, they can move logistic and anything personnel to the site.
Oh, for the provide the transportation and for example, we move to from
maybe like in Indonesia, Basarnas or etc.
I understand. If I answer wrong, you can clarify to me. For the logistic and for the logistics and something that we move to the location of the affected area, we can provide by requested from the affected area. For example, in the province, we are affected, but if they need logistic, they have request from the underground to the operational district and to the provincial department, and provincial department request to the central, and after that the central deliver from the CMS to the affected area. This is your question?
Is it answer your questions?
Yes, and
Okay.
any rapid response team for immediately move to the site?
Yes, immediately. You know, in Cambodia we have, I showed you in the presentation, we have central level, sub-level, provincial, district, and central level, center. So if the center need everything, the district transfer immediately to the affected area.
Okay. Okay.
Yes, thank you.
Thank you very much, Ms. Lauk Musing. We give a round of applause for Ms. Lauk Musing from Cambodia. Thank you very much. Now, we are moving on to our colleague from Malaysia, still in the topic. I would like to ask Mr. Abraham Chin Zevong to present his talk about the case study and public health preparedness in Malaysia, the lesson learned from the Mount Kinabalu earthquake. Okay, the floor is yours.
Thank you very much, Mr. Moderator. Very good morning to all distinguished guests of honor and everyone here today. My name is Dr. Abraham Chin Zufong from Ministry of Health Malaysia, and I'm delighted to share my topic with you today. So the authors have no conflict of interest to disclose in relation to this presentation. So a little bit about Malaysia. Malaysia has two main geographical parts. The Peninsula Malaysia, also known as West Malaysia, and also East Malaysia on the Borneo Islands. As we can see from this picture, Malaysia, you may see, is relatively shielded from major disasters such as typhoon and earthquakes. However, having said that, Malaysia, especially in the state of Sabah, we did experience earthquakes in the past, okay, with the highest magnitude of 6.6 in Lahadatu district in state of Sabah in 1923. On the 5th of June 2015 at 7:15 a.m. Malaysia time, an earthquake of magnitude 5.9 on the Richter scale occurred with the epicenter at Mount Kinabalu, Ranau, Sabah. Okay, the tremor from this earthquake can be felt at 14 districts all over Sabah state. This deadliest earthquake in Malaysia's history took the lives of 18 people from many nations, including Malaysia, Singapore, the Philippines, China, and Japan, and injured many others. There were also reported damages to healthcare facilities, and hundreds of health personnel were mobilized for management of this event. Okay. Under our national disaster management mechanism, the roles of Ministry of Health Malaysia are to provide emergency treatment, forensic services, as well as public health services. Now, this event has taught us many things. We had challenging interagency collaboration, poor coverage of communication devices, lack of early warning system and risk maps. Our EMT at the time were not trained for high altitude response, nor did they have the appropriate gear for cold weather. And we only had one forensic odontologist at the time, hence we had difficulty identifying body parts of crush injury victims. The responders were not familiar with the incident site, and thus we had to rely on the mountain guides as part of responders. So these are actually the mountain guides, not the search and rescue responders. Okay, of course, there were challenges with handling mental health issues of emotionally unstable and angry survivors, as well as the personnel on site. There were numerous aftershocks during the event, and the personnel had to respond on site with the mental status that they're in. Even after the incident, the acute incidents, continuous mental health and psychological support interventions were carried out to local communities for weeks after the earthquake. Then there was also disruption of clean water supply due to mud flood. We had to source clean water from nearby districts and arrange transportation for drinking water to affected area and also temporary evacuation centers. Now, past history and research have shown that Malaysia is not totally immune to earthquakes. And Sabah state in particular is relatively prone to seismic activities. So, bearing that in mind, we have to strengthen our preparedness. The Meteorological Department of Malaysia introduced ADMIS in 2017. We now get an earthquake bulletin within 8 minutes of each incidence of earthquake. A seismic hazard map was also produced in 2019, and seismology centers were built across Malaysia. This example of earthquake bulletin described an earthquake near Tasmania, Australia, just a few days ago. Okay. Capacity building activities are also intensified for all agencies involved. This was spearheaded by Sabah Parks as the caretaker of Kinabalu National Park. And then our National Disaster Management Agency also produced a standard operating procedures for earthquake disaster management. And of course, our Sabah State Health Department under Ministry of Health also produced guidelines on disaster response at Mount Kinabalu and Kinabalu National Park. Looking at this trail map, it shows you the distance of trekking distance and also designated areas for helipad for emergency evacuation if needed. So the main gathering area will be at the Panalaban Base Camp, which is about 6 kilometers of trekking at the elevation of 3,200 meters above sea level. Hence, we can appreciate the magnitude of capacity building for all responding personnel in terms of physical fitness and mental strength. 3 full-scale simulations have been held so far, starting from 2016. We had the disaster in 2015. We found that there were lessons learned, and hence we had simulation exercise to strengthen those, to overcome those weaknesses. So we had to pause the simulation in 2020 due to global pandemic. And this simulation was also participated by the top management. In 2016, we can see the then Ministry of Health, Malaysia, as well as its Assistant Minister of Local Housing and Local Government from the Sabah State, participated in the simulation and made the climb themselves. From the pictures, we can see there were much improved interagency collaboration for search and rescue. And we also tested our Medivac and set up medical base camp at a designated location at Kinabalu National Park. In 2018, we have our Secretary General Ministry of Health Malaysia and also Deputy Director of General Health, Public Health participated in the simulation, which include their climb to the summit as well, so that they can experience firsthand what it takes for personnel to go through the response. And here are some photos from the simulation in 2018. And lately, last year, this was in 2022, The simulation was participated by our head of disaster outbreak crisis emergency sector in Ministry of Health Malaysia. There was Dr. Mariela Sulaiman. Here she was with other agencies at ground zero at 3,800 meters above sea levels. On the picture on your left, our AMT are provided with jumpsuit to handle cold weather. And we also managed to get our medical search and rescue officers to participate in the climb up to the summit for medical response. As you can see in the middle also, Dr. Hazlina also participated in the climb, so she can appreciate what strength it takes. Of course, recently we developed our guidelines on human resource mobilization during public health emergencies, which was also tested during our 5th regional collaboration drill. This further adds to better coordination of our EMT. For communication-wise, we engaged with our strategic partner, Sapura, to provide mobile transmitter during disaster response, as the area in Kinabalu National Park is a communication black zone. And of course, we have our database to monitor our resources and equipment through Malaysia Health Data Warehouse on GIS app. We keep this regularly updated. Next, using whole of society approach, we work closely with NGOs and promote community empowerment. During the earthquake in 2015, we collaborated with NGOs like MyCare and Imaret to provide psychological first aid to local communities and response personnel. We also have a network of community health agents named as My Champion, whom we train to be community change agents. We provide training sessions and workshops such as CPR training to community members. We also train more people to become psychological first aid providers. And our strategic partner, Med Malaysia, constantly educate the public on disaster preparedness. In conclusion, public health preparedness is a shared responsibility involving multiple stakeholders, including government agencies, community organizations, healthcare providers, and individuals. It is essential for enhancing resilience and reducing impact of emergencies and disasters on public health. Last but not least, to those who have not been to Kinabalu National Park and climb Mount Kinabalu, we welcome you. And the picture on your left shows the memorial monument for all the 2015 earthquake victims. Okay, for those who want to find out more, you can go to the website to climb Mount Kinabalu. Here are the list of authors, my list of references, and acknowledgement to Director General of Health Malaysia for the opportunity to share today. And to our partners, Sabah Parks, Med Malaysia, and all other strategic partners, we will continue to work together. So with that, I end my presentation. Thank you.
Thank you very much, Mr. Abraham. I'd like to invite a question from the floor. Okay. Oh, okay, please.
Thank you, Doctor, for a very interesting presentation. I'm Rosa from Aceh. We've been doing the disaster simulation as well. And the problems is still on the collaboration. The idea of the collaborating with other professions, yeah, it seems have the challenge of like underestimating other professions, job description, capability, and so on. So I'm wondering if it's also happening in your simulation, and what ways you navigate those problems. Thank you.
Okay, thank you very much for the questions. In Malaysia, overall, our National Disaster Management Mechanism is spearheaded by our National Disaster Management Agency, NADMA. Under this, depending on what type of level of disaster, we have level 1, level 2, level 3. Level 1 will be at the district level or the provincial district level. Level 2 is more on the provincial level, and level 3 is in the national level. So at each level, we have the incident commander. That is for the overall mechanism response. However, on site, we have on-scene command posts, which is headed by our Royal Police, Royal Malaysian Police. So the on-scene commander will dictate the overall coordination, and also each of us, different agencies will play different roles. As I mentioned just now, our roles of Ministry of Health is to provide emergency medical services. So other agencies will have their specified role as well. And of course, in 2015, when the real disaster happened, we can see that's when the chaos happened. So that is where we keep having simulation, and thankfully enough, after the first simulation, second simulation, third simulation, we keep improving on this interagency collaboration. So my advice would be, I think we just need more practice. Practice makes perfect when it comes to interagency collaboration. And of course, you get to know more and more people from different agencies. You increase the frequency of interaction with each other. However, another challenge came when there's turnover of personnel from different agencies. So that is why the regular and frequent simulation has to be conducted to improve on the collaboration. Yeah, I hope that answers your questions.
Okay. Thank you very much, Mr. Abraham Chin Sevo. I would like to give him a round of applause. Okay. Okay, moving on to the next presenter, we have our colleague from Myanmar, Mr. Nhan Win Min. Could you hear my voice? I think, is it still mute, or we cannot hear your voice yet?
Yes, Mr. Chair,
Yeah,
I
yeah.
can hear you now. Thank you.
Okay, great. We can hear your voice. So, Mr. Nhan Win Min would talk about strengthening early warning and rapid response in Cyclone Mocha affected areas in Rakhine State. Please, the floor is yours.
Thank you again, Mr. Chair. So I would like to screen share from my side.
Okay, please.
So I cannot share screen from my side because the organizer is not allowed to share.
Okay. Please, a technical team. Okay. Can you share it now?
Sorry.
Yeah, we can see your slide. Okay, your slide is clear now. You can start your presentation, please.
I have no UI to disclose in relation to this presentation. As you know, the Myanmar is very prone to the natural disasters and is facing cyclone flash and landslide, etc. every year. In recent year, we faced about the major flooding events in 2015 and 2015 and 2018. And very severe cyclone storm Mukha has made the landfall to the Rakhine Coast on 14 May this year with the wind speed at 135 miles per hour. Due to the cyclone Mukha, it has caused the damage to the health facility, communication and transportation facility. It has caused about 145 life lost in Rakhine State due to the cyclone. And Ministry of Health, in coordination with the health partners, are providing the essential healthcare services to the communities, as well as we are strengthening about the early awareness and rapid response system for early detections and response to the epidemic-prone disease and event. Ministry of Health, in coordination with the partner, has identified about the 15 common communicable disease and health events in the Rakhine State for EWAS. Myanmar has activated about early warnings and rapid assistance since 2018 after the cyclone Nargis. And since then, we have activated our early warnings and rapid system in case of the every major natural disasters and public health emergency events. The aim of the EWA is to reduce the morbidities and mortality due to the priority communicable disease or the public health importance among emergency or disaster affected population. It was reported that there was no last major outbreak in post-Nargis periods due to the effective implementation of the EWAS among the Ministry of Health and health partner. Myanmar has 70 states and regions, and currently we have activated EWAS system in Rakhine State and Kachin State, which is now facing about the natural disaster events. This slide shows about the information flow of the EWAS system in Myanmar. And as you notice in this diagram, so for the EWAS, we got the information not only from the hospitals and health centers like the rural health centers and sub center. We have collected information from the mobile clinics and health clinics from the INGOs and UN agencies, as well as we got about the information from the temporary relief camps due to the information. From these health facilities, the information are sent to the township public health departments, state regional health departments, and the Ministry of Health. We also share this information with the WHO health partner for early detection and response to any potential public health threat. And for the Ministry of Health, we also publish, in coordination with the WHO, we have published about the weekly bulletin for the EWAS for in kinds of the policy advocacy with the authority, as well as for the information sharing with our head partner. Because as I already mentioned, Myanmar has very common for the natural disasters, and we have usually carry out about the EWA training program before the monsoon seasons. And this year, our EWA training program was conducted on April 2023 with the focal person from the states and regional public health departments. And so in this meeting, we explained about our standards operation procedure for EWAS. We also conducted about the workshops on monsoon season preparedness on early May this year. And so this kinds of the event is very much useful for preparedness and response to the cyclone Mogas and other natural disasters even during the monsoon season, because the Myanmar is very prevalent for the floodings and cyclone events during the monsoon season. This slide shows about the track of the cyclone Moga events, and the cyclone Moga hits about the northern Rakhine State, and for the Rakhine State there is 70 townships, and 70 townships, and the cyclone Moga has affected about the 10 townships in the northern Rakhine State with the populations of 2 million people. For the EWAS, we have 19 reporting sites, not only from the health facility from the Ministry of Health and Sport, but also from the clinics and mobile clinics from the INGOs and UN agency. The objectives of this study is to assess the situation on the priority communicable disease and public health events and the early warnings and rapid response system in cyclone Moga affected areas or the 10 townships in Rakhine areas. We have analysis about the weekly data from the EWAS, which are compared before and after the cyclone for any changes in epidemiologies and burdens of communicable disease in Rakhine State. This slide shows about the total numbers of consultations in Moga affected area in Rakhine State by epidemiological week 1 from week 39. And cyclone Moga hit the Rakhine State on epidemiological week 20, and as you see, there is dipping in numbers of the consultation in affected townships during the cyclone because the people are not coming out during cyclone events. After the cyclone events, the numbers of the consultations in Moga affected area is improving, and so by cooperation from the RRTs and emergency medical team from the Ministry of Health, as well as from the health service provided by the health facility from MOH and mobile clinic from the UN agencies and INGO. This slide shows about the numbers of the acute watery diarrheas in Muka affected townships in Rakhine State. As you see in this slide, in week 21, there's a little bit increase in acute watery diarrhea events in Rakhine State, which is immediately after the cyclone Mukas. However, the diarrhea cases are return to the normal patterns and after the week 22 due to the disease control activities by our MOH and head partner. This shows about the weekly distributions of the influenza-like illness in Muka affected townships in Rakhine State. And for because the influenza season in Myanmar is the monsoon season, and that's why the influenza cases is weekly influenza cases is slightly increased in these townships in Rakhine State. This slide shows about the COVID-19 testings and COVID-19 cases in Rakhine State in 2023, and so we have tested more than 90,000. Tests for COVID-19 and only 16 cases are identified. In this case, for the COVID-19 is not a major public health problem in these townships. This slide shows about the other medical consultation by the community to the EWA partner in Cyclone Muka affected townships in Rakhine State, and so for the other medical consultation to the Cyclone Muka is also improves after the Cyclone Muka due to a fall from head partner. This slide shows about the diseases and the public health events under the EWAS. And so this slide from the epi week 1 to 39. And so this slide shows that there's no major outbreak, no major communicable disease outbreaks, as well as no major public health event during this reporting periods. So due to the data analysis from the EWAS, it is shown that the numbers of consultation to the health facility and mobile health teams are increased after the cyclone Mukas. And it's also found that the incidence of the influenza-like illness is increased due to the seasonal changes in monsoon season in Myanmar. However, the number of diarrhea cases are not so much different in townships in these Rakhine states. On top of that, there are also no significant changes in other communicable disease and public health events before and after cyclone Muka. In conclusion, due to the effective implementations of the EWAS by our Ministry of Health and our partner, the incidence of the communicable disease and public health events does not increase and follow the normal disease patterns, as well as there's no occurrence of the communicable major outbreaks in Rakhine State. Thank you for your attention. So thank you for your questions. And so we have the EWAS implementations, early warning and rapid response system implementation in Rakhine State since 2016. So because the Rakhine State is very prone to the natural disasters, and so for EWAS implementations, we have the Ministry of Health in coordination with WHO has developed about the dashboard system for EWAS, and so health partners and the health facility can fill the EWAS form by mobile phones and mobile app, etc. And so in area which has a very limited accessibility to the internet, they can submit also by the EWA hard copy files. And so these data are sent from the township head departments and from the head partners such as INU and UN agency, as well as from the head facility from the MOAs. So at the Rakhine State Public Health Department, the WHO teams and the MOA team are working together for collections of the data. And so after that, they are data collections and analysis. They send the data to our Department of Public Health and Ministry of Health and WHO, and so we can share weekly with the other head partners. Thank you.
Hello, this is Dr. Tatsu speaking from the Indonesia. And thank you very much, Dr. Mian, for sharing your great system, surveillance system. And I'm very impressed. And can I confirm one thing? Does your surveillance system cover the emergency medical team? Like a team, do you have that kind of data? Can not only the local facility, but emergency medical team can report to the emergency medical team can report to your great system? Thank you.
Yeah, thank you for the questions. And so for the EWAS, we include about the all head partners. And so for respond to the cyclone Muka, the Ministry of Health as well as the head partners such as the INGOs and UN agency are sending the emergency medical teams, as well as the rapid response team to the Rakhine states. And so they also distributed about their daily data. They also collect their daily data and so submit to our focal points in Rakhine State Public Health Department. So this data also includes about the data from the emergency medical team. Thank you.
Thank you very much, Dr. Nyan. So that is great to hear. And I do believe all EMT must contribute to your national surveillance system. And as a product of the ARCH project, we have standardized the regional reporting form to the local public authority, which is called the Minimum Dataset Data Reporting, EMT data reporting. So I hope in future you cover not only your national partner, but also international regional capture can have a more privilege to contribute in your great system. Thank you very much, sir.
So thank you very much for your great suggestion.
Thank you very much, Prof. Kubo. Thank you very much, Mr. Nyaw Min Min. We give a round of applause for Mr. Nyaw Min Min. Okay, and now we are moving on from the last but not least, our presenter from Thailand. I'd like to invite Miss Dang Phun Prokum. She would like to talk about an adaptation of the emergency medical services during COVID-19 outbreak in Thailand. Okay, the floor is yours.
Okay, thank you. Good morning and almost noon, ladies and gentlemen, and also your excellencies. I hope you can see me up here and not just these flowers. My name is Dang Phan Prongkham, and now I'm the acting manager of the International Collaboration Center for Emergency Medicine and also in the professional level in international coordination. Today I have my boss with me and also my co-authors, just in case that you give me a very, very difficult questions. So the authors has no conflict of interest to disclose in relation to the presentation. Okay, so since the 2019, the COVID-19 has brought us the catastrophic impact to the world and also to Thailand. The EMS or the Emergency Medical Service of Thailand was also heavily affected. According to this graph, there were 3 waves of infection or the pandemic period in Thailand. The first wave started in February 2020, the second one started in January 2021, and the third wave started in April 2021. And according to this graph again, the first and the second wave the impact was quite minimal, but for the third wave, the accumulation of infected cases reaches more than 170,000 cases. Tremendous phone calls to the 1669 call and dispatch centers. The demand of EMS services increased. Calls were complicated with multiple emergency numbers, including 1669, 1330, 1668, and 1646, and so on and so on. Could you have a next slide for me? Okay. For the first and second wave, again, the pandemic had a minimal impact to the EMS system since the number of infected cases were low and Thailand can control the infection well. So our focus remains at the sustaining emergency medical service system. So the first thing that we do is that we set up the special COVID-19 operation team called the SCOT team. So the SCOT team was created to become a competent team that can handle transportation of the patient under investigation cases and also normal emergency patients. They have to be operated under the medical direction of the call and dispatch centers, and they must transport the COVID-19 infected patients whose conditions are not severe from their houses to medical facilities. The second thing that we did was to establish the Emergency Operations Support Center for COVID-19. We adapted from the Incident Command System, or the ICS. We create the emergency management system that is unified but flexible. It also gathers intelligence and do the brainstorming between commanders and also the leaders. For the third thing, we develop call and dispatch center protocols and EMS agency for the COVID-19. They develop safety procedures for EMS practitioners, identify common spatial definitions, common code of conducts, and also the rates of compensation. Currently, they have 9 versions of protocols already. For the fourth thing, we provide training courses based on the universal precautionary principles. For example, how to wear personal protective equipment and also how to take off the personal protective equipment. We teach them on to do the decontamination, infection control, and etc. 5, we provide educational materials for EMS providers and also the public. For example, video clips on how to wear PPE, take off the PPE, the brochure, and also the infographics. 6, we also support the personal protective equipment or the PPEs to the EMS practitioners. For example, in the case of Ministry of Public Health, National Institute for Emergency Medicine, and also our international partners and alliance, they provide and donate PPEs for our EMS practitioners. And to conclude the first and the second wave, may I quote the saying of Dr. Acharya, since the number of infected cases in the country were low and the country can control it well in the first and the second wave, the EMS system was more focused on preparation to protect EMS providers from any infection. So here's come the third wave. For the third wave, the infected patients were more than 20,000 people per day and continued like this for more than 2 weeks. The infected patients in Bangkok reached 4,000 to 5,000 per day. The number of available beds were in shortage for the symptomatic COVID-19 infected patients. The number of deaths reached more than 100 cases a day. We have the lack of specialized medical personnel, and also the country was in need of the integration of efforts from multiple sectors. So in the third phase, the NIAM, or the National Institute for Emergency Medicine, and also the whole country have 4 missions. The first mission is to set up transportation system for COVID-19 infected patients in Bangkok and suburban area. The second mission is to set up the emergency medical system for the national mass vaccination program. The third mission is to set up referral system of the infected patients from Bangkok to their hometown. And the fourth mission is to conduct the active searching of in-risk patients to be transferred to medical facilities. And here's the first mission. It is to prepare for surge capacity. And we do what we call the Temporary Emergency Medical Operation Unit, or agency. We call on the EMS Alliance in other parts of Thailand, other provinces, and the other volunteer groups to help us conduct special missions in Bangkok and suburban areas. And then these temporary units must be trained and certified and then granted temporary accreditation. Currently, we have 76 volunteering EMS medical operation agencies and 171 EMS medical operation units. They must operate under NIAM's direction for less severe case or asymptomatic cases. And next, this is the number of transport missions transferring infected patients from houses to medical facilities. Actually, there are more than 7,432 missions and almost reached 10,000 cases. For the next mission is to prepare the EMS system for mass vaccination program. So we have to prepare the EMS service for the population who may experience the adverse events following immunization, such as life-threatening side effects of the COVID-19 vaccines. We must prepare, monitor, and respond to any illnesses that might be associated with the vaccination within 30 minutes after the vaccine. If the ground ambulance were not capable or not available, the helicopter emergency medical services or HEM service were also prepared, especially for the island area. And for the third mission, we set up the referral system of infected patients from Bangkok to their hometown. We, in collaboration with the Ministry of Transportation, we find available modes of transportation, which is to distribute the number of patients being admitted in medical facilities from Bangkok to other areas. The first step is to get the patients from their home. The second step is to transport them to the provinces of their hometown using long-ride vehicles. For example, in this case, we used the bus, the big bus, the van, and also one trip of the train. But it's quite hard to control the infection. The third step is to transport the patients to identified medical facilities. And the fourth mission is to conduct active searching for the in-risk patients to transfer to the medical facilities. So we do active searching from social media and also the civil societies and also the volunteer networks. So in conclusion, the outbreak of COVID-19 has affected all sectors in Thailand, economically and socially. The emergency medical system of Thailand has also been affected heavily. The challenge lies on the ability of the concerned authority to keep essential public service running with no disruption. To prepare for public health emergency situation, adaptive and flexible management is needed. For example, new management structure, protocols, code of conducts, prompt personnel, new norms, effective management of limited resources using surge capacities and multi-sectoral collaboration. An emergency medical service system of Thailand remains operable and is able to continue delivering their services to the population. And that would be all of my presentation. If you need to contact me, you can contact me through my email. Thank you.
Okay, thank you very much, Ms. Dang Vun. I'd like to invite the question from the floor. Okay, please.
Okay, thank you for the opportunity. Let me introduce myself. My name is Livia Alessandra. I'm the student of the Gajah Mada University, majoring in nutrition and health. First of all, I'd like to ask that on the third waves, the Thailand did experience the shortage of beds. Then my question is, did Thailand also experience the shortage of the workforce? And if yes, what is the consequence of that? Did the quality of the workforce decrease, or did the quantity of the accepted patients decrease, or is there any other consequences, and how do you counter it? Thank you.
First thing, yes, we have the lack of the available beds, but for another thing that you asked, what is that? Sorry.
Did Thailand also experience the shortage of the workforce?
Shortage of the workforce? Yes, that's why we need the temporary EMS unit, because actually these people are not legalized yet in our system, but because we are in shortage of the people to work for us, that's why we call on their help and then do the temporary accreditation for them.
So did Thailand experience did the quality of the workforce decrease, or the quantity of the accepted patient is decreased, or do you face another problems with that?
For the quality, I cannot say that I can measure that quality, but the quantity, yes, there are also less quantity because there is one factor. The emergency medical service provider also feel, I don't want to use the word scared, but they're also worried about the infection in their own family. They can bring back the infection to their own family. So yes, some of them are reluctant to operate, and some might deny to operate unless we provide the PPE.
Okay, thank you so much for your answer.
Okay. I think that's all. Thank you for Mr. Dangpun. We give her a round of applause. Yeah. And I would like to ask all the presenters to go to the stage. All the presenters, please go to the stage. We have a token of appreciation from Mr. Suichi Ikeda. And while waiting, I would like to give a summary remarks. So from all the presentation, we can learn that the EMT well-being and health are really important. So that we need to really take a look at that part, and then pre and post-COVID screening program also important for EMT service during the pandemic. And health needs assessment is very important toolkit, but we need to adjust it accordingly to the to match for each AMS need, and multi-agency stakeholder commitment is needed for the COVID response, as well as the support from the stakeholder agencies and community in important part. Okay, now we please Mr. Suichi Ikeda. We can give one by one, yeah. Okay. Okay, thank you very much.
Ladies and gentlemen, we are now presenting our tokens of appreciations to our esteemed speaker for such an inspiring session one. What a session that was. We are truly delighted. Another one may we present to our delightful moderator of session one, Mr. Datu Respatika, an honored member of our faculty. Thank you very much. May we have you front and center, sir, on the count of three for a group photo. 1, 2, 3. One more time. Do not wink. 1, 2, 3. The biggest round of applause, ladies and gentlemen, for session one of our conference. Thank you very much, speakers and moderator. Inviting you to return to your seats, please. Distinguished delegates, ladies and gentlemen, it is now high time for us to invite you to enjoy your delicious lunch, already served at the Le Patio restaurants, or rather El Patio in Spanish, that is. I was going with French there. So please enjoy your lunch. We look forward to see you in less than 1 hour, as we'd like to be on time and punctual for the next sessions. So we will convene at 1 p.m. local time for session 2. Ladies and gentlemen, please have a wonderful lunchtime.
The next song we're going to do is a song by a really good friend of mine. He's actually featured on my original Black Radio album. He co-wrote and sang a song on there called "Oh Yeah." It's by my friend Music Soul Child. It's entitled "So Beautiful."
What up? It's music. I heard you was doing my joint so beautiful. You and the guys was doing it over, and I really feel like I really feel honored. I mean, it's a good thing that you picked that song because I think it's important that women know how beautiful they actually are, despite whatever may be going on in the world these days. When it comes to women and how they feel about the way that they look, how men think about them, and what they think men expect of them, I don't think that
Distinguished delegates, ladies and gentlemen, we are due for the next session of the conference. We are calling upon our participants who might still be outside. We kindly invite you to return and take your seats. The next session is about to begin. And while we wait for the rest of our fellow participants to join us here in the ballroom, may we also invite you to visit our website, aacdhm.net, for more content pertaining our conference here in Yogyakarta. So once again, the address is aacdhm.net, and we hope to display that very soon on the screen. Once again, inviting delegates and participants to join us here in the meeting rooms. We're about to begin. Thank you. Distinguished delegates, ladies and gentlemen, welcome back to the second half of our conference. We are sincerely hoping that you're all refreshed and energized to embark upon the second session of our conference. Session after lunch is always the most challenging, but no worries, we have such an exciting topic to dissect. We're going to be shining a light on human development and education for DHM. And allow me to present to you and introduce our moderator for session 2, coming all the way from Bangkok, Thailand. At present, he is one of the Arch Project's consultants who is responsible for supervising and giving out useful advices to ensure the project is run in accordance with the plan of action under the ASEAN Leaders' Declaration on Disaster Health Management. Ladies and gentlemen, it is my pleasure to invite Dr. Phumin Silapun.
Okay. Good afternoon, ladies and gentlemen, and welcome you to the longest session. This session is 4 hours, and this day will be end at 7 p.m. So I think you should prepare yourself for a very long session. But I am sure that you will listen to the very good presenter, 11 presenter for this session too. Some presenter experience, but some few experience. And some, this is the first time for them to present in English language among international participants. I would like to remind a little bit about the objective of the ARCH project and the conference and academic activity. We know that if we want to sustain our regional capacity, sustain development of disaster health management, we need to engage a new, young researcher to involve in the academic activity. So this conference and the journal, we will try to invite or encourage the new younger. So I hope you to cheer up them, all presenters, that I know they are very exciting now, okay? And we should start from the first presentation by Dr. Phumin Salim from Thailand. He will present about the basic cost for disaster health management that we call B cost and its challenge for the application to each AMS. Please, Dr. Phumin.
Good afternoon, delegates, ladies and gentlemen. It was my gratitude to be here. I would like to say thank you to the committee to invited me to join this wonderful conference. My name is Dr. Phumin Salim. I'm an expert level emergency physician from Hat Yai Hospital in the southern Thailand. I have working on curriculum development in disaster health management for the ARC project. especially in a basic course of disaster health management. Today, I would like to report the roadmap of B course, the challenges, and the way forward that will be one of the stepstones to increase capacity of disaster health management for ASEAN countries. First of all, I would like to declare that I don't have any conflict of interest to any organization in relation to this presentation. As we already know, that ASEAN region is one of the most vulnerable regions for natural disaster. But from the survey in 2015, the level of preparedness for emergency response differed among countries, from disaster-prone countries that already well prepared to the developing countries that could not obtain sufficient resources because the disaster preparedness is their low priorities. Oops, sorry. Okay. The formulation of the project for strengthening the ASEAN regional capacity on disaster health management, or ARC project, was proposed and endorsed in 2016, 1 year after the survey. Meanwhile, the ASEAN leaders signed the ASEAN Declaration on One ASEAN, One Response in September 2016, which has been expected to increase the speed, scale, and solidity of ASEAN response. One of the distinguished outcomes of the first phase of the ARC project was the minimum requirement and qualification for member of emergency medical team, or EMT, as shown. To get the minimum requirement, the sub-working group for standard curriculum development has been founded. It aims to construct the consensual training program for the AMS country, and the basic disaster health management course is one of the courses that have been proposed. Regarding of the heterogeneity of the capacity on disaster health management, among each AMS as mentioned. The objective of this presentation were to describe a development process of the B course throughout the sub-working group of, on the standard curriculum development mechanism, to describe activity among each process, the challenges for the application of the course, and the way forward to the implementation. The author reviewed the reports on the sub-working group on standard curriculum development and related articles, as well as described the observing outcome of the training activities on the B course. So the result of the presentation, the start of the curriculum development using this diagram to be a guide to construct the program. By conceptualize the learning outcome, determine the competencies, create the content, decide the material and teaching method, implement the program, and seek for evaluation, and will be the circle of curriculum development. All the process have been discussed by the participants and representatives from the AMS country, and seek for agreement in the meeting. Sorry. There were 5 meetings among this process. I would like to make a brief review on why we choose to develop this course by the competency-based method. Because responding to the health disaster, they require owning competence in order to help the casualties. Particularly, they should ensure that they make an action with confidence to perform the best medical task possible. This leads to the Miller's Pyramid in 1990, that the healthcare worker must achieve the peak of the pyramid. And the question is, how can we do that? I wish for the next several slides to give you a clue and answers. For the learning outcome, this is the first question for the committee to determine before we start to generate the course. So what do we want? What do we want the trainee to be after they finish the training? From the first subworking group meeting, the B course would like to make the small disaster-related healthcare team, which will be able to perform medical care and disaster-related tasks, as well as having a good attitude, being self-sufficient in the domestic response. This leads to the 6 competencies that has been endorsed for the team. Briefly, the 2 of the competencies describe about the disaster medicine theories, and 3 of them, most of them, are to demonstrate the disaster mindset, and the last one is the essential skills that the team need to provide to the casualties that they cannot be seen in the routine work. To blending these 6 competencies together, we expected that the trainee who finish the course will work efficiently when they are deployed. To blend the 6 competencies, I would like to bring you back to another pyramid of learning. The theory told us that people tend to learn more if they are doing it or discuss about it, while the traditional lecture gives only 5 to 10% of knowledge in the long term. That is why the committee have an agreement on the blended learning method, which is the adult learning method, and plan to providing the theory by the directed self-learning, and combining the skills and attitude training by integration of discussion and simulation. This slide shows the contents of the course, the theory. It consists of the 9 general modules, and 3 of each module is the medical and logistic module. All of them will be provided in the online learning platform, prerequisite to the hand-on simulation and workshop. We discussed a lot about the workshop, that whether we need the costly field simulation to enhance learning to the participant or not. It came out that 5-day workshop with the field training exercise would be too hard to manage. So the workshop was reduced to 3 days, integrated some activity and lecture, and to be more to scenario-based, scenario-oriented discussion, and discard the field exercise and make the detailed tabletop exercise instead. So this is the tentative schedule for the workshop. So this slide will show you the online platform to provide to the participant for the self-learning. But unfortunately, this platform is temporarily for the mock-up course on July. But however, from the observation in the initial course, which is not the must for the participants, we found that about 50% of the participants finished the course by the self-learning. So this slide shows the example of the workshop activities that we have been done in the face-to-face workshop during the subworking group meeting. We have the scenario-based group discussion. We have the activity enhanced learning by the patient guards, and the presentation and sharing for the participant in the workshop. We already had 2 initiate workshops during the subworking group meeting mechanism. The first one we have done in Surat Thani, Thailand in 2022. This course was done for the Thai participants only. And the next one is what was done lately in July 2023. This is the full mock-up course, and the attendants were the AMS countries participants representative and the Japanese experts. Both initiates workshop gave us the fruitful outcome and the good feedback. So the discussion, the BDHM or the B course is one of the outstanding outcomes from the project Working Group 2 of the ARC project. This course was expected to be the standard curriculum for the AMS country that has never had the disaster training course before, and which the competency-based method. The objective of this course was very clear and compromised to other existing courses in another country that is similarly to this course, and ensure that personnel who attend either this course and other can be harmonized in the operation for the ASEAN country. This is the challenges for the B course implementation and development. One, there are some language barriers in some AMS countries. The English content somehow might be hard for them and maybe need to be translated to the local language in the AMS country. Two, there are a limited number of instructors. To conduct this course in other AMS country, it would be needed some initiated instructors to guide the local instructor before the course could be conducted in their own country. Three, we already calculated the expense of the course. It is about 150 to 333 US dollar packs, depend on the cost of the venue and the number of facilitators. And the last one is the B course, particularly every course in the future, it needs the academic background, such as to perform the certification, the online platform, the accreditation process. Maybe the ASEAN Institute on Disaster Health Management could be involved for a sustainable implementation in the future. This is the way forward. So I suggest that the B course should have the quality assurance process and more improvement process. Two, the next edition of the course might need to be done under the responsible academic body. Three, next capacity building course might be done in the future, such as the course to enhance the operation team internationally and make the capacity development sustainable, or the training for the trainer, or the refreshing course. For the conclusion, the BDHM has now been successfully developed in the cooperation and hardworking process of the Thai task force, Japanese expert, and subbing group meeting on curriculum development for the ARC project. Further implementation in other member states will need to be done to achieve the goal of the action plan of the ARC project. And it is expected that the course will provide the standard guideline for the disaster response team in AMS in the future. Thank you for your attention.
Thank you, Dr. Pumarin. Any question from the floor? Okay, so I have one question. Because this course designed for all AMS who interest to building up capacity of their own people, but in each AMS they may have different contexts, such as culture, law, regulation, how they can adapt this course to their own context. And in case they want to organize this course in their country, how about your recommendation, how they can coordinate with you, or please?
Thank you for your question. The first question is, how can we imply this course for each of the AMS context? So I think this course was designed to be the competency-based course. So this means if there are some of the contexts in each country, they can determine that each content or the activity that they use in the course is compliant to the competency or not. If they are compliant, it will be very good for this course, for the standard one. And for the second question, to be implemented in the other countries, maybe right now we don't have the contact body for the course, and I think we may be used for the consolidate bodies such as the AIDHM to be the connecting point for the other countries to be use this course, or right now maybe the ARC project can help.
Okay, thank you. Any question? So, okay, please.
Yes, yeah. Thank you very much for your lecture. It's very impressive. My question is, how far have you implemented your curriculum in your country? I mean, it's just in your hospital, or it has been a government policy, or I mean, have you trained such a only medical, or you have trained any such a special community in your country? Thank you.
For the Thailand policy, maybe the last several years, we are taking into account that every province should have the disaster health care team. Usually, we already have one of the course right now in Thailand. However, for the Thai people that attend to the course, they will be come from the Ministry of Public Health. Most of them are nurses, doctors, and yes, because this course using, we expect to have the logistician. So we include the logistician like emergency medical technician or the pharmacist to the course too.
Okay, thank you, Dr. Pumrin. Please give him a break. Okay, for the next presentation. In our project, ARCH project, we developed two standard curriculum. The first one is basic disaster health management course that Dr. Pumrin just presented. And the second one is coordination course to train the people who work in the coordinating body of each member state. So I would like to invite Mr. Suichi Ikeda from Japan. He will present the coordination course for the HM development and its challenge for the application to each ASEAN member state. Please.
Thank you very much, Dr. Pumin. And good afternoon, and Excellency, delegate of the OMS and participants, dear participants of the conference. And it is a great pleasure and honor for me to have this opportunity sharing about our progress and update for the development of the coordination course, which the moderator already mentioned a little bit, as one of the activity of the ARCH project. I don't have a COI for this presentation. I'd like to touch upon a little bit about the background, why we start up this development with SIG course. Some of you may know about the name of the Plan of Action to implement ASEAN Leaders Declaration on Disaster Health Management, so-called ALDDHM. This Plan of Action was approved by the ASEAN Ministers meeting, maybe August of 2019. And in this Plan of Action, they set the 21 target which shall be achieved until 2025. Among those 21 targets, regarding about the training matter, they also put listed the two targets for this POA. One is, yes, standard training curriculum shall be developed, and also each country has to improve their training system. Based on such kind of POA, started, and as my previous presenter already mentioned, the sub-working group was formulated to discuss about the development of this curriculum and material. And actually, the B course and the C course was identified by this sub-working group. It is necessary to develop under the ARCH project. The target of the B course and the C course is a little bit different. The target of the C course is the potential member of the EMT who work for the actual affected area. C course mainly for the head office, the prefectural officer who will be responsible for the coordination for the disaster response. Yes, outline of the C course. The aim of the C course is to strengthen the domestic coordination capacity in each AMS country to be able to manage incidents occur in the country, including the context where international and domestic EMT are arriving. And actually, all of the people who are working in this area, they are sometimes emergency medical doctors, a nurse, or head office, and they are very busy. Therefore, we have to develop very compact, short period course, and this should be very practical. And the participants should be limited up to maybe 20 or 30 is enough for the group works. Target participant for this C course is coordination staff who are possibly to work in the POEC or EMTCC. And we, through the several discussions, series of discussions in the sub-working group, we decided this content, the 18 module is essential from the basic framework of disaster response system, and they have to learn also SASOP, that is a regional disaster response mechanism in ASEAN, and up to the withdrawal of the EMT. Yes, this is a three pillar of the course. The participants have to learn the regional coordination mechanism, as well as international theory and international mechanism and standard operation procedure. But these kind of things should be applied and integrated to the context of the domestic coordination system. And these three is very important because our target is persons who are working in the domestic disaster response in each country. And of course, this should be very practical. Therefore, not only the lecture, group discussion, the practice, and the sim is very important factor for this course. After we continue the many discussion in the sub-working group, we could develop some kind of a draft curriculum as well as material. Based on such kind of development, we organized the trial C course in Japan on December last year. The purpose of this trial C course in Japan is to validate its overall curriculum design and the length, target participant, future application to local context, and the content and teaching format, etc., etc. Participants from each AMS country join to this course, and the lecture are gathered from the Thailand, Philippines, AHA Center, and the ASEC, and the member of the Japanese advisory committee who are the experts for the disaster health management and the JICA expert. As a result of this trial course, participants gave us many comments. The sessions are too heavy and some sessions are overlapping. And the exercise should be made more practical and correspond to the tight time frame. And there are many component or concepts which are difficult to understand. Maybe for the new person to know, to hear about disaster health management theory, it's rather difficult. It is recommended to have a more TTX to ensure the participants understand the actual process. And actually, in this case, we invite all the 2 members from all countries from the MS. They have different background and knowledge for the disaster health management. Therefore, giving the different background and knowledge level of the participants, it is recommended that the participants acquire basic DHM knowledge before attending the course. Yeah, based on such kind of comment, we also developed the application course in the context of Malaysia. Actually, in this year, Malaysia hosted one of the very big events for the arch activity, that's the so-called regional collaboration drill, inviting all AMS countries, inviting all EMT team, consisting of the 5 members, to gather to Kuala Lumpur and Putrajaya. But in order to prepare such kind of thing, and we have to train the player for the EMTCC during the 5th RCD Malaysia for its preparation. The trained person by the course were expected to appropriately play a role for the coordination with participants of RDC and providing the appropriate instruction to those members. And based on the previous experience and the comment from the participants from the trial course, we consider dividing this course should be into 2 parts. We have to introduce pre-learning session, providing the general information and the theory and the regional mechanism, etc. And in-person training shall be done in Malaysia sometime on different day, especially the more concentrating about the group works and practice. This is the pre-learning lecture. As I say that the purpose of this pre-learning to provide general theory or the regional mechanism and the international mechanism by lecture by different lecturers, taking around 2 days, taking 8 hours. This is the implementation of the C course taking 2 days in August. Yeah, I'd like to introduce some of the content of the module. This is a module for the initial assessment and strategic decision making. We try to create a more practical one. Therefore, we provide each participant to conduct a task by group. Based on the scenario, actual scenario, which would be utilized for the RCD in Malaysia. Yes, we show we provide some of the data, and participants are required to predict about the possible increasing the injured personnel, as well as how many major injured might be included in the injured. And they also have to analyze the damage of the medical facility and consider how much is the gap between those needs of the surging needs as well as the reducing the capacity. And finally, they have to discuss about how many EMT, what type of the EMT is necessary. This kind of discussion was done. That's another example, module for the EMT tasking and resource allocation. Based on the Malaysian disaster scenario, on the map for the actual disaster area, they have to discuss about the assignment of the type of the EMT, considering about EMT capacity, and also considering about the safety of the EMT and security of the EMT and the needs of the each area of the effective area. Out of the C course for Malaysia, the EMTCC and EXCON staff for the RCD were trained, and they have obtained the necessary knowledge and skill to play their role in the RCD. Second, Malaysia guideline relating to DHM, such as disaster management plan and the guideline of the human resource mobilization during the public health emergencies, were shared among the participants to the further improvement during the course. They discussed about this thing, and also they already started some kind of the improvement for this kind of the guideline. And also, assignment of the medical coordinator to AMS EMT discuss about their qualifications and role during the course was tested in RCD. As a result, it was confirmed that the presence of the medical coordinator was necessary for the effective and appropriate operation by the AMS EMT as well as for the EMTCC. Actually, the assignment of the EMTC was required in the ASEAN standard operation procedure for the EMT development. Therefore, we test this one. And MDS, that is the medical minimum data set, which is WHO standard, MDS collection was effectively conducted in the RCD, and the result of the MDC collection was properly shared among AMS EMT during the sub-EMTCC meeting. From the EMTC side, they also confirmed their contribution for the provision of the data is really important for the analysis for the many decision making. And the fifth RCD was successfully conducted as an upgraded RCD with full application of the EMT SOP, which was integrated version of the SASOP, that is the final version, including the pre-deployment exercise, assignment of the medical coordinator, effective data management, EMTC meetings, and challenging the scenario with infectious disease and chemical incident. The future plan for in-country course in AMS, we would like to encourage the other AMS countries to apply this vehicle for the organizing your in-country training course. I would like to propose when you organize your in-country course, maybe the pre-learning is necessary, and that you can utilize our pre-learning recorded video of the previous lecture provided for the Malaysia. With some, if necessary, we can put some complementary online lecture. Totally 8 hours is necessary. And in-person course, mainly focusing on the group works, this should be 2 days at least. And as an option, you can include the tabletop exercise based on the disaster scenario from disaster occurrence, EMT deployment to withdrawal of the EMT, and finally after action review. The passive support of the plan in the ARCH project, yes, we can provide necessary advice for the implementation plan, and we can dispatch a mentor team from other AMS and Japan to provide developed teaching material, online lectures, and to dispatch a necessary AMS Japanese lecture for your country. Maybe we expect next year some of 1 or 2 countries raise your hand to host organizing this in-country course. Yes, finally, maybe many of you might have more interest for the ARCH project. Actually, working with WADEM, we succeed to publish this supplementary issue February 2022, and we could contribute 5 articles for the ARCH project. This can be very useful for your learning about the ARCH project. Thank you very much.
Thank you, Mr. Ikeda, for the interesting presentation. Any question from the floor? You present very clear. So I have one question. Please you explain more if some country interesting to organize this course in their country, how should they do? If they want to organize this course.
Okay. Actually, the end of this year, we would like to conduct some kind of the press survey for all AMS countries, whether that you want to organize and application course for C course to your country. And maybe, yeah, after that we can discuss and we can organize the mentor team as well as the preparation team, and we should have the consultation meeting, and we can start up. The very important thing is application, integration process for all the regional mechanism and the international mechanism to your domestic system. That is very important. Therefore, just not implementing the C course. We would like to have, we think that the preparation process is very important, and in consultation with the mentors. Maybe some of the country, you don't have the system of the EMTCC. Maybe you have to discuss before which organization can be responsible for the setup of the EMTCC. Maybe you have to discuss. Maybe we can talk each other, and after you prepare such kind of the integration policy, if you cannot decide it before, maybe at least you have to show, yes, we have planned to integrate such kind of international or the regional mechanism into our policy like this, according maybe 2 years, 3 years. Maybe this is okay, but this kind of the preparation stage process is very important for the organizing in-country training course in your country. Thank you very much.
Thank you. Please.
Good afternoon. I'm Eric from the Philippines. Thank you for a very relevant and impressive presentation about C-Course. My question is about learners' evaluation.
Yes.
What assessment methods or tools are being employed in order to assess the understanding and retention of our learners about the C-Course? Thank you.
You mean that for the assessment procedure? Actually,
yes.
This is the standard curriculum. That if you apply, yeah, we expect that you request a mentor team come to your country and talk with your preparation team from the preparation stage, and they also can be should observe all the course, and maybe your how can say course is really implemented based on the standard curriculum. Such kind of the accreditation, the assessment shall be done by mentors. That is the idea.
Thank you.
Thank you, Mr. Ikeda. If no any question, please give a big applause to him. Mr. Ikeda is not only a good researcher, he also be a good funder. Right? So you have allowed 2 months before he sent a survey. If you would like to organize the course in your country, you need to talk with your people, your executive. And when you get the email from JICA, you can apply. Okay, we have B course and C course already, but sorry, we have no D course. The next presentation from Dr. Rak Muang Sang to present the Human Resource Development Strategy on the HME in the country. Please, Dr. Rak.
Yes, thank you very much, Dr. Pumin, that invited me to have the presentation, and thank you so much, the art project team and JICA, who always support us to join the art project team. Thank you very much. I would like to present my slide. And ladies and gentlemen, good afternoon. Yes. You know, Cambodia the royal government of Cambodia and Ministry of Health in particularly is dedicated to working toward to strengthen the capacity and implementing national strategy plan on disaster risk management for health 2020 and 24. The objective of the Cambodia health sector is sufficient capacity for disaster risk reduction, so to limit the population exposure to some hazard, to increase the resilient committee and healthcare delivery system and recovery from resilient of committee and healthcare recovery from adverse consequence of emergency disaster. Cambodia, we have a level of healthcare service delivery system. In the central level, we have national hospital and provincial hospital level and operational district level and health center, VHV mean volunteer health village, and VHG volunteer health support group, and community is the population that need service delivery on health. In strengthen human resource of disaster management for health, we need a national strategy plan on disaster risk management for health, disaster training curriculum on disaster management public health for public health, and minimum initial service package for reproductive health in emergency and disaster. So we already have on law in emergency and disaster, but under the development of National Committee for Disaster Management in general for disaster. In health, we have only a strategy curriculum. National strategy goal, the life and well-being of the population in Cambodia are protected from the impact of disaster by appropriate public health activity. In the national, we have main 4 strategy. The first, strong governance, policy and coordination. The second, effective information knowledge and management. The third, readiness for health service delivery. And the fourth, adequate resource, human resource and financial. In the context of training, there have 2 lines, training for health, pre-service training. Pre-service training we implement in the University of Health Science. In service training, in PMD, Preventive Medicine Department, and NIPH, mean National Institute for Health, Public Health. In Preventive Medicine Department, provide training all level of health staff on disaster management and other, for example, tabletop exercise and simulation exercise. So in 2022, we have conducted tabletop exercise 2 times and simulation exercise 2 times. According to ART project introduction. And IPA, National Institute for Public Health, the focal point is Dr. Chichobon is the director of an IPA. They conduct in the NIPH master degree of public health. Master degree of Health Science for Epidemiology, Master degree of Science in Nutrition, Master degree of Hospital Administration, Master degree of Health Community Development, Master degree of Public Health in Health Economics and Finance. This subject will be open soon. And for the Master of Health and Community, we include disaster management into this master. The objective of the training curriculum for disaster to help health manager and staff to perform their tasks managing public health emergency in disaster situation more effective and efficiency, as well as develop approach and develop preparedness and response plan to reduce mortality and morbidity in emergency and disaster situation. In the strengthening health staff in survey as learning objective, we have learning session. Session 1 describe of contextual of hazard and emergency and their health consequence in Cambodia and in Asia and the Pacific. And understand the principle of emergency preparedness, risk reduction and management. And third, develop emergency response planning and health service management in health emergency disaster, plan and conduct damage, loss and need assessment analysis with the rapid health assessment. And fifth, the role epidemiology as tool for decision making in emergency. And sixth, manage communicability and emergency situation. Manage risk communication in disaster situation, the process of recovery and rehabilitation phase in emergency. Manage and plan for drug and logistics in disaster situation, manage and plan for market security management, and manage in case of snake bite in the context of Cambodia. Manage of environmental health in disaster situation. This is the session for training on disaster management. And we also have a minimum initial package for reproductive health in emergency training curriculum. The curriculum designed to develop the capacity of health workers to prepare for and respond for before and during and after emergency, especially in reproductive health. The learning session, we have nine sessions. The first, disaster overview, and the second, initial minimum healthcare package for reproductive health, and collaborate and coordinate of the first minimum healthcare package for reproductive health, and prevent and manage for the consequence of sexual violence and other violence. Reproductive transmission of HIV, reduce the transmission of HIV and STD, this session, and prevent maternal and infant death during disaster. Main activity in addition for minimum initial health care package for reproductive health. Reproductive health and sexual health of adolescent and time of disaster, in time of disaster. The ninth session plan for comprehensive reproductive health service. So minimum package for reproductive health, we have 9 sessions, and next week I will join the training of trainer at Thailand with UNDP. UNFPA invited me to join the MIS training for TOT. Challenge, the National Strategy Plan Disaster Risk Management for Health, we will expire in 2024 and will update soon at the end of 2024. Still, all disaster training curriculum on disaster management for public health, it will be updated as ASEAN curriculum because, like Dr. Pumin introduction, and limit of human resource and logistics for disaster management. And gender is imbalance on disaster risk management. You know, gender unequal for disaster management because they think that for the disaster management is the hard work for men, not for women. So when we invite the women to join for the disaster event or situation, they are afraid with disaster. So for the disaster imbalance, for gender imbalance. Next step, we will be mainstreaming disaster risk management into the pre-service training. Pre-service training, we are implement the project quality insurance in Cambodia. We conduct the pre-service training, and some World Bank donor, they request us to prepare the session for disaster management in the pre-service, prepare for put into the pre-service training in the University of Health Science. So we'll be update the curriculum of training as consistency with the ASEAN training curriculum. Will be incorrect gender involved in the strategy on disaster risk reduction. Thank you very much for your attention. I would like to tell you this is the temple, Angkor Wat temple, and this is the sunrise at the morning. Many people want to see the sunrise.
Okay, thank you, Dr. Lak. And thank you for this beautiful picture. We should organize RCD in Cambodia. I think many of us would like to go to Cambodia when we see this picture.
If I project support.
Any question? Please.
Thank you, Dr. Lai, for the presentation. So, in my country also, you had some program and plan something like that to develop also curriculum training for the disaster health management as well. So, my question is that, you know, how about material that you develop by yourself or charter based on by WHO guideline, or maybe you refer from another country? Thank you.
Yes, thank you for your question. For the material of training curriculum on disaster, we developed for a long time according to WHO.
Okay.
Yeah,
Thank
and
you.
For the minimum package activity for disaster risk reduction for reproductive health, we follow by UNFPA curriculum.
Okay, thank you. Any question? I have some question. I interesting in the reproductive health. Reproductive health.
Reproductive health, yes, okay.
Can you explain more about who is the participant of this course? And is it different from the public health course? And duration of this course? How long?
For the participant involved in the reproductive course, we invite, the MCA, Maternal and Child Health Director, or the director of hospital. We invite to join this course because we would like to provide knowledge and provide a plan. After the training, we need the participant to develop on their own plan for response on reproductive health. I would like to introduce you about UNFPA. If we want the support from UNFPA material, and the government need to declare. The government cannot respond on the event. UNFPA can produce everything to us, but the government cannot announce, so the UNFPA cannot produce for us.
Okay, thank you. If no any question, please give a big hand to Dr. Rai. I think it is an interesting course. We may have B and C and R course, reproductive course in the future. And next presentation from Ms. Uraiwan Ponasan from Lao PDR. The presentation about action plan of training for emergency medical team, please.
สบายดี Good afternoon. I am Dr. Urawan. I am emergency doctor. I work at the Mitraphap Hospital, Vientiane capital. Today, I am really happy for my boss who are sitting the second line to give me a chance to be here and guide you to our action plan. So, since 2018, we have the big disaster in our country. We cannot call like a dam collapse or something, but effective area is covered to the 19 villages, more than 14,000 people who living there. On that time, we found only 48 people who are dead body and 23 people who are still missing until now, already 5 years left. On that time, we have too many challenges as we are lack of the triage system, insufficient medical supply, and inadequate logistic support for the EMT member. This what will happen on that time. Not only the village, but on the roads or everything is gone with the flood. So on that time, our EMT Taiwan fixed to deploy to area on the day 2. The first round is we call the rescue team, but they are act like first aid responder with the emergency physicians. Second round, we orthopedic and anesthesia, they went over there. And the third round is internal medicine and pediatric, they come to there. For our lesson learned from the Atapu is the southern part of the Laos, And we have attended the HM course with the art project. What we have done is SOP and strategic already done. So for the action plan for training, EMT training, the one of the strategic. What we will do, or what priority in the EMT training? The first one is strengthen national EMT capacity. Second one is establish provincial EMT and strengthen their capacity. For the strengthen, we are focused on the 2 points. The first is develop training curriculum, and second is conduct simulation exercise. For things we will activate of the training curriculum. The first one is develop training by the trainer. Second one, conduct TOT. Third one is identify, train junior medical. And the last one, annual refresh. For the simulation exercise, two activities gonna do in simulation. First, develop exercise material and conduct simulation exercise. For the second priority in our action plan is establish provincial and strengthen their capacity. We will work on at the 4 points. The first one establish, and second one is training. Third one simulation, and the last one is monitoring. For the establish of the provincial level, we express at least the 1 team for the 1 province. We have the total is for 17 province, but at least we will have the one team for the 1 province. Second, we are not our SOP in the central levels can use in the provincial level, but we will adjust SOP for the provincial level also. And for the training, a little bit difficult for provincial level. Will they have a training as a central level? We have two challenges in the provincial level. Some because their capacity, or some because their knowledge skill. That's why we will make the other curriculum for the provincial. For the conduct simulation, and that's one also as a we are same the member on the 1 team, but for the material we will design example like in the central hospital. Maybe we will have a 5 day for the course, but in the provincial level maybe will be the 4 day example like that. And the second one is deliver simulation exercise. On off the action plan, we are designed to start from the 2020 until the 2026. So for the monitoring is a key to get the results from each activity. Terima kasih.
Thank you, Dr. Urawan. Any question? Dr. Ching, please.
Thank you. It's a very good lesson that from Vietnam we learn from you, right? But during your presentation, you mentioned about the three that EMT. First one, you Taiwan may classify by WHO, and second one, international EMT, and also last one, you have professional EMT, right? So it's what the different three, according to my understanding.
Okay, thank you for your question. But for my presentation today, I am talking only the national EMT. That's why we will separate only the two types. The first, two level. The first level will be at the central hospital, and the second will be the provincial hospital level.
So it's, the provincial EMT that are like a national EMT, right? The same level, but located in the province or no?
For our healthcare, we we have the five level. The first level we call the central level, regional level, and provincial level, district level. But on that time, we, as I mentioned previously, our action plan will cover now. We will cover start from this year until the 2026. So we are planning to got in the central hospital to have EMT, East Hospital. Totally, we have the five hospital, central hospital. And after we are finished, we are done on the EMT in the central level, we will expand to this to provincial level.
Thank you.
Thank you. Any question? Okay, no. I don't know I should ask question or not, because at the lunchtime she said to me, please don't ask me a difficult question. But I think you present very well. Okay. Okay, so if no question, thank you, Dr. Ulawan. And for the next presentation from Ms. Radin Haliati, she will present the challenge of Malaysian nurses in disaster training. Dr. Radin, please.
Bismillahirrahmanirrahim. Assalamualaikum and a very good afternoon to everyone. Thank you to the moderator, to the Secretariat of ASEAN Academic Conference, and to all the delegation. My name was given as Radinur Adriana. I'm a matron in Emergency Department Hospital Kajang that's stated in Selangor, Malaysia. My topic is challenges of Malaysian nurses in disaster training. I have no conflict of interest to disclose in relation to the presentation. This is content of my presentation. Okay. The Malaysia is not located within the Pacific Ring of Fire, which is known for earthquakes and volcanoes like Indonesia and the Philippines. Although outside the Pacific Ring of Fire, Malaysia is not spared from natural disaster. The terminology, disaster, the severe disruption that causes extensive damage to people, property, and the environment, surpassing local resources for recovery. Widespread losses that are too much for the affected community to handle of its own, like human, physical, economic, and environmental. In Malaysia, we experience some of disasters as follows. A collapse of Penang Ferry Terminal Bridge that happened at 1988. The number of killed is 32 person, affected is 1,674. Sungai Buloh fireworks factory explosion, 1991, 22 numbers of killed and 103 affected. Fire and explosion with risk, the oil tanker Chun Hong Klang, 1992. Collapse of Highland Towers lead to landslide. In 1993, 48 people killed and more than 1,000 people affected. Karak Highway landslides, Post Dipang mudslide and Aborigine settlement village is 1996. 44 people killed. Tropical storm Greg lead to the floods hit the west coast of Sabah in 1999. So 302 people are killed and more than 4,925 people 25 houses are affected. In 20s, we experienced the earthquake causes tsunami and subways coastal region of Peninsula Malaysia in 2004. Flood in 5 states nationwide in 2007, 17 killed and more than 10,000 affected. Landslide of Anich home in Langat, 2015, and 16 students are killed. Sabah earthquake in Ranau, 2015, 18 people are killed. Kim River toxic pollution, 2019, more than 16,000 affected and 2,775 hospitalized. Pandemic of COVID-19 2020 until 2021, more than 40,000 people killed and more than 3 million are affected. Then last, the recent one is Batang Kali landslide 2020, 31 people are killed and 92 entrapped. Okay, the disaster nursing in Malaysia. Disaster nursing is an emerging specialty, and Malaysian nurses are encountering challenges in disaster management, including training which require attention. The urgent need for specialized and highly skilled emergency medical response teams is evident. There is a pressing requirement to establish an integrated, coordinated and systemic policy and mechanism for medical and health-related disaster management. We do have a training that we call a Medical Emergency Response Training, MERT. The Ministry of Health Malaysia conducts annual scheduled training meeting known as Medical Emergency Response Training, which involves emergency nursing and medical personnel, including staff nurses, doctors, and assistant medical officers. Okay, the objective of the MERT training is to ensure the efficient delivery of emergency medical response which follow the standard national disaster response framework, to enhance Ministry of Health Malaysia capacity for emergency health and medical response, to establish a well-coordinated integrated medical response system that support local and state authorities in handling major incidents and disasters, and 4, to train healthcare personnel specifically for crisis and disaster response, ensuring they are readily available for on-site patient treatment and providing technical guidance. Okay, after the training, the emergency medical response team is MERT team to provide frontline response by delivering immediate assistance for the victims. To save lives, a swift and effective response by trained personnel is required. Especially a trained medical rapid response team was formed to assist and supplement the local medical responses when the need arises. So this is a MERT training available in Malaysia, which is under Ministry of Health Malaysia, and probably for me to show the batch of the training. So we got B-MERT, A-MERT, MyRay, and T-MERT. T-MERT training includes basic emergency medical response training, advanced medical emergency response training, medical air evacuation response training, and training for trainers, MERT. Okay, now we concentrate to the basic medical emergency response training, BMET. Basic disaster training exposes personnel to the situations that closely simulate real-life incident. It's officially started from 2012 until now. It's collaboration with multiple agencies such as Fire and Rescue Department Malaysia, Civil Defence Forces, Armed Forces Malaysia, RELA and Royal Police of Malaysia. Training is held 2 days and 2 nights continuously with 6 CIMAX and 4 tabletops. Okay, the 6 situations that closely simulate the real-life incident, we are created road traffic accident, mass casualty incident, night rescue, collapsed building, water confident, and also the landslide. The objective is to expose and experience the personnel to the nearest serial incident situation and also to assess the response and management of the personnel towards the incident. It includes theory session, skill station, tabletop exercise, simulation exercise, and also a water confident. Okay, the data collection. The data is collected from the participant who attended BMET in 2022. The data collected through post-evaluation forms from participants who attended BMET courses throughout the year 2022 was analysed to determine the composition of the participant based on their professions. So in Malaysia, just now I said that the BMET is mainly for, not mainly, it's open for the all the professions, but I just take medical officer, assistant medical officer, and also the staff nurse. The training was we do in all states from Perlis until Sarawak, and the total of the participant who attended for the 2022 MOs medical officer is 41, assistant medical officer is 84, and the staff nurse only 17. So we can see the huge differences between AMO and the staff nurse. Okay, what are the challenges that the Malaysian nurses facing? First one, the issue of overcrowded in emergency trauma department, the worldwide issues. It become worse for the hospital in the urban area. For the information, the picture is show the real situation in my red zone hospital Kajang. Usually our bed capacity mostly 95 to 80, 100% utilization, and also length of stay patient in emergency department more than 4 hours is around 80 to 90% at the total of the patient. So patients in the emergency and trauma department are experiencing prolonged bed confinement. For that, there is a high need for additional nurses to care for patients in the emergency and trauma department. Okay. From the problems in bed lock and the long stay of patients in the emergency department causing the nurse manager not to be able to allow the nurses to attend the training because it will interfere with the actual work in the department. For now, for the education, formal education for the nurses on disaster training in the nursing curriculum. For now, learning related to disaster training is just an introduction and need more detail about disaster management for the nurses. Okay, education training program in disaster awareness, proper training for nurses to know the roles of nurses in the department, especially in responding the incident site. So, from the issue, frequent disaster education and training for in-service nurses. Why I say in-service nurses? Because from the basic nursing curriculum, we don't have formal training. So, with the nurses who working in the emergency department need to expose that we are facing the problem not to be able to join the disaster training because it take a long time, and also for the capacity of the beds for the high needed care patients in the department. So, okay, my recommendations: support the improvement in nursing disaster core competencies by nursing managers. So evaluate the limitations, knowledge and skill related to disaster management in order to receive disaster preparedness education as continuous nursing education. Allow the nurses periodically take part and participate in emergency response drills and disaster management training in order to be prepared for disaster. So develop a personal disaster plan to arrange matters related to disaster management. Be prepared to make ethically challenging decisions because during disaster, the routine method of nursing care are changes. Conduct periodic disaster management training programs for all nurses and healthcare professionals to extend their awareness around disaster management. So, such as frequent disaster education among nurses, tabletop exercises, disaster drills, and conducting sessions for routine disaster scenarios. For the curriculum as a formal education by nursing managers, providing nursing curriculum with the nursing disaster preparedness and management subject to prepare undergraduate and postgraduate nursing students to manage the disaster. So, to my conclusion, further formal disaster preparedness training for nurses should be promoted through support and awareness programs with a focus on involving nursing managers to support broader training in this field. The development and expansion of disaster nursing in Malaysia can significantly enhance overall disaster response, particularly within the Ministry of Health Malaysia. And then, thank you.
Thank you, Mr. Radin Haryati. Any question from the floor? I think this a new challenge. I think the same problem in every country. Yeah? It's the same problem in every country. Yes. They have a lot of work, too much work. My question is, when you train the MERD, MERD and MERD, you train in team. Each team composed of doctor, nurse, or the participant to train the MERD should come by team or individually.
Okay, before this, I think after we make some changes or some what we call, we are going through the modules. So last time we promote the team. One hospital must send one team, included emergency physician, AMOs, and also staff nurse. Now we open for everybody. Once we open the training, everybody can just submit their own names. And also one more thing, I want to say this. Our training is got the payment. We got the fees. Okay. For the BMED now, the fees is RM 350 per session.
That is a problem.
Yeah. Also the problem.
Dr. Kylie, you know this problem already? Okay. Okay. Any question? Please.
Good afternoon. Thank you for your presentation. It was mentioned earlier about the shortage of nurses. How does your government address that challenges in order to somehow limit the brain drain regarding nurses going to other countries?
Okay, thank you for the questions. For the shortage of nurses in Malaysia, we have assistant medical officers. So, if a disaster preparedness or disaster response, if the nurses is not enough, we are sending assistant medical officers to go there. For time being, the nurses which cannot be attend the training, we will do a short course in the hospitals, like awareness of disaster training in the hospital or in the department.
Okay, thank you, Ms. Radin Hariati. Thank you. And now we already have 5 presenters already, and my boss, the lady behind me. I think she's so tired she needs a break, please.
Thank you very much, moderator. Delegates, ladies and gentlemen, we are in for a long session today. This is a marathon, not a sprint. So to make sure that we don't run out of breath, we're now taking a 5-minute break to allow us all some time to sort of stretch out, get the circulation going, maybe go out for a bit for a fresh breath of air. We hope to see everyone back in 5 minutes. Thank you very much.
The next song we're going to do is a song by a really good friend of mine. He's actually featured on my original Black Radio album. He co-wrote and sang a song on there called "Oh Yeah" by my friend Music Soul Child. It's entitled "So Beautiful."
Distinguished delegates, ladies and gentlemen, may we have your attention, please? It's time to come back in and continue our session for the afternoon. Once again, may we notify our participants out there, it is high time for us to continue on with the rest of the agenda in order for us to make it in time for session 3 later on in the day. Once again, delegates, ladies and gentlemen, inviting all participants of the conference to return, please, and take your seats. Thank you. Distinguished delegates, ladies and gentlemen, welcome back. And now with full throttle, may I hand over the continuation of session 2 to our moderator, Mr. Muffin, or rather Mr. Fumin Silapunt. Mr. Moderator, please.
Thank you. Now we come to the second half of session 2. And we still have the 6 presenter. I would like to start from Mr. Muhammad Ali Shabana Yassin from Brunei. He will present evaluating the necessity of EMT training and development in Brunei. Please.
Thank you, Dr. Pumin. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang and a very good afternoon to you all. So my presentation today is touching on the training of EMT and disaster health management in Brunei Darussalam. I myself is an emergency physician, and I also act as the deputy chief for the clinical management of pre-hospital services and the ambulance services as well. Just would like to set the disclosure that there is no conflict of interest with my presentation today. So the outline of my presentation this afternoon is I'm just going to talk about the disaster profile of Brunei before going on to describing what kind of EMT training and DHM training that we have in the country. And from that on, I'm going to explain to you what challenges that we are facing back home in developing EMT training and also DHM development, and what our way forwards are. So before we go on the major content of what I am here today, that is the EMT training, please let me share with you a bit of a brief introduction on an overview of the disaster profile of Brunei. Because I believe that much of the slow progress of the development of disaster health management and the speed of the EMT training that we have in Brunei is particularly linked to the fact that Brunei has no major disasters, and also we are deemed as having a pretty much low risk of getting significant disasters. As my colleague in the morning session has explained to you, Brunei is very small. So it only consisted of about less than 500,000 population, and it is only one dot in the Borneo Island. Brunei is located in a unique area spared from natural disasters. And even though it is located close to disaster-prone areas, the Ring of Fire, there has been no records of significant disasters related to earthquakes and cyclones. However, we are still susceptible to minor disasters such as floods, landslides, forest fires, air pollution, and haze. And with the increasing expansion of our petrochemical industries, we are also facing an increasing risk of industrial and chemical-related incidents. That's why most of our training aspects for our medical rescue team is focused on managing and responding to man-made disasters, major medical emergencies, and also mass casualty incidents. If you can see, these are the pictures taken from previous flooding incidents over in the remote rural area, and you can see that our Sultan frequently visited the affected areas as well. So in front of you that here, these are the trainings that we have in Brunei that are specific to disasters. As such, we do not have an official DHM or EMT training curriculum, but we do have multiple aspects of training that can be linked to disaster health management and EMT. We have the major incident management course, the incident command system, again with the simultaneous introduction to the Brunei National Standard Operating Procedures. So this NASOP is the SOP that guide Brunei and other multi-agencies and multi-stakeholders in Brunei on how to manage and respond to a disaster in the country in a multi-agency collaboration. As such, because of the increasing expansion of our petrochemical industries as well, we do focus on hazmat management for our medical rescue team. And of course, we do have frequent, regular exercises and drills, which I think at multiple levels, multi-tiers, and multi-agencies collaborations, both government and non-governmental sectors. The first one is the major incident management course. Again, we do not have a disaster health management committee at the moment, currently in Brunei, but we are working towards establishing a dedicated disaster health management unit in MOH. This MIMC course was organized by the pre-hospital emergency management team. It is conducted every 2 years. We have already conducted 2 courses, and the last course was just before COVID. The target participants are including doctors, nurses, paramedics, allied health professionals, and also support staff as well. For each course, we are opening up to a maximum of about 20 to 30 participants. The curriculum consists of a 2-day workshop, which includes a series of lectures, practicals, and hands-on sessions, again with the tabletop exercises and mini scenarios as field exercises as well. So the objectives of this MIMC is for us to be able to provide the participants, for them to be able to describe the response to a major incident in the country. Again, touching on the command structure, which is very important in any incident management. The roles and responsibilities of focal people or focal person in that command structure, and also touching on the responsibilities and roles of other non-MOH agencies, such as the Royal Brunei Armed Forces, the fire and rescue teams, and other NGOs and all that. Explaining the activation process if there is indeed a mass casualty incident. Again, for the students to be able to describe the organization of operations at the incident medical post on scene. Demonstrate the process of triage and evacuation of the casualties on site, and also touching on the logistic management, procurement, again, deployment and allocation of resources on site. Again, touching on the importance of an effective communication when you are out responding to an incident, and also psychological support that is available to the field medical teams as well. So these are the objectives of our MIMC. So just a few core samples of our MIMC is, of course, we are leaning for focus on the CSCAT principle, touching on the command and control, safety as a whole, communications, assessment of the incident, and assessment of the casualties. That will involve the triage, treating them, and transporting them to the appropriate facilities. Again, as I said before, teaching them on the command system, which is going to be used on the field, and also what kind of triaging or modified triage system that you need to use on the casualties on site. The other disaster-specific training that we have in the country is where we are getting this incident command system. The incident command system is not organized by the Ministry of Health. It is coordinated by the National Disaster Management Center in collaboration with a non-governmental training center, which is the CAE, Multipurpose Training Center. So the CAE MPTC was founded in 2014, I believe, and it is an emergency management and crisis management center of excellence in the country. So they do offer general courses in relation to general management on disaster, not specific to disaster health management. For the ICS 100, we've got a few classes that runs every year. And for the higher level of ICS, 200, 300, and 400, they are based on request, based on NTMC and through our Human Resources Department in the Ministry of Health. The target participants for these incident command systems are basically everyone who are at all levels, strategic, operational, and the tactical levels. And the target participants are all agencies involved in disaster management. As I said, this is not much of a disaster health specific, but a general disaster management as a whole. And each class will have a maximum capacity of about 20 participants. So just a brief overview of the ICS 100, 200 until 400 is basically introduction to the incident command system. Explaining what are the key principles, roles, and responsibilities of people in the incident command system, and this includes the communication and the chain of command. And as you go higher up, it is more touching on the supervisory role and also for those who are at the decision-making capacity. The other third course that we have, and this is organized by the Ministry of Health, is the Hazmat Decontamination course. This is organized by the Medical Hazmat Committee, and the first course was conducted in 2014. This course is conducted every 1 to 2 years, and we have successfully conducted 5 courses altogether all over the country. And the last one, again, was conducted in 2019, that is before the COVID pandemic. Again, the target participants for this course includes doctors, nurses, paramedics, the allied health professionals and support staff, and one course, and each course will take up to a maximum of about 44 participants in one go. And the curriculum, again, consists of a 2-day course. It lasted for 2 days. Again, series of lectures, practical hands-on on the decontamination process and the PPE. And of course, there will be assessments as well. The course objectives is to raise awareness of potential hazmat emergencies, providing the healthcare providers the necessary knowledge and skills to manage, especially mainly the decontamination of hazmat casualties before they enter the hospital. Enhancing the hospital's major medical emergency preparedness and response towards this type of incidents, and to maximize the capability of hospitals in managing this response towards toxic industrial chemicals, which is used in the various industrial plants in Brunei. The content and the module will include introduction to hazmat and what are the toxic chemicals and how to identify them. Activation process of the hazmat response team. The management of hazmat casualties involving basic clinical management, detection, and also life-saving procedures. Teaching them also on a module on hazmat PPE, decontamination process, and of course logistics and the setting up of the decontamination tent and other equipments. We conduct a lot of regular, frequent exercises and drills. And although Brunei has no major disaster before, we do conduct a lot of disasters and exercises. This is the tabletop exercises at the Ministry of Health at the management level and also the strategic level. Again, we are having tabletop exercises at the operational level at each hospital. Again, testing their major medical emergency plan, inclusive of the hazmat response SOP as well. This is part of our national field exercises. I think this scenario was an airplane crash into a very densely populated residential area. And again, multi-agency collaboration with an aspect injection of hazmat incident as well. This is fresh from Brunei today. We did have a field exercises this morning, and this is part of the pictures from this morning. Other supporting trainings, of course, your basic life-saving courses, trauma, injuries, and also basic emergency care, which is wound care, fracture management, and acute area management as well, as part of supporting the EMT capability. Regional trainings, again, we are sending people off because, of course, because we don't have any experts in DHM in the country, so we are sending selected healthcare workers overseas, kind of like a training of trainers as well. So where do we go from here? The pre-hospital management has proposed a teaching EMT training curriculum that is based on general, clinical, operational, and continuous assessment area. And we noted that we haven't got a lot of the areas covered in Brunei. Challenges, of course, the lack of awareness at multiple levels in the management. There is no denying that there is support from the management, but DHM can easily get overshadowed by other priorities in the ministry. Lack of local DHM experts. Instructor pool is also very, very small, and you can see that the same instructors are the same instructors for most of the training program. Lack of supervising body, multi-agency involvement is also a challenge in developing EMT training program. And also we are lacking of real-life experiences as well. So the only real-life experiences that I can think of is possibly during when we sent a couple of doctors off to Aceh as part of the Royal Brunei Armed Forces mission there. Way forward, again, action plan 1, we need to increase our awareness to disaster. Education curriculum, probably inclusivity of the disaster program in nursing and paramedic curriculum in the colleges and universities, and also looking at the governance of the DHM in the ministry. Action Plan 2, training of trainers, we are increasing that. International experts, collaborations, and other collaborations with other international and regional team. Multi-specialties and multi-agencies, we need to strengthen our collaboration with them in terms of EMT training. And of course, to keep on continuous assessments and reviews of the exercises and drills and make necessary actions from after-action reviews. That's all. Thank you.
Thank you. Any question? Okay. Sorry, because the time is over. So I think we should forward to the next presentation. Thank you, Doctor.
Thank you.
And the next presentation from Ms. Lapipon Rojana Sangryang from Thailand. She will present about competence assessment of the emergency healthcare providers trained in basic disaster health management course in Thailand. Dr. Lapipon, please.
Okay, good afternoon, ladies and gentlemen. I'm Dr. Rapipon Rosangryang from Thailand. I'm the Chief of Emergency Medicine Department from the Faculty Medicine of Wachira Hospital, Nawamintara Thirat University, Bangkok. I have no conflict of interest. In the past, JICA and NIM collaborate to establish the ARC project in the 2015 and 2017. The Thai side of the ARC project developed the basic disaster health management course, and we teach around 3 times before going to the Surat Thani province. Because in the Surat Thani province, they face with the flood every year, and this year in the Surat Thani province, my team developed the research for evaluation the cost. The objective of research is to evaluate the basic cost using MCQ, self-assessment, performance checklist, and after-action review. The method is a big method study. We randomize the 65 healthcare providers in the Surat Thani province and divided them into 5 groups. Each group consists of the drivers, emergency medical technicians, nurses, and doctors. And we did the 2 parts. Part 1 is a quantitative study and the part 2 is the qualitative study. Part 1 quantitative study, we did the baseline characteristic, and following the schedule first day, we asked the participant to do the pre and post test after the lecture. And day 2 and day 3, we asked the participants to do the self-assessment after the small group discussion. Day 4 and day 4, all day, we do the tabletop exercise in the morning and field exercise in the afternoon. We ask the trainer or instructor to do the performance checklist to evaluate the skill. And the last day, we did the after action review together. This is a schedule. That means following the first day is a lecture to orientate and the teach about the knowledge for the basic. And following the day 2 and day 3, we did the small group discussion, and in the day 3, we separate in the 2 rooms. One room is for the doctors and nurses. Second room is for the paramedic and EMT because they have the different basic knowledge. And day 4, in the morning, we do the tabletop exercise, and afternoon we do the field exercise, and last day we do the after action review. This is all of participants to join the class. The majority of participants were nurses, around 35%. Secondly, it were paramedic, 23%, and doctor, 19%. The majority of the participants had no experience in the disaster, around 71%. And after the lecture, the post-test showed the mean score around 19. In the total point, 20 points. That the mean score from the post-test showed different as significant p-value less than the 0.05. Small group discussion, the participants did the self-assessment, and self-assessment show the topic that can enhance knowledge of the participant were the ICS and lesson learned, around 74%. And instructor assessed the performance checklist in the tabletop and field exercise. Following the tabletop exercise, overall performance showed the mean score above the 4 point, following the like a scale. And overview in the field exercise just show only the mean score 3.8. Part 2 is a qualitative from the after action review. The participants appreciate the course because the course show how to manage, how to organize the chaos, that they appreciate the course. And they appreciate lecture out on the first day too, because senior one has a different background. Lecture out should be held on the first day. And they appreciate about the tabletop too, because tabletop exercise can alert them about the difficulty that they can face in the field exercise. Following the recommendation, they don't like to separate the room because they said they need to work together, that they need to know all duty for the team. And before participating in the tabletop, they need us to show out every duty room for a tour to remind them again before jumping to the field exercise. Before jumping to the exercise and tabletop. And they say tabletop and field exercise should take place on the different days because it is so tired. The conclusion, the lecture improved the knowledge as significant. The small group discussion improved mostly in the ICS and lesson learned from the student self-assessment. And following the tabletop and the field exercise, instructor assess the performance skill, and tabletop improve overall performance above 4 points in mean. And overall performance in field exercise show mean only the 3.8. After action review, the course reached the goal because the participants appreciate and then learn a lot about the system and framework for organizing chaos. And they like the lecture on the first day. And they like the tabletop because that can make them to find out the way to face with the field exercise. And from the recommendation, they like to learn together in all topics. Don't separate between the MT and doctors because they need to learn together. And actually, the course is point to the management cycle more than the treatment knowledge. And they need the demonstration desk to add on the course. And they would like to separate the tabletop and field exercise on the different days and need to invite more agencies to participate in the training. Thank you for all, for your attention. And thank again if you don't have any question.
Thank you, Ms. Dr. Rapipon. Any question from the floor? She just kidding. She want a question. Please.
No
I see
kidding.
a lot of hand.
No kidding.
Mr. Ikeda, please.
Thank you, Dr. Murappong. I'm sorry that I'm also the one of the presenter, but I have the one question for the clarification. According to my understanding, your BDH course is a local course targeting for the training of the prefectural level or district level in Thailand. But on the other hand, as a leadership of the Thailand, the Thai people, Thai member, the leadership of Dr. Pumi and Dr. Pumani, you developed the big course as an ASEAN standard curriculum, which shall be applied for each country, including Thailand. And I would like to ask you, what is different between your local BDHM course and the big mock-up, big course? According to the presentation by Dr. Pumani, you have 12 modules, and I don't know your case, how you modify what is different and what is the relation between those two courses? Thank you.
Before applying the course to the Thai people, we add the lecture out for the first day. That to orientate and teach the basic knowledge. After that, when they jump to the small group discussion, they have the basic knowledge to join and talk together. And the small group discussion is the same like B course for the ASEAN. tabletop exercise is like because like ASEAN course. Following the field exercise, Dr. Pumalin and team and Dr. Pumin delete the field exercise because it's a costly. But in the Thailand, I think field exercise can make them to face the real more than the tabletop. That the field exercise show it enhance a little bit because when they jump to the field exercise, they need more skill and knowledge. That is a in-depth, deeper than the tabletop.
Thank you.
Okay, I am ready to answer.
And in the BDSM course for ASEAN, we have the lecturer from other countries, not only Thailand, such as Singapore. And Dr. Pumalin, can you help me? For the local training, we have only Thai lecture.
Thank you, Dr. Pumin. I would like to say that this is the example of the implementation of the B course. So in each country, they can improvise, or if they believe that some activity is better, so they can put it into the B course. As in the B course in Thailand that I mentioned before, at first, actually, the 9 module of theory is still there, and the lecture, first the day 1 lecture is complied to all of the 9 theory, and yes, because we are afraid that Thai participants maybe they are not keen to do the self-learning by themselves. So if we are afraid that, so we give them the lecture, and we think that in the planning process of the course, we think that okay, we can add more the field training because we have some budget left over, and we want them to make more exercise and face with the real life situation. This is why we are put more to the B course. However, when we consider to application this course to another countries, and maybe the budget is not available, so we are that's why we reduce the B course for the mock-up course to test that is it available, is it feasible to imply to the other country or not, and if it's not enough, so you can put more. For the budget, as I present, the $150 packs of this course is not included in the field exercise is not included, so it's just only 3 days of the B course in Thailand. Thank you.
Okay, thank you. Any question? Okay. Okay. She said you have more 4 minutes, but I know you don't want to have that 4 minutes. Okay. Okay. So thank you, Mr. Rafiwan. Give him a big hand. And the next presentation, I'm proud. This by the Dean of Faculty of Medicine, Public Health and Nursing of University Gajah Mada, Dr. Jody Mahendra Hatta. The presentation about the introduction of disaster health management curriculum in pre-service education, students, and strategies for the future. Please.
Okay, good afternoon, everyone. So I've been asked to share with you our experience in trying to introduce the disaster health management curriculum into pre-service educations, which is quite challenging because, as we know, the curriculum of all medical school is quite packed already, so it's very difficult to actually insert additional things inside the existing curriculum. So it's a struggle, but it's an ongoing process. Now, I don't have any COI, and well, this slide summarizes my whole presentation, actually, this picture. If you look at the gentleman here on your right, that's the hospital director of the provincial hospital in Banda Aceh, which was struck by a tsunami in 2005, where 200,000 people were killed. And he doesn't have any staff because all of his staff were either missing or died or evacuated somewhere. So he was alone with his deputy director for finance in the middle, Ibu Chut. Now, over there, the third one is a junior doctor who looks very lost. Looks very lost because he's a junior doctor. That was his first mission sent to a disaster in tsunami, and he has no experience whatsoever, and he doesn't know what to do. But he was sent there. His name is Yodi Mahendra Datta. That's me. Maybe it's difficult to recognize because that's 18 years younger and 18 kilogram lighter. But just to highlight that experience, it's really life-shaping, life-changing, because it is then that I realized that it's unacceptable to actually have a medical doctor who is not ready to serve in disaster if you are actually living in a disaster-prone countries like Indonesia. That's simply unacceptable. But it simply was not in the curriculum at all. So I was not prepared at all, so we was learning trial by error. So that was quite risky. But that's what happened in 2005. This is 2018. These are our students, which we sent to North Lombok during an earthquake. So these are medical students and also some MPH students, which we send along with our disaster response team, and they assist for recording, reporting, and also other tasks which are in line with their current studies. And they really appreciate this learning experience, and all of them have graduated now, and they are now working either in hospitals or health offices, and until now they still consult with us if there are any disasters which struck around their area. And so that becomes a strong network. So that's quite a long period, a journey between 2005 and 2018. So what I'm going to share with you is just a brief introduction and the milestones and our curriculum and how we integrate it and what are the challenges and strategies. So what we realized that based on our experiences in tsunami, earthquake, volcanic eruption, and so forth, we experienced firsthand that disaster health management is multidisciplinary and practical field. Now we are fortunate that we are not just a faculty of medicine. We are a faculty of medicine, public health, nursing, and nutrition. So we have already multi-profession within our school, within our faculty, and that helps us to prepare the student for multidisciplinary, for multi-professional in the field. And we realized that disaster management cases are suitable to be part of student learning curriculum to introduce roles and competencies of coordination and leadership, because that's what called for in disaster, you need leadership. And as Indonesia is one of the most disaster-prone countries in the world, and we have been involved in disaster response, and we have been actively engaged in various disasters, so we decided then to make an effort to try to integrate this. And this is how we tried to do it. So in 2010, so 5 years after the tsunami, we finally managed to actually insert it within the curriculum. After 5 years, we introduced it into the curriculum of the medical, nurse, and health nutrition students. Our curriculum is problem-based learning, so it's not traditional lectures, so we use problems to stimulate small discussions, small group discussions, and also self-directed learning, and that's how we integrate it. That's in 2010. And that was in the medical curriculum. We placed it in the last year, just before they graduate, and the 7th semester. And in 2016, we then strengthened that further by introducing household disaster preparedness under a longitudinal program, which is Community and Family Healthcare Interprofessional Education, the CFHC IPE. The CFHC IPE is a longitudinal program in which medical students, nutrition students, nursing students get together to learn modules, and one of the topics is disaster preparedness. And then in 2017, our health nutrition study program, they add an elective on health nutrition disaster management course. And 2023, now we are going to integrate disaster management longitudinally from first semester until the last semester. And this is just an overview of what it looks like in practice. So it basically consists of, as I mentioned, a problem, a case, and then to be able to resolve that case, then they would need support. They would need to draw from lectures, tutorial, practical sessions, and also skills lab. Now, even though it's already action-oriented, it's still very difficult for students to imagine a disaster on paper. So we tried to bring them closer to practice by having exhibition, a whole week of exhibition on disaster management, which we bring in disaster experts, disaster actors, to go into campus, have an exhibition, shows what they do, and also what all of the equipments that they have to make it more lively for the students. And then this process contributes to prepare for to be deployed in disaster response. Now, we try to integrate field experience into our disaster response team, and that's what I showed in the beginning. So every time there's a disaster, by default, we try to think, what is the possibility to bring our students into this disaster response? Of course, we have to think of the safety issues and all of that, but that's by default. We need to think to what extent this is, because it's a really valuable learning experience for students to be part of these teams early on. It's a really good early exposure. So we send them, of course, under supervision, and of course, after taking into account safety concerns and so forth. And we've been doing it for several years now, taking our students to the field, to these disastrous areas. What are the challenges? Well, like in any institutions, I think the numbers of instructors or experts in disaster health management is limited. So we don't have much. We have a small team who are very passionate about disaster health management, but the number is still few. And then if you look into the curriculum in universities in Indonesia, there's a wide variations of disaster across the curriculum, because we don't have yet a standardized curriculum across the different campuses in Indonesia. And there's not many parties who are really interested in advancing disaster health management, so it makes it difficult for us to actually obtain additional resources to move forward with disaster management in educational setting. And what are the strategies? We now have a policy window. We have a momentum because the government has just issued a new health law, number 17/2023, which is an omnibus law. It's overarching, it's very comprehensive, and it has a lot of disaster issues integrated into it, including the health reserves, which Ibu Ina is going to mention afterward. So there's a lot of requests, a lot of needs, a lot of demands of disaster health management embedded in the new health law. So we're going to develop the disaster health curriculum based on professional competencies, and we aim to develop cross-cutting competencies so that health professionals, be it nursing, public health, medicine, can work together in harmony. And we aim to synchronize disaster health curriculum in congruence with national disaster policy, because now we just try to incorporate as we can, as much as possible within the existing curriculum. So that's the strategies, and we know there will be a lot of challenges to be able to do this, but we are very confident that we can move forward, because as of this week, we have many new friends to learn from. So thank you for coming to Yogyakarta. Thank you for being our friends. And yeah, we can count on for us calling you from now on and maybe asking you to contribute and also to invite you as guest lecturers and so on. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you. Please.
Thank you, Prof, for the presentation. My name is Henry from Universitas Samratulangi, Manado. maybe I would like a brief overview for maybe you have the interprofessional education for each of the medical students, the nursing students, and the public health students for this curricula. A brief overview if there is any interprofessional education in your faculty. Thank you.
Okay. Okay, I don't have slides or details with me, but I think we can get back to you, Bu Bella. We have the CFHA curriculum for IPE for disaster, so we can share with you, of course. But yes, it is very new. I think in many faculties they don't have it yet, and we are among the first one which try to initiate it. And it counts as credit, so it's not elective, it's not optional, it's mandatory. So all of the students, be it medicine, be it nursing, be it public health, be it nutrition, they have to take it. Yeah? But the details of semester by semester, we have it on file, we have it in document, and we can share with you if you wish, and you can have a look at it if you want to consider to adopt it in Samratulangi and Manado. Okay? Thank you.
Okay, please.
Thank you so much. Dr. Ching Kong from Vietnam. I'm certain, but also we have some problem like from that your presentation that I learned that you said that challenges that a few instructor, right? How you make that your student interested, you start to have management because they should be like a potential instructor in the future. In my country, for example, I'm working for the medical university, but always students, they show some, it's a field study to be also easier to apply the job, like a surgeon or doctor, something like that. How much okay?
Yeah. Okay, thank you. Yeah, so this is the situation now, but the situation is still improving. So there's an increasing interest. So what we have now are pools of graduates who graduated from the curriculum many years ago, like me, who didn't have that exposure. So that's why we have very few instructors, because it comes from 10 years ago. But now we have more and more graduates who are now exposed from early on disaster health management. So now we have a larger pool, actually, we can draw on. Of course, they're still very junior. And the challenge is, of course, that for those the juniors, the fresh graduate, they don't have much experience yet. So it's also a bit challenging for them to give instructions in campus, in classes. But we do tandem. So we have assistants. So we recruit assistants, the young instructors, and they go together with the senior ones. So if they are still inexperienced, then we can still mentor them so that as they go along, they can pick up the things which perhaps they did not pick up from campus. But I think as time goes by, there will be more and more interest. And with AIHDM, I'm sure there will be much more interest for instructors.
Thank you so much.
Welcome.
Any question? Okay, if that question. Okay, thank you, Dr. Jody. And the next presentation from Mr. Phubet Ploysawat. He will present about the disaster medical volunteer from Thailand. Please.
Okay. Good afternoon, everyone. My name is Phubet Ploysawat, Head of Emergency Medical Division, Julapon Hospital, Thailand. Today, I present training course disaster medical volunteer, DVM. Disaster in Thailand mostly occur due to flooding, fire, and massive road accident. When this incident happen, assistance to the affected individual come from two main type of organization: governmental organization such as hospital, the Department of Disaster Prevention and Mitigation, local administrative organization, and voluntary organization like volunteer from various foundation and association. Picture funding in Thailand happen every year. Fire and massive road accident. Okay. In Thailand, voluntary organization was first found by Chinese merchant aim to dedicate to people in need and unidentified corpses. Later, they began to rescue road accident victims and transfer them to the hospital. The voluntary organization is composed of people to come together to dedicate themselves to improving their society. In Thailand, there have been over 100 voluntary organizations that operate during disaster recently. When disaster have struck in the past, it has been observed that first responder, including doctor, nurse, paramedics, and volunteers, have voluntarily entered the affected area without sufficient knowledge and skill on disaster management, placing them in danger rather than assisting the victim. Julapon Hospital has therefore organized training course for disaster medical volunteer to provide medical assistance skill knowledge during disaster to those who are involved in emergency medical care, and to establish a medical response team ready to help the public during a disaster. The training program is 5-day and cover both theoretical and practical aspects. The course is consisted of incident command system, major incident medical management and support, team working, crisis management, disaster communication system, and medical response in various disaster scenarios, such as flooding, fire, chemical leak, and incident resulting from mass gathering. Picture training DMV course, CPR, and lighting and moving communication system, tabletop exercise, training, field training, flood and fire medical operation, rope rescue, command system. Okay, a total of 338 individuals have completed the DVM training as follows: 47 governmental hospital officer, 32 military officer, 51 local administrative organization officer, 42 non-medical officer from governmental organization, 166 emergency medical staff from non-governmental organization. All of them would like to prepare themselves for voluntary deployment in the future, even some of them are governmental officer. Out of the 38 individuals in Kusting, 11 doctors, 29 paramedics, 27 nurses, 22 emergency medical technician intermediate, 64 emergency medical technician basic, 99 emergency medical responder, and 36 non-medical staff. The 10 participants are all over the country as follows: 43 in Northern region, 177 in Central region, 27 in Southern region, and 91 in Northeastern region. The post-training assessment results show the following. First, knowledge and skill in providing medical assistance during disaster is 92.75% increase. Ability of risk management in various disasters is 91.257% increase. Confidence in providing assistance in an affected area, 39.8% increase. And preparedness for emergency operation has increased by 95%. The feedback from the trained participant is a great cost and want the training to be held all over the country. The training is very good fun, but also very exhausting. The training is intensive, but it is worth your time and applicable in real life situation. I like the training for basic water rescue and chemical incident because they provide actual equipment for practice. The post-training follow-up result. Volunteers are well prepared and on standby mode for 24 hours a day, 65%. And the assistant can be deployed within 24 hours after the incident occurs, 52.5%. Future plan for the DVM. To 10 DVM nationwide and create a tool or coordination structure for DVM. Thank you.
Thank you, Mr. Puppet. Any question? Okay, please.
I'm Dr. Nopuni from Bangkok, Thailand. And I would like to thank you for your presentation. And for the background, Thailand have lack of the healthcare worker to work in disaster sometime. But I appreciate for Juraporn University in dealing with the training course for the volunteer. And this volunteer is a main group for a long time for Bangkok to work with healthcare worker like a hospital in Bangkok and some disaster. And after that, we develop the knowledge to the volunteer. And then we try to make a quality to improve for the volunteer, right? Cost for them. And dealing with the hospital to qualify, look like emergency medical service, send the patient to the hospital. We have the records to feedback them about how they do well, how did you can do, and how you cannot do this like this. Okay. And for this presentation, we want to know that what is the topic that the volunteer interesting from this course.
Oh, okay. After attending DVM, we found that they interesting in the water rescue and fire operation, medical operation training, in scenario training. Okay.
And the volunteer interested in water training, like a scenario to train?
Yes. In this course, topic water rescue and fire rescue. The participant interesting this topic.
Okay. Okay.
Thank you.
Please.
I'm Dr. Kai from Japan. I'm very interested in the medical volunteer. I have a few questions. First one, medical volunteer is volunteer or commercial company, which, because you need a 5 days curriculum, you need a lot of money. Yes, you with how to manage that course, 5 days course, budget?
This cost budget for project. Okay. Thai government support budget.
Government support? Okay,
Yes.
Okay. And then including your lecture, one is a MIMIS course that licensed by the United Kingdom, and Eastern Common System licensed by the USA. And then the lecturer has some license, official license for that company. Your lecturer have this instructor license or not? Who authorized this course?
Chulapon Royal Academy.
Chulapon Academy
Yes.
authorized. Okay.
Yes.
Okay. Thank you.
Thank you.
I would like to explain more. It's just the very basic. For example, water rescue and fire, just make the participant know what happened, what to do. Not as an expert, to be special. Just let them make a dream. If they want to learn more, they need to go to the training institute that have the certificate, something like that. It's just a basic, because there is only volunteer. Some doctor in this course is not the emergency physician, but they would like to prepare themselves. If any disaster happen, they want to deploy, they want to help people, that they need to know what should they do in the disaster situation.
Can I ask a question? Shinji Egawa from Tohoku University, Sendai, Japan. And as you said, the medical doctors or nurses have techniques that, for example, the vaccination of the people when the emergency physicians are very busy to respond. So that kind of operation is in your vision or not? Water rescues and fire rescues are the firefighters' work or rescuers' work. However, medical profession, the volunteers have techniques to inject something to the patients. So are you trying to introduce such techniques into the volunteerings?
Mostly we focus on the safety. When medical personnel go to the flooding area,
sure.
how can they survive? Even in a fire situation, we not focus to rescue people for the water or fire.
Right.
But we to make the course interesting, and we let them wear the fire suit or some equipment, but we don't expect them to rescue.
Right.
Just take care themselves
Okay.
for safety reason, because they normally work in the hospital. They are not emergency physician, but they want to be volunteer when disaster happen. So we need to prepare them for the safety first.
Okay. I got it. Thank you.
Okay. Any? Okay. Thank you, Mr. Pubet. Mr. Pubet this is the first time of him. So as I mentioned earlier on my session, that I think we would like to engage all young researchers to involve in to do research together, because if we want to sustain our improvement on disaster management, we need to build capacity to the people, especially the younger person. And I think Mr. Pubet, you done it well, and I hope to see you again in next conference. Okay, Pubet? He really excited. Okay. Okay, now we go to the next session by the beautiful lady that we familiar face. Dr. Ina Agustina Isturini. She will present about the reserve healthcare workforce system in Indonesia. Dr. Ina, please.
A very good afternoon, everyone. It's nice to be here again. Okay, I would like to present about reserve healthcare workforce. As based on lesson learned of COVID-19 response, Indonesia government has conducted the health system transformation. And one of the transformation is about the health resilient systems. And part of the health resilience system is to develop health reserve healthcare workforce programs. And last year, me and my two colleagues, Dr. Hadijah Pandita in the back, and Dr. Widiana, I don't see her. Oh, over there. Yes. We were assigned to develop the concept of reserve healthcare workforce. And this afternoon, I would like to share our journey, how we developed the program, and how the framework of the programs. Yes, there's no disclosure of conflict of interest for this presentation. Yes, this is table of contents, lesson learned from pandemic COVID and natural disasters, benchmarking the system, reserve healthcare workforce system, and register reserve healthcare workforce in Indonesia, and conclusion. Yes. So many things that we learned from COVID-19 pandemic, and one of this that our experience to recruit the volunteers. Yes. The process includes announcement and opening the registration link, administrative selection, medical examination, and determination of selected volunteers through an assignment letters. It needed about 2 until 7 days. The sources of recruitment, fresh graduates, former volunteers from post-internship, etc. A total number of volunteers recruited in 2020 is about 6,000, and in 2021 is almost 14,000, and in 2022 is about 2,000. But the thousands volunteers that we already recruited, only 65.9 or 65.9% of our needs. Yes, we can see this for examples of types of health workers that we recruited since 2020 until 2022. General practitioners, specialists, doctor specialists, nurse, and laboratory worker. None of them that we recruit fulfill all the needs. All the needs, yeah. Especially in 2021, when Delta arrived in Indonesia, came to us, and we have extreme wave peaks, especially in mid of 2021. We can see in 2021, it's very percentage is very small that to fulfill the needs. And we also learn from many natural disasters in Indonesia, many big natural disasters in Indonesia. But because of limited time, I only show you a big disaster because of an earthquake. We didn't have the detailed data about the needs at that time, so we try to compare it with the ratio standard, in normal situation per 1,000 population. We can see this for the specialists. Yeah, the blue one is the normal ratio standard in normal situation, and then another colors represent many big disaster, big natural disaster because of earthquake in Indonesia. Padang earthquake, Tasikmalaya earthquake, PD Jaya, Lombok, Mamuju, and the last one last year Cianjur earthquake. What we see is we can mobilize volunteers multiple times than ratio standard in normal situations. So in natural disasters, there's no problems with the the number of volunteers, different from pandemic situation. And this is other type of health workers: general practitioner, nurse, midwife, pharmacist, nutritionist, and sanitarians. There's no difference. We can mobilize multiple times compared to ratio standard in normal situations. Based on this, what we learned, there were no major obstacle to mobilizing the health personnel in large number in natural disaster. Because if one area affected with disaster, we can mobilize from other area. We have 38 provinces right now, 38 provinces that ready to be mobilized to one area that are affected by disaster. The challenges is not about a number of volunteers. The challenges were in fast and precise response. as well as effective and efficient management. That's the problem in natural disaster. But different from natural disaster, the pandemic, there were difficulties in mobilizing health personnel according to needs due to the entire area was affected. The first cases in West Java, and then several months later, all of our province already affected by COVID-19. And recruitment process during emergency took time and it delay response. As I mentioned before, it needs 2 until 7 days that we need to recruit the volunteers. Yes. And we identify the root of the problems. First, there's no database. And second, incomplete standard for calculating needs. And third, there's no competency standard for disaster, competency standard for health workforce, I mean. And the majority of districts or cities don't have contingency plan. Even though in our regulation, the contingency plan already become the mandatory, but still it's challenges because the majority of district cities don't have a contingency plan. Oh yeah, for information, we have more than 500 districts or cities, yes. And then what to do? We need a management system to produce health personnels who are competent, can be identified and contacted quickly and easily when needed, and ready to mobilize whenever we need it, and can be carried out measurable monitoring and evaluation. That's the system that we have to develop. Yes. And the first step, we conducted the benchmarking. I think we have 20 benchmarkings, but I will show you 5 of this, national, international. And first, like medical research course from America, we learn the definition, the type of recruitment, and who the potential for recruitment, and then the competency and how the deployment, how the funding. We learn about this from many institutions, Medical Research Corps and Australian Medical Assistance Team, AUSMED, and then a military reserve component in Indonesia. Military already have a component cadangan in Indonesia, military reserve component. And then from BNPB or NETMA, or National Disaster Management Agency, they have also a voluntary system, and their specific voluntary system for COVID-19 by Satgas COVID-19. Satgas mean working group, yeah, working group, national working group. So these are half of benchmarking that we learn to develop the system. And benchmarking key findings first, the similarities. Most of them voluntary based, and there are core competencies as minimum standard, mobilized to support the main component. The flow of process, recruitment, capacity building and mobilization, and then the recruitment of non-health personnel to support the healthcare services. And the differences, the recruitment condition and funding are in accordance with the policy of state or sectors. We can see the differences funding system. And the main component of military is army, whereas the main component of disaster is assisting or local capacity is different. In military, the main component is army, and the reserve component is community. But in disaster situation, based on many benchmarking, the main component is existing or local capacities. And the reserve corps from other area. And deployment only in emergency situation versus deployment in preparedness, emergency and recovery situation is different, because like medical reserve corps, they can deploy in not only in emergency but also for preparedness and recovery. So, yes. And this is the framework that we developed last year, the concept of reserve healthcare workforce system, or we call it tenaga cadangan kesehatan TCK, in Indonesia call it TCK, yes. The reserve healthcare workforce is the human resources, teams or individuals, both health worker or not health workers, who are prepared to be mobilized in emergency situations of health crisis by natural, non-natural, or social, in order to strengthen the capacity of local health workers and health programs in the affected area. In addition, TCK can also be mobilized to assist the disaster risk reduction efforts. So we can see this, when there is health crisis, there will be response by local health capacities, and after the assessment, we can decide whether adequate human resources or not adequate human resources. If there's not adequate human resources, there will be mobilizing human resources. We call it reserve healthcare workforce to deliver the health services. Yes, this is the grand design. First, the registration in the pre-health crisis or pre-disaster situation. And we not yes, learn from COVID-19 also. We not only voluntary, but also we have the system mandatory based on the MOU between the government and the institution. It can be the source of the prospective volunteers. Yes, and then there will be credentialing, registration, and they become the database. And we web-based information system. The system automatically make the leveling. There will be pre-elementary, elementary, intermediate, and advanced. And after that, we can do the capacity building. Capacity building become the responsibility of national government and local government, and also work together with community. Yes, and then this is the mobilization. Hilang, disappear. Why? Sorry. In Indonesia, disappear is hilang. Yeah, you can. Okay. The show must go on. So the show must go on. Yeah, thank you. I think I need additional time because, no. Yes. Yeah, and then we have also mobilization system. The web base is centralized. Information system is centralized, but can be accessed by local government. So the database can be utilized by local government also. Yes. And this is the tier of level of reserve healthcare workforce, the description, and the required trainings. We make the concept about this. And we also make the reward system for the healthcare workforce. And then this is the data 6 days ago, because I submitted the presentation 6 days ago. Yes. And then already, since the launching on 21 December 2022, there are more than 12,000 persons registered as reserve healthcare workforce. And we divide between team non-EMT and EMT team. Yes. And then, sorry. Yes, the conclusion. Reserve healthcare workforce is part of health transformation system, especially for health resilience. The framework consists of identification of potential volunteers, registration, capacity building, and mobilization. The program is carried out through web-based information system. The impact of this program will make the emergency response faster, more coordinated, and systematic. Thank you. And these are 3 of us who designed who was assigned to design the framework. Thank you very much.
Thank you, Ms. Ina. Any question from the floor, please?
Thank you, Dr. Ina, for a very interesting brief on the Health Reserve Force. I just have one question. Is there a proper structure in the Reserve Health Force such that who can activate the Health Reserve Force, and after they have been activated, actually who can command it and who can decide what they can do? Is it within the district itself, or is there an overall national structure whereby there is an overall commander that actually activates and controls the Health Reserve Force? Thanks.
Can I answer now? Mr. Moderator? Oh. Okay, thank you. Yes. The system will be integrated with health emergency system in Indonesia, health crisis system. We already have the health crisis management system. We have the disaster management system. It will integrate it. So in our system, the one who decided whether receive or not the health reserve workforce, reserve healthcare workforce are the local health emergency operation center. So who can mobilize? It can be national government or local government. But who can accept? The accept is the local health emergency operation system that in the affected area. So these are the database. They become the database, and we can utilize this, the national government and local government to mobilize this. Maybe can we see the mobilizing system, the grand framework of this, please? Okay. Yes. Yeah. After this, I will show you because there's bell ringing. I didn't I didn't explain much about the mobilization. Yes. Not yet. Only me in the screen. Yeah. Thank you. Sorry. I think this. Sorry. Sorry. Yeah. Yeah. Back. Okay. Yeah. This is here. And if rapid health assessment results show that need the mobilization of healthcare workforce, so the coordination to fulfill the needs of healthcare workforce by health cluster coordinator in the affected area, because we have a cluster system. The health cluster coordinator become the command or the lead of health emergency operation center, and then the system will give the notification by system notification to the nearest reserve healthcare workforce, the nearest, and they will answer by system whether they are ready or not, and then we can identify who are the nearest personnel that are ready. Before manually, if manually we have to contact them one by one, and they will answer, oh, I can't because I am abroad, I'm at Singapore or at there. But now we can it automatically by system, yes. And then the personnel mobilized to the affected area, assignment by the health cluster coordinator in the affected area. Okay, thank you.
Okay. Any question? Okay. No question because you explained clearly.
Thank you.
Okay. Thank you, Dr. Ina.
Thank you very much.
The next and the last presentation of this session come from the Myanmar by online. Dr. Nguyen Win Min, can you hear me? He will present, his topic is deployment of RRT, Rapid Response Team, and medical team to Cyclone Mocha affected areas to provide essential health care to population in Rakhine State. Dr. Winman, are you
Yes,
ready?
thank you.
Okay, please.
Thank you, Mr. Chair. Yes. So I will share the screen from my side. Good afternoon, distinguished delegates and colleagues. So first of all, I would like to thank the organizer for allowing me to present online. And so my presentation will focus on how the RT teams and ENT teams are crucially to provide the essential healthcare service to Cyclone Mocha affected populations in Rakhine State. So I have no COI to disclose relation to the presentation. As you know, Myanmar is very prone to the natural disasters and is facing the cyclone, floods, and landslides in every year. And in recent years, we have faced about major flooding events in 2015 and 2018. The very severe cyclone storm Mocha has made landfall to the Rakhine State on 14 May 2020 with the very high wind speeds, and due to the effects of the cyclone, it's caused damage to the health facility, communications, and transportation, etc. The cyclone also caused about the human life loss, and it's lost about 145 that's due to the cyclone Mocha. In response to the cyclone Mocha, the Ministry of Health, in coordination with the health partner, had discussed about the 57 rapid response teams and 30 emergency medical teams to Rakhine State to work together with the local health staff to provide the essentials and crucial healthcare service to the community. Our RT teams and the emergency medical teams are conducting about the rapid health needs assessment, conducting about the surveillance, risk communications, and treating patients in disaster-affected area. This slide shows about how the cyclone hits the northern Rakhine State, and in Rakhine State there are 70 townships in Rakhine State, and for the cyclone it's affected about the 10 townships with the affected populations of 2 million. I would like to give about some brief discussion about the RRTs and EMT background information in Myanmar, and the Ministry has conducted about the free epidemiological trainings and RT trainings and ENT training program in coordination with partners since 2010. We are coordinating especially with the WHOs and some ASEAN member countries like Thailand for free epidemiological training programs. So RT teams and EMT teams are organized at a national levels, and we are also organized at the third national level, like second administrative level, like state and regional level. And we also organize the RRT and ENT at the district level. Our RT teams and EMT teams are actually participators in response to any public health emergency events, which includes about the major communicable disease outbreaks, pandemics, such as COVID-19, and natural disasters like major flooding events and mass gathering events. The Ministry has had the highest priorities for the capacity building on the human resources, and Myanmar has conducted about the joint external evaluations in 2017, and it shows about for the joint external evaluation, there are 5 levels of the scoring system. The one is for school 1 is the very limited capacities, and for 5 is the sustainable capacities, and for the human resource capacity building, we got about the 3. That means it's like we have some kinds of the median school for human resource capacity building for the EMGs and RTs and FETP training program. So based on the findings from the joint external evaluation, we have developed and implemented about the national action plans on health security from 2018 and 2022. And so these are our 3 priority activities for the capacity buildings. And this priority activities includes about the free epidemiology training programs, RT training programs, and ENT training programs. However, I think we need about the more international cooperation for the free epidemiology, RT, and ENT training program. So the objectives of this study is to find out about the activities of the rapid response teams and the emergency medical team for contribution of the improved accessibility of the health service in Cyclone Mocha affected area in Rakhine State. So we have conducted about the descriptive analysis for the qualitative data, we collect the qualitative data daily from the rapid response team, emergency medical mobile teams, as well as from the health facilities and government health facilities and mobile clinics from the INGOs and health partners and UN agency for discrete analysis. These are our deployments of RTs and ENT from May to early May to early October 2023. We have discussed about the 10 central coordination teams to the cyclone-affected area. These teams are coordinating about the daily operations and reporting of the RT teams and EMD teams, as well as for the coordination with the local authorities and other reporting mechanisms and coordination mechanisms. And we have discussed about the emergency medical teams and special 33 emergency medical teams and the specialized teams, as well as we discussed about the 59 rapid response teams to the cyclone Mocha affected area. So these teams are distributed to the all 10 townships in Rakhine State. In Rakhine State. So these are the 10 compositions of the RTs and END teams dispatched to the cyclone affected area. So the main priority for the rapid response team is to gauge about the primary health care activities and public health activities and disease control activities. And so it includes about the public health physician, public health assistants, and public health supervisors. And in terms of the END, their main duty is for the emergency medical service, and so it includes about the emergency medical specialist, nurse, and nurse assistant. This slide shows about the activities carried out by the emergency medical teams and specialized teams. Our specialist medical teams and emergency medical team has conducted about the 58 major operations and 79 minor operations during the reporting period from 15 May 2020 to 9 October 2023. And the medical teams have also provided more than 85,000 OPD consultations during reporting period. These are sent photos from our EMD team, activity from the EMD teams, and they are providing about the emergency medical operations for the disaster affected pregnancies, such as ectopic pregnancy operation in 17 May, because the cyclone Mocha hits on Rakhine State on the 14th, and so for the 17th, there's some kinds of electricity blackout in these areas, and so our EMT medical teams are carrying out with available resources for life-saving measures like ectopic pregnancy operation. The EMD teams are also conducting about the basic ophthalmological activities, etc. And for activity, this slide shows about the activity carried out by the rapid response teams, and our rapid response teams together with the ASEAN ERAP team are together conducting about the health need assessment in early phase of the disasters. And so based on the findings from the ASEAN ERAP teams and our needs assessment, we are prioritizing about the health activity for the disaster affected areas. And in terms of the health service to the affected population, our RDs and local health staff providers about more than 370,000 consultations to community at the cyclone affected areas in Rakhine State. And in terms of the disease control activities, RD teams have chlorinated more than 70,000 members of the wells and water sources to prevent the diarrhea's affected area. In the morning presentation, I highlighted about there is not much changes in the diarrhea cases in cyclone affected area due to some kinds of the disease control activity. We also distributed about more than 400,000 water purification tablets to communities, and our RD teams are also demonstrating about the local community how to use for the water purification tablet. And our RD are also providing for the antenatal health care to the pregnant women, and they have provided about more than 35,000 AN care to the pregnant women in the local communities. Other activity carried out by our rapid response team includes about the health education and risk communication messages and others public health activity such as dengue control, COVID-19 vaccinations, and routine immunization, etc. This photo shows about the ASEAN ERAP team visits to the Rakhine State during 20 to 26 May 2023. in early phase of the natural disaster for how about the needs assessment in the local communities, and our RD teams are together with the ASEAN ERAC teams are conducting any assessments to the local community. This photo shows about the chlorinations and dengue control activities by our RD teams. And this slide shows about the photos of the COVID-19 vaccinations and routine immunization to the local community. In terms of the conclusion, the RRD teams and deployments of the RRD teams and END teams to the local community is definitely improves about the healthcare accessibility to the disaster-affected areas in Rakhine State. And there's no major communicability outbreak in cyclone Mukha affected area due to the efforts from our RD teams and END teams, as well as from the healthcare workers from the Ministry of Health in coordination with the health partners such as the WHO, INGOs, and NGOs that's our workings in the local community. And currently we are no longer dispatch the RD teams and END teams to the Rakhine State because the health services in Rakhine State is returned to the normals, and so we have sent to the we only sent to the RD team and EMT team after the early October, and currently we have no longer dispatch RD teams and EMT teams to the local to the Rakhine State. Thank you for your kind attention.
Thank you, Dr. Nguyen Win Mint. Any question from the floor? Please.
Hi, thank you very much. Very nice presentation. I'm Shin Jae-gawa from Tohoku University, and my question is about local healthcare providers that was affected by the disaster by themselves. So how do you support those local health providers when you dispatch a large number of RRTs and EMTs in the affected area? Supporting the outcome, supporting the exogenous or outside volunteers is also a chaotic situation in the affected area, healthcare providers.
Yes, thank you for your very good questions. And so, for every disaster, the local health staff are the disaster victims, and due to this, so the Ministry of Health is providing about the some kinds of the assistance to the local health staff. So we also provide about the some kinds of the moral support as well as for the some kinds of the financial support to the local health staff because their home, some of their home is destroyed by the cyclones, and so we provide about the some kinds of the construction materials and some kinds of the operational support to the local health staff. Not only the Ministry of Health is support to the local health staff, health partners such as WHO also support for the local health staff in terms of the some kinds of the incentives as well as for the some kinds of the moral support. Thank you.
Okay, any question? Okay, if no question, thank you very much, Dr. Nguyen Win Mint. And now we come to the end of this session, the session of Human Development and Education for DHM. I would like to thank all presenters. I know you need to have a brave heart to stand here and you do the hard work, and thank you for the floor, for the active participation in this session. Thank you.
Thank you very much, Mr. Fumin Selapunt, our moderator for session 2. May we invite you to proceed towards center stage alongside the rest of our panel of speakers for session 2. May we invite you along on the stage, please. We'd like to use this opportunity to present you all with our tokens of appreciation. And as an expression of gratitude, we will now present our tokens of appreciations. May we please invite onto the stage President of World Association for Disaster and Emergency Medicine, or WADM, Mr. Donald A. Donahue to present, please. Our esteemed and distinguished panel of speakers, ladies and gentlemen, hailing from ASEAN member states and invited partners of ASEAN. Thank you very much. And another one to present now from our colleague from Indonesia. A very special plaque from the government of Indonesia, presented by the Ministry of Health of the Republic of Indonesia to our speakers of Session 2 for the second ASEAN Academic Conference on Disaster Health Management, and last but not least, the final two of the recipients of our tokens of appreciation today from Brunei Darussalam, and lastly, our very own Indonesian colleague. And finally, for helping us navigating through the discussion today, to Dr. Pumin Silapun from Thailand as our moderator. An opportunity for a group photo, Mr. Donald, front and center. May we have you, please, at the center of the row. Right, front and center on the count of three, everyone. 1, 2, 3. One more time. 1, 2, 3. An amazing session 2. Ladies and gentlemen, our speakers and moderator, thank you very much, everyone. Delegates, ladies and gentlemen, it is now time for us to take a 15-minute breaks and get ourselves infused a little bit with the much-needed dose of caffeine. So if you'd be so kind to approach our buffets and tables outside, our delicious delicacies from Yogyakarta and your coffee and tea are ready for you. And may we have everyone, please, in the room in around 10 minutes. We will begin the final session of the day at 5 p.m. Thank you very much. Delegates, ladies and gentlemen, our next session is about to start. May we have you in the ballroom and be seated, please. Once again, calling upon our delegates outside, you're more than welcome to bring in your coffee, tea, and delicacies to your tables. Our next session will begin in just a few minutes. Thank you. Distinguished delegates, ladies and gentlemen, welcome back. While we continue to invite the rest of our participants to kindly join us in the ballroom, we now embark upon the final session of the first day of the conference, Session 3. We will be shining a light on a very interesting topic of EMT development. Allow me to introduce our esteemed moderator for this sessions, who had to flew many hours to get to Yogyakarta, Indonesia. Our moderator's expertise lies in managing emergency medical teams, negotiating with stakeholders, and navigating complex crisis situations. He has worked for over 17 years with several organizations on health emergencies around the world, particularly with one that we know so well, Doctors Without Borders, or in French, they call it MSF, Médecins Sans Frontières. I hope I pronounced it correctly. It is my great pleasure to invite Technical Officer of World Health Organizations on Surge and Rapid Response. Please give a warm welcome to Mr. Suel Resch.
Should I start? Okay. Good afternoon, colleagues, distinguished guests, and estimated. Sorry, I have to put my glasses because I cannot see anymore. Sorry. Estimated colleagues, on behalf of the WHO EMT Secretariat, I extend my warm welcome to this session on emergency medical teams, development in ASEAN and non-ASEAN countries. Unfortunately, we are the last session, so I hope you're going to stay all the session and expect you to be very, very active. Today's discussions are vital as we explore the strategic approaches and synergies fostering the growth of EMTs in various regions. Emergency medical teams, as you know, play as we have seen all the day during the presentation, a pivotal role in providing crucial medical aid during disaster and health emergencies. And their development is essential for building resilient healthcare systems globally. Today, we are privileged to hear from our experts, each offering a unique perspectives on EMT development from their respective countries. So our first speaker, Professor Yadiana Arapa from the Republic Indonesia Defense University will tell us more about the strategies EMT multi-country training hub. Following this, we will gain insight from Mr. Somana Latana of Laos and Ms. Naru Mol, sorry if I mispronounce, Sawan Payalerts of Thailand that will join us online, who both of them will further enrich our understanding of the challenges and the success of EMT development within their own countries. We will then shift our focus to the collaboration between the Japan Disaster Relief Medical Team, GDR, and the Disaster Medical Assistance Team, DMAT, as we explore how these two agencies reinforce and support each other. And the session will be presented by our distinguished speaker, Dr. Yushi Koido from Japan. Additionally, we'll broaden our perspective beyond ASEAN region and learn about the strategies for EMT development in the non-ASEAN region from representatives of Costa Rica and Fiji. So these discussions are not only intellectually stimulating, but also crucial for shaping the future of emergency healthcare worldwide. I encourage you, all the participants, all the guests, to actively engage at the end of the sessions in the dialogue and share the insights. So let us start. I will now invite our first speaker, Professor Yadiana Arap, to share valuable insights. So thank you.
Mr. Suhail for the nice introduction. Good afternoon, everyone. First of all, I would like to thank the committee for inviting me to deliver the talk about the strategies for EMT multi-country training hub development. Yeah, for the background, as we know that Indonesia is a country with many experience of disasters, its geographical, geological, and demographic condition encourage us to strengthen continuously our capacity in health emergency readiness. Because of that, Indonesia became the laboratory and learning center in disaster management and has a track record in the role at the global level. So in order to enhance the emergency readiness capacities, Indonesia government continuously arranged the regulation of disaster and also health emergency in national and subnational level. And the pentahelix conducted involving the government and academics and also social media and private sectors and communities to enhance our commitment, to strengthen our commitment for enhancing health transformation, health resilience, and health security. And also because of that, the health emergency readiness is the main factor in handling every disaster. Because we are from the Defense University, the Republic of Indonesia Defense University, in this presentation, I would like to propose about the EMT, but with the biodefense perspective. Oh, yeah. So in this slide, you can see that how to strengthen readiness. We have a previous outbreak for actual, and also we should see the potential risk in the future. So from the previous outbreak, we have natural occurrence, accidental release, or deliberate use. We see that in the last outbreak, there's insufficient number of drugs, vaccines, medical equipment, etc. And then for the potential risk, there is a biothreat about CBRNA, chemical, biological, radiological, nuclear, and explosive threat. And because of that, it needs to establish the Health of Emergency Center of Excellence to prevent, detect, and also respond to emergencies. In the biodefense perspective, we have collaboration from between the military and also non-military personnel. Slide. So this is the biodefense perspective. Biodefense perspective, the goal is the biosecurity, and finally we can obtain the health security. So we can see here that biodefense consists of biointelligence. In biointelligence, we can do the prevent and also detect. And while the health security resilience, there is the emergency management and also biosafety and biosecurity, CBRNA, laboratory capacities, and others. And then the result is health security. So the medical intelligence has the critical role in understanding and also in addressing about the health threats, both for military and also civilian. Slide. Now we go to establishment, the multi-country training hub. That is the background. From that background, then we can develop the module and the curriculum for the biodefense perspective. Slide. So following the COVID-19 in 2019, there is the presidential instruction directive to Minister of Defense to improve coordination, synergy, and cooperation in mobilizing defense sector resources to prevent, detect, and respond to public health emergencies and or non-natural disaster, whether intentional or not. And then it is followed to November 2020. the Indonesian Ministry of Defense sent a letter to WHO Director General to cooperate in biosecurity, especially in the defense sector, to tackle the COVID-19 pandemic. And then in June 2021, the meeting of the Minister of Defense and the WHO DG in Geneva to discuss about how to strengthen the emergency readiness capacities, in particular with a strong focus on biodefense for future threats. This includes the establishment of Center of Excellence that can serve all sectors to strengthen emergency readiness capacities at national and subnational level and contribute to regional and global level. And the Republic of Indonesia Defense University, it is an academic institution and part of the Minister of Defense, is assigned to lead the initiative as the Center of Excellence. Slide. So this is the goal of the cooperation or collaboration Indonesia and WHO to establish the Health Emergency Center of Excellence. It is a learning center for the trainee from the all sector who have a strong spirit for defending the country, especially who are interested or related to work in of health emergency operational readiness. This training aims to provide the necessary concepts and skills referring to the operational readiness of health emergencies based on WHO guidance and standard and lesson learned of natural disaster and health crises that have been experienced and faced variously in Indonesia, especially in biosecurity and biodefense fields. Slide. So this is the goals of the training and knowledge hubs that already established in the Republic of Indonesia Defense University. We have collaborating with the Ministry of Health and Ministry of Defense and other related stakeholders. The aim of the multi-country training and knowledge hub is to enable Indonesia and other countries to have complementary training and also research through new innovative training package and updated research. The training including simulation exercises and to ensure longer lasting skills and management acquisition and retention when practiced and sustained through refresher simulation courses, and the research not limited only to EMT, but the other research will conduct it, but still correlated to the emergency. And the goal is improving health emergency operational readiness capacities by producing potential trainers in the development of the training hub in the future to facilitate the improvement of the health emergency operational readiness globally, which is supported by innovative research. Slide. So this is the course that we have developed. Yeah, we proposed to WHO about the certified courses, health emergency operational readiness with biodefense perspective. We developed three main areas of courses: that public health emergency, medical and logistical management, and medico-socio-economic aspect. For the first that we have developed in 2023 is the emergency medical team, and supervised and supported by WHO, and we followed the guidance and curriculum from WHO. While the others also, we developed the curriculum based on the biodefense and biosecurity perspective. Slide. And this is the module. We have already developed 7 modules. Beside the EMT modules from WHO, we developed by ourselves in the Republic of Indonesia Defense University, and also we make the collaboration with other stakeholders. Slide. So this is the milestone. We didn't work alone. We engaged with related stakeholders. That stakeholders have a correlation with emergency, such as National Disaster Management Authority, National Search and Rescue Agency, and also Ministry of Health and other institutions. And then this is the important milestone in, you can see here, yeah, the yellow color, that is during G20 2020 in Bali, the MOU has signed by the Minister of Health, Minister of Defense, and also Director General of WHO. And in that MOU stated that the Republic of Indonesia Defense University become the center of excellence of the multi-country training hub on emergency preparedness readiness. Slide. And in 2023, we already conducted 5 agendas. So from March until October, we already conducted 5 agendas. The first training, this consists of team member induction training and training of trainer, and then continue the second training on July. This is also EMT, team member induction training and training of trainer. So for the first and second training, we recruited the participant from domestic or national, come from the Republic of Indonesia Defense University, and then also from our related stakeholders such as Ministry of Health, Ministry of Defense, National Disaster Management Agency, National Search and Rescue Agency, and also from academic institution and association. And then continue in August, we conducted the civil-military collaboration workshop. You know, in April 2023, WHO released the guidance for the civilian-military collaboration. And then in September 2023, we conduct the third training of the team member induction training and training of trainer. In the third training, we recruited participants not only from Indonesia, but also from ASEAN countries and also the district outside Java Island, such as from Kalimantan, Bali, Papua, and also Sumatra. And then the last week, yesterday, this is the EMT coordination cell training, EMTCC training. This is the last agenda in this year. Slide. In conducting the EMT training, it consists of team member induction training for 3 days. It is the entry point for roster members of the EMT organization from all specialism, a dedicated opportunity to come together and learn from one another's perspective and experience before each specialism progresses to further technical training. And then each training, we only recruited 24 participants. And then we select 12 participants, continue to the training of trainer. Slide. That is all for the 2023 agendas. So you can imagine in 1 year, we can conduct 5 important trainings in Republic of Indonesia Defense University, collaborate with the Ministry of Health, Ministry of Defense, National Disaster Management Agency, National Search and Rescue Agency, and the most important with WHO. So in 2024, this is our agenda, the roadmap for next year. So we want, we want to implement the other course that I mentioned before. We have 3 main courses, and also about the biosafety and biodefense for national and international institutions. And the second, biosafety and biosecurity, especially for infectious disease. This is the research with U.S. Defense Threat Reduction Agency, because they want us, the Republic of Indonesia Defense University, become the center of excellence on biosafety and biosecurity. And then the third, from the ASEAN plus military personnel, from ASEAN Defense Minister Meeting, or ADMM plus expert working group, asked to redo, to certify the personnel for EMT. And then the fourth, collaboration for education, training exchange and research with National Critical Care and Trauma Response Center in Darwin, Australia. And 5, collaboration in EMT training with European Defense and Security College, or ESDC. Slide. So the summary, this is the short summary. Our strategies for the development of EMT multi-country knowledge and training hub are rooted in a commitment to excellence, collaboration, and adaptability. Slide. This is some documentations that this is the historical for us, because in this documentation there are many efforts that we already conducted. Slide. This is when our Minister of Defense met the DG in Geneva to discuss about how to strengthen the Center of Excellence in the Republic of Indonesia Defense University.
Thank you. We have to
There are many slides, but it's okay. There are some pictures actually for the first training, second training, third training, but it's okay.
Okay, thank you. We have to stop because we have a tight schedule. Thank you very much, Professor Yadiana. From the audience, do you have any questions? Please go ahead.
Hear me? Yeah. Thank you very much, Professor Diana, for your great sharing your great insight. May I ask you a very simple but quick question? There's many training hub or training in this world and in this region, but how do you think, what is a key feature, what is a key value of your training hub? Thank you very much.
Yeah. Thank you. So there are many training hubs for EMTs. Yeah, in the world there are also many. Yeah, but in Republic of Indonesia Defense University in Indonesia, we developed the EMTs training that with the perspective of biodefense. So in every trainings we involving the participants from military and also non-military or civilian, and then we also conducted the content of the experience of the military together with civilian to deploy to the outbreaks area together, something like that. Maybe in the other EMTs training hub, there is know about the biodefense, biosecurity perspective. Thank you.
Thank you, Madam.
Thank you very much. Any other question? Okay, donc, thank you very much, Professor Yadiana. Please applaud. Thank you very much. And now we are going to welcome Dr. Somana Latana, excuse me, Deputy Director of Healthcare and Rehabilitation Department, Ministry of Health, Lao People's Democratic Republic. She's going to present the strategic plan for emergency medical teams. Please welcome her as well.
Good afternoon, nearly evening. Ladies and gentlemen, today I have the opportunity to come to present about the strategic plan for emergency medical team. So for our strategy plan, in this year we developed the process for the national EMT strategy, that we conduct the consultation meeting with the relevant ministry, department, and central hospital and line ministry to review and draft of strategy and finalize the operational plan. For the strategic plan for EMT, we will start 2024 to 26. Our vision we have to, our vision is an emergency medical team is always prepared for provide rapid health care and respond to disaster event, including public health emergency effectively. We have two goals. The first, strong the national EMT central and provincial level to ensure people to be accessed medical care for life saving. The second is a clear multi-sectoral coordination mechanism for EMT deployment. Because in the past, many sectors, they think that the emergency or disaster will be responsible for the health sector. So that's why I would like to make the multi-sectoral coordination in our country. The four strategic objectives, firstly, we strengthening the national EMT capacity, and the second is strengthening the provincial EMT capacity across all the provinces. And the third is develop the legislation and improve overall management. The strategic plan for emergency medical team Now I would like to present about the strategy objective. We have 4 points to strategic. One is strengthening for national EMT capacity. The first is strengthening development arrangement. And the second, conduct training EMT response to disaster and deployment SOPs for national EMT. The third is conduct the training for rescue team. And the fourth is conduct a simulation exercise for the national EMT. For the strategic objective to establish the provincial EMT and strengthening their capacity, we have 3 points. The first is establish provincial EMT, and the second, conduct training and simulation exercise for the own provinces. And the third is monitoring and evaluation from the central level once a year. The strategic objective 3 for develop legislation and improve overall management. We have 5 points to do in the objective 3. The first is develop necessary legislation and the financial support, because we have the challenge, the big challenge is for the finance to support for EMT. And the third is conduct the simulation exercise for national EMT. And the fourth is strengthening multi-sectoral coordination. And the fifth is strengthening international coordination. That is our objective. Now we come to the plan in our plan in this year, that we have the strategic objective 1, we will strengthening development arrangement, approved for the SOP. Now we wait for the approval from the minister, and after that we will distribution in SOP in the whole country, and establish the focus official to reach 24 hours per day. That is our plan. But when I come here, I saw many countries to their presentation. I have idea that we will adjust in our strategy for the clear and to make one response, one team, one ASEAN, one response. Yes. And I would like to thank for AACDM and ARC project to give our team to have opportunity to participate in this conference. And please continue to support Lao PDR. Thank you.
Thank you. Thank you, Dr. Latana. Any question for Dr. Latana?
If I may, thank you very much for Dr. Latina for your great presentation. I'm very impressed that you're now focusing on not just a national central level, but also the provincial level. But to keep the provincial level updated and keep the capacity building always challenging, I feel. But how do you see the situation? What is your plan to support the provincial level capacity building? If you have any idea, that would be appreciated. Thank you.
Yes, thank you for your question. Firstly, we would like to strengthening the EMT team, national team, and after that we have the support from technical from the WHO to extend to the provinces. But in the first year, I would like to extend about 3 provinces because we have the 17 provinces in our country, so we just step by step. And after that, the 3 provinces, the big provinces, will be trained in the nearby province to help them.
Thank you very much. One additional one. How do you choose those 3 provinces? Is there any background of those 3 provinces, if I may?
Sorry,
sorry. How do you choose? You prioritize those 3 provinces, and there's 17 provinces, but how do you choose those 3? Is there any thoughts on that?
We select like a part of the provinces. Yeah.
Thank you.
Yeah.
Any other questions? Okay. Thank you very much, Dr. Latana.
Yes,
Please
thank
applaud
you.
her. And we are going now to welcome our colleague from Thailand, Dr. Narumal. Is it working? Presenting the strategies for... Okay, can you, Dr. Narumal, can you open your camera, please? And can you hear us? At least, can you hear me? Dr. Narumal? Yeah, she's online. Dr. Narumal, good evening, or good afternoon, sorry. Can you hear me?
Yeah, I hear you.
Okay,
Could you check Thailand MT instead for the microphone? This one doesn't work.
Okay. Can you speak louder, please? We can't hear you.
Okay. Could you check? Could you help me to allow me to talk for Thailand MT instead? Because the microphone from computer doesn't work well.
Okay, you have a problem with your computer, right?
No, I want to use by using the Thailand MT microphone. But they not allow me to use that one for the host.
Okay.
Could you please allow me to using the microphone on Thailand MT, please?
From the audience, can you hear? It's a bit difficult, huh? Okay. Doctor. Okay.
No, I mean the microphone. Could you hear me? Because the microphone computer doesn't work.
No, it's very difficult to hear. Yeah, can you speak slowly, please? Or if we can, or maybe cut the video, our video feed, maybe it will be better for the connection. No? Dr. Narumal? Can you try again, please? So what we can do, maybe we can pass to the next and then once the connection is better, we can come back to Dr. Nahomal. So I will now invite Dr. Yushi Koido, JICA Arch Project Japan Advisory Committee, Director General of the National Hospital Organization, MHLW Japan DMAT Secretariat, and is going to present the synergy between Japan Relief Medical Team, GDR, and the Disaster Medical Team Assistant Team, DMAT. Welcome, Doctor.
Thank you very much for Chair for introducing me. I'm Dr. Koido, Director General of Japan DMAT Secretariat. Thank you very much for giving me the opportunity to speak today. My title is the synergy between the Japan Disaster Relief Medical Team, JDR, and the Disaster Medical Assistant Team, DMAT. The JDR and DMAT mutual growth and reinforcement. I have no idea. So, before that I started my presentation, I'd like to share a brief story. 29 years ago, I was dispatched here by JICA as a burn specialist to treat the victims of the Mount Meraki eruption. For about a month, I collaborated with a local doctor at the Sarojit Hospital performing the skin graft surgery. This mission was my first international relief activity, and it left a profound impression on me. Since then, I've decided to dedicate my life to disaster medicine. I truly believe that without my experience in the Yogyakarta, I wouldn't be standing here today. In that sense, today is deeply meaningful to me. Okay, let's start my presentation. So disaster medicine in Japan began with the Cambodian refugee relief mission in 1979. The response of the medical team to Cambodian refugee is the first response of the Japanese medical team, both domestically and internationally. This was a significant achievement and is said to be the origin of the disaster medicine in Japan. For this medical response to Cambodian refugee, the medical team had a delay in response because the dispatching system was not established at that time, and no systematic operations were conducted, since the team members consist of the only medical personnel without a logistician at the moment. In 1982, the Japan Medical Team for Disaster Relief, JMTDR, was established based on the Cambodian experience with a system to register and dispatch medical volunteer quickly. The Japan International Collaboration Agency, JICA, managed the JMTDR following the mission like the Ethiopian response. The Japan Disaster Relief Team Act was enacted in 1987. After the JDR law was enforced, the JDR team responded 60 times until 2023. Many of all deployments have contributed to develop the disaster medical care system in Japan. On the other hand, when we look at the domestic disaster response, as many of you know, Japan is a country prone to the frequent natural disaster. Consequently, the government has established the various roles for disaster response. However, it became evident that there had been no preparation specifically for disaster medical care until the 1995 Great Hanshin-Awaji earthquake. In this earthquake, over the 6,400 people died, but it has been reported that 500 of those deaths could have been prevented. This disaster became a wake-up event in the field of the disaster medicine in Japan. Since this disaster, disaster medicine in Japan has made significant progress. The experience from the international disaster medicine was applied to the domestic disaster. Following the 1995 Hanshin-Awaji earthquake, Japan disaster medical system established 4 main pillars, designated the disaster-based hospital, and established the disaster medical assistant team, DMAT, and implementing the broad area for air medical evacuation, and introducing the emergency medical information system. These were developed based on the experience from the international response, particularly in training medical personnel and disaster response coordination. Japan faces various disasters annually, and after each significant event, these systems are updated and defined based on the lesson learned. So with the international disaster response development, the academic field was also developed internationally. Although there was no domestic academic society on disaster in Japan at that time, the first international academic society called the ASEAN Pacific Conference on Disaster Medicine, we called it APCDM, was established in 1988 by Dr. Muneo Ota and Dr. Yasuhiro Yamamoto, who is founder of the JMDDR. And this photo is Dr. Rajak from Indonesia. He is also the founder of APCDM. It is worth noting that at this point, an attempt was made to strengthen the cooperation in the Asia-Pacific region. Domestic disaster-related academic science in Japan were founded following the 1995 Great Hanshin-Awaji earthquake. The Japan Society for Disaster Medicine, JADEM, was also established as a result of the Great Hanshin-Awaji earthquake. From this experience, the international disaster medical response is governed by the Ministry of the Foreign Affairs, and Operation Secretary is conducted by the JICA, and the team is deployed as the Japan Disaster Relief Team. On the other hand, the domestic disaster medical system is managed by Ministry of Health, Labor and Welfare of Japan, and the Japan DMAT Secretariat coordinated a response system, and Japan DMAT response as a domestic disaster response team. We have a separate system and organization. Although both JDR and Japan DMAT are under the authority of the different ministry, the fact that the member of the both team is the same reduce the negative effect of the vertically divided administration, and enables Japan for quick decision-making at the time of the disaster response. In another word, since human resources are the same, rather, JDR and Japan DMAT have stimulated and developed with a synergistic effect. One of the examples of the synergistic development of the disaster medicine is JSPEED and MDS. Japan learned practically of the surveillance in post-extreme emergency and disaster speed in the Philippines through the dispatch of the JDR to the super typhoon Yolanda that hit the Philippines in 2013. And after that, we developed the Japanese version of the speed. We called it JSPEED. JSPEED has transformed the Japan disaster medicine into a form that can be adjusted based on the data. Japan proposed the JSPEED to WHO for the international sharing of this knowledge. Based on the proposal, WHO established a working group to develop the EMT minimum data set, MDS, and adapted it as the WHO international standard. Another example of synergistic development of the disaster medicine is headquarter management and coordination. From over the 60 international disaster medical responses, Japan adapted to various medical systems in affected countries. This experience helped Japan refine its own medical coordination and management system. This system, initially influenced by the international practice, was standardized domestically. Later, it was integrated into the WHO EMTCC system. In events like the 2019 Mozambique cyclone, 2022 Moldova, Ukraine refugee response, and the 2023 Turkish earthquake, this Japanese coordination system was employed in the EMTCC setup. In conclusion, Japan international and domestic disaster medical response system developed synergistically since they had the same theory, philosophy, and procedure. Each development have affected each progress of the disaster medical response. This is not just going to be the story of Japan. For the ASEAN country to work together to have a synergistic effect on each other, you need to have a common language and common tools. This ASEAN academic conference is considered a place to build this foundation. Thank you very much for attention.
Thank you. Thank you, Dr. Koido. We'll go for a session of questions. Anyone? You raise your hand? No? Yeah, I have a question on the DMAT. Basically, it has been developed to respond to national crisis, not but do you also deploy internationally?
Yes. Thank you for the question. As I said, Japan DMAT never go abroad. But in case of a big disaster, for example, the Tokyo metropolitan earthquake, so at that time, we need a international medical team. So when international medical team come into the Japan, maybe Japan DMAT act as a counterpart for the international team. So we needed to collaborate with the international medical team in the peacetime through such a kind of the academic society or the training.
Okay, thank you.
Yeah.
Any question? Thank you. Can you please just introduce yourself and then ask?
Okay, thank you for the opportunity. My name is Livia. I'm a student of Gajah Mada University. Well, my question is, since the local and the international disaster is managed by two different bodies, did Japan ever encounter communication problems, and is there any specific mechanism to make sure that the information can be delivered properly? Thank you.
Thank you very much for the good question. As I said, actually, the member of the DMAT and the member of the JDR, almost the same member. So we discuss always about the countermeasure of the next disaster. So I think there is no problem that the communication between the two teams. But top level is, I don't know. Thank you very much.
Thank you very much, Dr. Kyodo. Please applaud him. Now, for the next session, we are going to welcome. Sorry, let me put my glasses. Dr. Mario Vilches Madrigal. So he come all over from Costa Rica, long way as well. He's the Director, Center for Emergency and Disaster Management, CCS, and you're going to present WHO EMT Global Initiative, a long-term commitment for Costa Rica. Thank you.
Good evening. I want to start by thanking the organization for providing all of us this great opportunity to engage, to see that, not to feel that alone in this quest to develop disaster medicine in our countries and in our regions. I have no conflict of interest to disclose. It's important to put a perspective on my country. It's a small country with 52,000 square kilometers and 5.2 million inhabitants. And we have no armed forces since 1948. And this poses a problem in disaster response because military always has some capabilities that are very useful during disasters. Ministry of Health is in charge of providing the policy of public health. And my institution, the CCSS, provides all the health care. So we have 92.1% of the population covered by insurance, and also we administer the funds for the retirement. And it composes 11.5% of our gross domestic product. And 1.2% of the population of Costa Rica works in our institution. Important to set up the stage for what we are going to speak about now. I was very fortunate to be participant of this seminar in 2005, and we started trying to develop the DMAT project. Who can't fall in love with DMAT once you know it? But we could not do it so far. So for us, joining the World Health Organization, a medical emergency medical team, was a very innovative approach for the provision of safe care during disaster. Because we do not provide any sort of pre-hospital care. Ambulance services are from other institutions. We only provide inter-hospital transfers. So there is a very big resistance for going outside the healthcare infrastructure. And all our planning was concentrated on augmenting surge capacity and capability inside the infrastructure of the hospitals. So we had absolutely no preparation, no experience, no DMAT. And at the end of the day, we all know that disasters, when they strike us all in the same way. So this is our response to the 2009 earthquake. As you can see, very even dangerous for the staff and response. So we needed to do something to change this. And the WHO EMT Global Initiative provided us with this excellent framework where we have all the principles, the standards, the typology, the coordination system for big-scale disasters, and helped us to promote the change from WHO to our organization. So whenever we had some resistance from some stakeholders, we would just refer to the WHO standards. And this was very important. This is the organizational chart of my institution. It's very complicated. I just want to point out that this project started with very few people involved. Our executive president, our big circle there is our office, and some other very carefully chosen stakeholders in order to avoid all the bureaucracy that might get in the way of developing such an innovative approach. And this was done from the top down. Very important for your countries that are trying to develop the EMTs to have this political support, because otherwise you reach a place where you cannot go on if you don't do it this way. At least that has worked very well for us. The executive president of the CCS at the time, she has had a political appointment. She worked for the Pan American Health Organization. She was involved in the guidelines of PAHO in 2003, and she was the former Ministry of Health. So everything fell in time, and you always need the signature of the people on top to be able to promote this. And we work very closely with the Ministry of Health, although as I tell you, they don't provide medical care. And political appointees change, but the signature stayed. So we had what we needed to go on with the project. We classified our team in 2017. We will talk about tomorrow in the engagement with the Pan American Health Organization, where we can share more of this information. And then the headaches start. Finance is very important for these projects, and it's also very difficult in resource-scarce countries. So we did some phased up, follow-up, initial investment, then follow-up investment. Then we had a gap in the preventive and corrective maintenance contracts during the pandemic. Now we have the budget for the surgical capability, but we haven't been able to start with this because of some planning issues. The non-emergency operational cost is borne by the ordinary budget, and I will speak about this a little bit more later, but we don't have registered how much this has cost us. And the emergency operational cost of the DMT is covered by the contingency reserve of the emergency in my institution. I would say dynamic or weak planning in the financial part, and donations also pose budgetary needs that you cannot plan for, but you need to be ready to receive donation and bear the cost of maintaining those donations. So after we set this up, we involved all the relevant stakeholders, but already with the signature of the big boss, so that nobody would give us a hard time. And this is critical because a project like this cannot be sustained without the involvement of the whole institution. We had a very nice warehouse at the beginning, but priorities change, and very quickly. So we have been assigned different warehouses. Now we're in 4 different warehouses. This is not sustainable. Maintenance of this equipment is very important because it will get damaged if you do not do this. And we need to do this indoors. If you do this outdoors, the rain or whatever is going to be a big problem for you, and you need the space. So we received a large donation from tents and medical equipment. We started with 6 medicalized tents, not tarps, but proper medicalized tents. And we received 23 donated tents, so now we have 29. And from 2 self-sufficient deployment points, now we can do 5. This is very good, but we need a new warehouse. We can't have this amount of equipment in the installations we currently have, so we need to adjust, make a plan. It's over 2,000 square meters that we need, so it's important for you to plan for expansion. Not only reach the finish line, it's only the start line once you classify your team. We have a core team to develop and sustain the emergency medical team. It has been heavily engaged with PAHO, WHO, and also JICA. We trained with our training program a core group according to the standards. This core group led the response during the COVID pandemic, and new staff had to be trained on site because we had no time to train them. But many of the staff have already changed positions or been burned out. So we're having a lag in our trained staff. Now every resource in the healthcare system, my institution has been moved to recovery of the services that we could not provide during the pandemic. And so this makes us compete against these other more urgent and immediate challenges. And there's a constant negotiation. This has set up our schedule back also, but we're still restarting and re-engaging in all these things. This is very important for us. How do we train our people? How do we make the institution see the emergency medical team so we take care of outpatients that have not been taken care during the pandemic, ambulatory surgery or outpatient procedures, and even if our infrastructure needs remodelation, we deploy to support and maintain the continuity of the services. It's important to regulate the non-emergency operation because once they see that this is viable and successful, everybody wants to have an emergency, so you send the EMT to that hospital. So it's important that you do regulate it very clearly. And only this year, we have taken care of 5,896 patients that were in the recovery phase of the COVID pandemic. Okay, some We did during the pandemic emergency-related 29 deployments, 21 related to the pandemic and 8 not related to the pandemic. We could see 324,000 patients in these deployments. And we did many different type of support to the hospital. And it allowed us to place the EMT where we needed it for the time we needed, then take it back, put it in the other sector depending on the different waves behaved and the regional affection or impact of the pandemic. So this gave us a lot of flexibility to support the hospital system to deal with the COVID patients. This was my hospital for over 16 years, so I put the picture. But this is the type of, the picture on the right, this is the type of medicalized tent that we use with full air conditioned and all the services. And we use here all the water purification system and the electrical power supply, all the self-sufficient aspects that the EMT initiative has, and all the standards. So that the registry of patients, everything, so that we do not cut corners, because it's very easy to start cutting corners when you deploy. I think these 6 points are, for me at least, very relevant, that you need to involve the highest level of your organization early on in the process. You need to prioritize national capacity, because it's very difficult to sell an investment like this scale just to international. And the gap from national to international will be closed in the process. You need to demonstrate with data all you do so that you can justify it to your financial authorities. They understand numbers very good, and we physicians sometimes don't like to give them the numbers they need. So let's make an effort and give them the numbers they need. You need to plan long-term. This is not a 2-3 year planning cycle. And at the beginning, I think we planned not for the long term, but we are trying to expand our horizon. You must always try to follow the WHO standards. Because as I said, it's very easy to cut corners, and when you realize, then you are not providing safe care to the patients. And we will speak about the regional WHO office involvement with our institution tomorrow. But this venue, this event, is an example of how you can support yourself with the regional and sub-regional partners to make this together. It's easier than to make it on your own. And this concept of one ASEAN, one response, something I am bringing back to Costa Rica. Maybe I changed the slogan a little bit, but I think it's a very good example of how things should be done. Thank you very much.
Thank you, Dr. Mario. Now, go for the questions. Very interesting. Any question? Yeah, please introduce yourself and go on with your question.
Thank you for this opportunity. And thank you very much, Doc, for the very inspiring presentation from Costa Rica. I'm wondering, throughout the 16 years of experience in managing your EMT, are there any major changes over time that, yeah?
Yeah, the biggest change has been brought about by the new standards. And at some point, the 2013 Blue Book had diffuse standards, sometimes hard to comprehend, and the operational and logistical support was not very well developed. but developing and participating in the update of this book, of these guidelines, has given us a clearer framework for our preparedness. So I think that the best part of this is that the standards and the Blue Book gets updated, and so you have a further reference to keep improving your system. So the biggest change, following the new standards.
Thank you very much. Any question? I have a question. Do you deploy internationally?
This is, unfortunate, we haven't been able to deploy internationally yet. The main problem is the funding allocation of the CCSS. By law, it cannot be used outside, and our MOU with other partners in Costa Rica and international collaborators has had some implementation hurdles that we haven't been able to fill yet.
Thank you very much.
Oh, thank you, sir. Thank you very much, Dr. Mario. I'm a member of JDR teams, Japan Disaster Relief Teams. I'm a clinical leader over JDR part. I have one question. Sorry. So when we are going to affected countries, it is a very challenging. The point is the transportation. So I think the anticipated is total weight is a EMT type 1 fix over 10,000 kilograms, I think. So how do you the management of transportation from a country to the affected country? And more, you arrive at a affected country airport, how do you management within affected country?
Okay, right. The national transportation is taken care of by our institution. We have a logistical branch, and we can cover land transportation for our team and for visiting teams also in case we need to request international assistance. As I said, we don't have military. So the airlift capability is in the civilian, at least in our country, is very limited. This is one of the biggest problems that we have. So we need to fill this gap with international partners to bring enough airlift capabilities to transport our equipment. So far, we haven't had this need, but we are sure we're going to have it. So we have been working closely with PAHO and some other agencies, for example, the US Embassy in Costa Rica and Southcom, to address this issue. And for the international deployment, we have not deployed internationally, although I was in the Haiti earthquake in 2010, and I arrived at Port-au-Prince Airport, and so we understand very clearly the big challenges of deploying by air in a real disaster.
Thank you very much. We have another question. Two, and then we have to move on.
Thank you. My name is Ryoma Kayano, Technical Officer of WHO Center for Health Development, located in Japan, Kobe. In charge of the research on disaster risk reduction and disaster risk management in collaboration with our headquarters disaster risk reduction unit. And thank you, Mario, for great presentation about and also emphasizing the importance of the engagement of countries and the engagement of all stakeholders, including the on-site workers and WHO and regional offices and the other stakeholders, including government. That is wonderful message I received from you. And also I want to say thank you to ASEAN countries and also the event organizers for this wonderful event. And my question to you is, through the current ongoing initiative, are you planning to any possible further collaboration with some research part? Means because doing the activities, on-site activities, EMT's initiative is simply great because of the standardized data collection tool is enable the standard kind of the systematic data collection, and it enables the identification of the health issues real time. It enables this resource allocation effectively. So that's wonderful. But how do you have any plan to using this momentum to create further evidence for the better policy and program in the future?
Unfortunately, we have not published any data about our EMT work. We have, I must say, we have an electronic medical record for the whole healthcare system, and when we deployed the EMT, we try to use the electronic medical record. So we are in a position to provide a lot of information, but we have not set probably a priority on this area. After the academic conference here, I think we have a lot of rethinking to do.
Thank you.
Thank you very much. Unfortunately, we have to move on because our colleague from Thailand, she's online, Dr. Narumol. Can you hear us?
Yes.
Thank you very much. Sorry. And don't hesitate to reach to Dr. Mario if you want, if you need more questions. Very interesting.
Okay.
Dr. Narumol.
Yes. Good evening, everyone. I do apologize for my inconvenience about the net, my net. Okay. Yes, I'm ready now. Thank you.
Please go ahead.
Yes. For my presentation, I would like to thank you for the art project for JICA and also for Indonesia government and ASEAN team members and ASEAN Secretariat that allow me to share my experience on this one. For my talk, we'll talking on the strategies for EMT, Emergency Medical Team Development in ASEAN. Next slide, please. For the content, we'll be focused on two topics. The first one is strategy of National Emergency Medical Team or National EMT, and the second one is the strategy of EMT in ASEAN. Next slide, please. This is the Thailand National EOC, which is under the National Disaster Risk Management Plan, which start from 2021 till 2025. So the control this because the Ministry of Public Health and will be under the National Disaster Risk Management will focus on medical care on that one. Next slide, please. And I will focus on the Public Health Emergency Operation Center or Public Health EOC. Okay, next slide. So this one want to show that for the Ministry of Public Health will be the primary agency focused on when the disaster occur in our country. We have a variety of the department. As shown in the picture, my department is Department of Medical Services. We will focus on the medical services and other department. And we have the support agency. NIAM is one of our good colleagues to work together on the disaster, including the military, Ministry of Defense, and also the Red Cross. And DPM is a disaster department, prevention and control. And MOFA, Ministry of Foreign Affairs. Next slide, please. In the Public Health Emergency Operation Center, when we have problem, we will focus on the, for example, the COVID-19 that we have, or mega flood in the previous long time ago. And up to now, we have the problem with flu, influenza, and also the other disease that occur. We have the team from the small group on the working on the situation surveillance, medical services, and also the networking with other team, including the logistic support. Next slide, please. So to focus on the National EMT, in Thailand we call MERT. Next slide, please. MERT is the stand for the Medical Emergency Response Team. We work very closely with the ERT team. ERT stand for Emergency Response Team, which is the rescue team. Next slide, please. For the MERT in Thailand, that we have the multidisciplinary volunteer healthcare provider team. We work as the medical operation response during the disaster, and also most of the team that will focus on the concept of medical readiness, rapid deploy, operate in the Austrian environment, and will prepare and training. Next slide, please. For the MERD mission, that we have the 3 T. The first one is treatment, triage, and transfer. For the treatment, that similar to the EMT, that we have the first aid and field care. We've really concerned on the sanitation, medical evacuation and transportation, and also the sanitation, healthcare for victims in the shelter, and also for the, we have the health need assessment. That's all. That's for all. Right. Next slide, please. This is the just the make you understand that when we have the any disaster, we have search and rescue team that will working at first aid. They will take the patient to the MERD low for the triage, treatment, and transfer, and then we could stabilize the patient for safely and transfer either by ambulance or by airplane or helicopter. Next slide, please. This is the showing you that the MERD training in national MERD or national EMT, that we training in the class for 4 days and in the field for 3 days. They compose of the 17 person. The MERD team, they have 2 doctors, 4 nurses, and 6 emergency medical technicians, 1 pharmacist, and other team that composed of 17 to 20 persons in each province. Next slide, please. And now, as we start the MERD since 10 years ago, up to now in Thailand we have 77 provinces. We have 77 MERD team under Ministry of Public Health, and we have the 6 military MERD under the Ministry of Defense, and 2 Navy MERD under the Ministry of Defense also. Next slide, please. And this one want to show that from the medical team on the national EMT transfer to the national EMT. Next slide, please. In the 2015 that we send the team to abroad for helping as the request from the Ministry of Public Health in Nepal, and we send the MERD team with other team, and after that we apply for the EMT initiative. And next slide, please, which WHO set up, talking that is a group of health professionals, everyone understands, similar that one. The key service, we apply for the Thailand EMT Taiwan fix, which similar to the national EMT, the triage, assessment, and first aid, stabilize and refer. Next slide, please. And after that, we take about 1 year. We apply and working very closely with our mentor. Thank you for Dr. Kai from Japan also, and Dr. from the Abigail from Australia that help us working on this one for the Thailand EMT Taiwan fix. Next slide, please. In July 2019, we verification by the WHO. Next slide, please. For the Thailand medical emergency has been classified as EMT Taiwan fix. But unfortunately, during the 2020 to 2022, we have the problem that we face with the COVID-19 pandemic, as every country that we have. But however, for the positive view, that we have a good opportunity for the Thailand EMT to experience how to respond to the COVID-19 outbreak, and we work very closely with other MERD in other provinces. Next slide, please. We have the temple. We set up our Thailand EMT in the temple. Yes, next slide, please. This is our, just show the picture that we work helping, because at that time, I think, at that time it's a Delta pandemic at the time. So many people really severe and have many places to helping. Next slide, please. This is the field hospital Thailand EMT that we set up to screening before helping. And this one is the one of the province that we have the many foreigner as a worker, and also foreigner that have infection, but they could not go to anywhere, and overwhelmed of the hospital. So we set up the field hospital. Next slide, please. This is just show the picture and sharing our experience on that one. Next slide, please. And we learn many things back for the new technology. For example, telemedicine and telepharmaceutical to helping to treat the patient, like in the picture on this one, and that represents in the slide. Next slide, please. From this lesson learned from the pandemic response, facilitated us to set up the plan for capacity building and strengthening for the national EMT potential in Thailand. Next slide, please. From after that, for this year, from the end last year, that after the pandemic go to the normal situation, we refresher for the MERT team, and also we plan this year. We plan to have capacity building more in the field for the MERT that we have already trained and work closely with the military team. Next slide, please. And also the Royal Thai government policy commitment that will support Thailand EMT in terms of training, scenario exercise, and drill, including the sharing of experience to our neighboring country. This, which is really important to enhance the collaboration and capacity building to develop the statistic for the EMT in our ASEAN. Next slide, please. From this one, we got the budget from the Ministry of Foreign Affairs and Africa in terms of TICA. We set up the regional workshop on training needs of the medical emergency response team under strengthening the MERT team in CLMV country project. And after that, next slide, please. This is the team that, next slide, please. Yes, thank you. And this was the team that we set up from the CLMV country that we have the team. Yes. Next slide, please. And this is our friend from Myanmar that we are working to close together. That's how to help sharing our experience together. And also this year, next slide, please. We have a training with the, also the Minister of work with closely with the Ministry of Foreign Affairs and also Thai Academic on the emergency team, working together to working on the comprehensive life support course on training them and sharing experience that we learn each other, and then we to get some material to work for home to helping the national EMT team in our neighboring country. So finally, I would like to give you take home message on this one. Next slide, please. Policy support is very important, including the quality assurance. For after anyone our training, we either in the class or in the field, we need to have the quality assurance to make sure that everything will go on the right track. Practice and practice and practice, including the simulation exercise. I think for this one, I will would like to thank you for everyone for your kind attention, and we could sharing experience in the future. But I do apologize again that I cannot join for the meeting in Indonesia. But I will work together with you. Thank you very much. Next slide, please. Thank you.
Thank you very much, Dr. Nahomol. We'll go now for the questions. Any question? Please introduce yourself and question.
Good afternoon. I am Dr. Lam Muisien.
Can you use, maybe you can use the other microphone behind you.
Yeah. As you know, I am Dr. Lam Muisien. I have two presentations today. So I would like to ask Dr. I forgot her name, that present the EMT in Thailand. Cambodia will be develop the EMT and this year, maybe next month. We have support from WHO to develop. I would like you to share with us on number of EMT in one team and critical for EMT to develop the EMT team. Thank you very much.
Yes, thank you. To answer your question, that our Thailand EMT, we compose of 32 persons. We have the 4 doctors, and we have the 9 nurses. We have 1 pharmacist, and also the medical emergency medical technician, 9 person. This is the medical team part, and for the technical logistic, the rest will be the technical logistic, which composed of the electric person, the communication, the nutrition, and also others. So it will be 32 persons for our team. Yes.
We have another question.
Could you share the document on the EMT and critical of EMT? Could you share?
Dr. Narumol?
Yes, yes. For the document, I could share the number of that one. Yeah. But for in the detail of the SOP is depend on WHO, because this one will be, we have to discuss in the detail later on that one. Yes.
Yes, thank you, Dr. Narumol. I'm happy as well to share with you the link to the Blue Book, the minimum standards, if you require. Any other questions? I think we need to move. So now we have our colleague from Fiji, Dr. Luc Nasedra. He's going to present EMT accreditation, the effort, the challenge, and the strategies. And Dr. Luc is from Fiji Emergency Medical Assistance Team, FEMAT. Welcome.
Thank you. Good afternoon. Excellencies, distinguished guests and delegates. I bring to you greetings from Fiji and the Pacific Islands. I thank the organizing committee for the invitation and the sponsors for getting me to this beautiful Yogyakarta. I work in Fiji's for largest hospital, and that is part of the Ministry of Health. I am here because I was the chair of the Fiji Emergency Medical Assistance Team and Disaster Response. Before I proceed, I would just like to take this time to thank the Indonesian government. 2 weeks ago, we celebrated the 70th anniversary of our secondary school that I attended. It was damaged in the 2016 tropical cyclone, and the government of Indonesia stepped in and adopted the school and repaired the damages dormitories. And 2 weeks ago, we celebrated the 70th anniversary, and I want to thank the government of Indonesia for the support. My task today is to share with you the EMT experience and the journey for Fiji. What you will hear today is the result of, is not the sole effort of Fiji. It is the result of regional and international collaboration. And I would just like to take this time to thank WHO EMT for all the support, WHO Fiji office, the Australian government and AUSMED, the New Zealand government and NZMED and JICA for all the support that has been given to Fiji for us to be able to get our EMT team underway. I have no conflict of interest to share with you. The Fiji Medical Assistance Team, we call it in short FIMET, was established in late 2016. In May of 2019, we became accredited as a Type 1 fixed medical international emergency medical team. When we were verified and accredited, we became the 25th EMT to be verified by WHO EMT, and we became the first developing country to be accredited as an international EMT. Why did we do it? Well, as you all know from the yesterday and today in the presentations that have been going, EMT is a proven concept that will protect developing countries from ad hoc practices by visiting medical teams and EMTs. Fiji has been engaged in some form of EMT operations, but has not been recognized as EMT by WHO prior to 2019. And in order for us to do this, we need to align to this WHO EMT concept and international standard for us to appear on the global stage of disaster response. So I just like to take us back that in 2010, we developed what we call the Fiji Head Map. This is the Health Emergency and Disaster Management Action Plan for Fiji. And that guides all the disaster response in Fiji from, even we have been doing it, but from 2010 that was formalized, and it was a guiding document that has been with our Ministry of Health. In 2019, the ministry was invited by the Republic of Fiji military forces to join the UNDOF mission, UN peacekeeping mission to Syria in 2013. It's the first time that a big team from the Ministry of Health got deployed in a conflict zone. And I happened to be the team leader for that deployment to Syria in 2013. And then in 2015, because of the experience that we had when we came back from Syria, when they had the tropical cyclone Pam in Vanuatu, Vanuatu asked for assistance from Fiji. And because we had a team from the Ministry of Health that has been deployed to conflict zones, we were asked if we can put together a team to go to Vanuatu. I eventually had to lead that team to Vanuatu. And then in 2016, we had our own share of tropical cyclone, Category 5 tropical cyclone that hit Fiji with the devastation. We managed to do some organization around the response for Fiji during that tropical cyclone. Now, and I know that hearing the presentations that have been going through in the last 2 days, how do we handle a Category 5 tropical cyclone that has almost devastated half of Fiji? And we put together an operational team that we managed to organize the response of the local team and also to receive the assistance that were coming from the international EMTs that come to Fiji. And so this was happening even before we entered the EMT program. So how did we do it? It requires a lot of effort, commitment, and collaboration. And we had to overcome the challenges that come with this. And along the line, we have to develop some core strategies that align to the Blue Book of EMT for us to be able to achieve the target that we have set before us. So I just want to take us on the effort, the commitment, and the collaboration. Why I'm mentioning this is we didn't do this alone. We had to do this with the collaboration of the international and regional organizations. We had to make sure that we set up a system, EMT, that we have to set up a system that can deliver quality care and align to a standard. And the international standard, the minimum standard is set in the EMT Blue Book. And we need to start training our human resource. We need to build up a team of medical staff that will be able to be deployed during the time of disaster. And we need to set and show that whatever response that we are going to do is going to be a timely response, that we can organize ourselves within the first 48 to 72 hours and go to a disaster zone. And one of our biggest challenges is, okay, we've got all the logistics, we've got the cash, we need to have a system of deployable logistics. It's very interesting, the questions that has been asked about how do we deploy the logistics, the cash that we have for a type 1 fixed. And then we need to develop a safe and resilient network and a sustainable system. So the challenges, one of the biggest challenges that we have to face is accepting the change. You know, there is a norm. We have a system. Why do we need a new system? And we have to overcome that. And number two is we are a resource limited country. resource constraint, and we need how can we get the resources. So this is where we engage with donor partners, stakeholders, to make sure that we got the resources that we need. A committed technical working group. There were 6 of us that started the work in late 2016, and we see it through right to the verification in 2019. And if you can see the picture right on the right, you'll see that there is our mentor. So in the EMT journey, there is going to be a very important need that we need to work with a mentor that will guide us. People, our mentor is from OSMET. They've done deployments, they've done verifications, so they will teach us how to get there, and they guide us there. And there is a vision that we need to achieve. So FIMET is a small team, but the vision is on the picture at the top there. That is the field hospital that we put up during COVID-19 when we have to support one of our major hospitals during COVID-19 when the hospital was under lockdown. That is when one of our first major local deployment within Fiji. The governance strategy, it's 3 simple governance strategy. Number 1, there needs to be a political and administrative commitment. Without that, we can't proceed EMT. For us, I can remember that I entered the EMT environment in June of 2016. I made 2 submissions, and in October of 2016, finally the administrative and the political willingness comes in, and we started the journey from there. That started our journey, that our leaders are willing to go along the way. And then the next one is we need international and regional collaboration. We couldn't achieve it alone, and that is where the international and the regional organizations. The ASEAN One Response concept that I've heard in the last 2 days is quite very interesting, and I think that is the way to go. And then we need a technical working group that should be the leaders. The international community can't move in unless we, the locals, can take the step. We stand up and we take the first step, and they will come in. They will see that we are there, that we are willing to go along the way, and that's where we need good technical working group that will lead the work towards EMT. So our outcome for FIMET, we became nationally recognized. In Fiji now is, for any disaster, the most immediate call, even from ministries other than the Ministry of Health, can we deploy FIMET? So FIMET is now like a national icon when it comes to disaster response. And this has given us the strength that even the other ministries apart from Ministry of Health has recognized FIMET. And that is one of the biggest plus for us. FIMET becomes the response mechanism in outreach, even clinical. So in peacetime, we go for outreach. We take our case, our tents, we go for surgical outreach. We don't leave the tents there, we take it out. We go for outbreak response and national and international deployment. And we set national standards. We set standards even in Fiji. And we've got ground and maritime response capabilities. And after all, at the end of all of this, it's about saving lives in times of disaster. So what happens after FIMET became verified? We didn't wait. After the verification, we started going on land and maritime outreach. This is where we take the case, we see the limitations in the case that we have. We start learning from even after the time of verification. So in 2020, we had a share of tropical cyclone. So within a month, we had 2 tropical cyclones that devastated half of Fiji again. And we managed because we have a system in place that can be deployed effectively. In 2021, we had the Delta wave. We managed the Delta wave, and I've shown you the field hospital that we set. We managed a hospital lockdown, and we also, in the event of a hospital lockdown, we were hit by a Category 5 tropical cyclone, and we managed. That is because we've got a good system, EMT system, in place. In 2022, the government of Tuvalu requested for help for the COVID response, and we deployed FIMET. 2023, we had the tropical cyclone in Vanuatu, and they requested the assistance of FIMET, the Fiji government, and we deployed internationally again to Vanuatu. So what is the future for FIMET? At the moment, our team is working very hard because we need to be re-verified in next year. So next year will be the 4th year of FIMET. We need to be re-verified under the WHO EMT process. And now we are thinking of, we need to see if we can go for Type 1 mobile international EMT verification. So we are thinking about that. We've already got an SOP. We might now need to tweak the process and the logistic process to suit Type 1 mobile. We've already got the case for Type 1 mobile, and now we are thinking and we are already in the discussion to get it verified. We are also thinking of going into specialized cell accreditation. So we've got the rehabilitation cell, the surgical cell, and also the public health. And just like the one ASEAN one response, we are also contemplating on a regional Pacific medical assistance team where we can join the Pacific Islands into one response team. I just want to take you with this. We've got a medical boat. This boat was built in Malaysia under the partnership of the Fijian and the Malaysian government. When I went in 2018, they said, we've got a boat and the medical floor is empty. So just in time, we were working with FIMET and we put in the process and the plans to have this medical boat. So this medical boat, every year, will visit every island in Fiji, even in our normal operation, and also is available during disaster operation. I want to finish by acknowledging the organizers of the second ASEAN Academic Conference on Disaster Health Management. Thank you so much for your invitation. And I want to thank JICA for sponsoring my trip from Fiji, the logistics team, and the liaison officers that were waiting at the airport. I was privileged to be here, and thank you very much for your time.
Thank you very much, Dr. Nasedra. Is there any question you have for Dr. Nasedra? Yeah, please go ahead.
Thank you very much. This is Tatsu from Japan Advisory Committee of the ASEAN Arts Project. Thank you very much, Dr. Luke, for your great sharing your great history of a great team. We are very inspired. And my question is, you mentioned about the outcome of the establishment of the FEMAT. And that's made, and now you have a very big recognition, not by the Ministry of Health, and other partners notice your great capacity. And my question is about, is that impact is only for the disaster time, or did you see some outcomes even for the peacetime medical services? Do you see some impact on the peacetime?
Yes, thank you. Our FIMET technical working group is working all year around. So, like now we are ready for our disaster season is November to April, and that is where we stand by for disasters. From May to October, that's when we utilize FIMET for peacetime operation, mainly for outreach. Now with the concept of universal health coverage, now our boat, as I have mentioned, our boat is now being used in screening for the outer islands in Fiji, and also we respond to even outbreaks, LTD outbreaks, even in Fiji. So whenever something happens, the quick call from government stakeholders is, can we send FIMET? Can we have FIMET? Yeah. Even when NDMO, which is our main disaster lead, when they run even a training or an exercise, if in the last minute, if they find somebody can identify, we're about to run a disaster training, we can see FEMET in the program. Even we have been called in last minute that there's a disaster training that is happening. So not only that the ministry is, but the other government stakeholders have recognized FEMET as a disaster response mechanism in the country.
Thank you very much, Dr. Luke.
Thank you very much. I think this is the last question. I will not do the remarks, right? But yeah, thank you very much. And please applaud Dr. Nasedra from Fiji. That's 3 words? Yes, let's go ahead. Key takeaways from the session. For me, I will not go through the details. Political commitment. If you want to have an EMT, an active EMT, sustainable political commitments, international collaboration and commitment from the different partners. And that's what we're doing here. Legislation. We have heard from Costa Rica that there is some constraint regarding the legislation in the country, but also from Laos that there is a legislation that helps as well to put in place this development of EMTs. And finally, from the last point is common language and common tools that is needed. And this is where we are here. We mentioned the Blue Book, but you have also, the ASEAN has also developed a lot of SOPs that can be used for the development of your own EMTs. Sorry. Thank you very much.
Thank you very much, Mr. Moderator, for summing it up for us at the end of the session 3. We truly appreciate it. And may we also request you, Mr. Moderator, to please join us front and center for us to present our tokens of appreciation. And may we also invite our panel of speakers for session 3 to kindly join us up on stage as we'll present to you our tokens of appreciations. May we invite from Indonesia, Ibu Yahdiana Harahap, from Laos PDR, Mr. Somana Latana, and also from Japan, Mr. Yuichi Koido, from Costa Rica, Mr. Mario Vilches Madrigal, and from the Republic of Fiji, Mr. Luke Nasedra. Do join us up on stage, please. And to present a token of appreciations, may we request from Japan, the chair of Japan Advisory Committee, or JAC, Mr. Tatsuro Kai. Shall we start from the first end? First, Mr. Kai, to Madam Somana Latana from Laos PDR. A token of appreciation presented for such an insightful presentations and inspirations for session 3. Thank you very much. From Laos PDR. And next up to Ibu Yahdiana Harahap from Indonesia. Thank you very much, Ibu, for your inspirations. To our colleague from the Republic of Fiji now, Mr. Luke Nasedra. It's amazing that we get to hear not only from our colleagues of ASEAN member states, but best practices from around the world as well, from Fiji, ladies and gentlemen. And next, may we have Mr. Kai present to Mr. Yuichi Koido from Japan. Arigatou gozaimasu. Terima kasih banyak. Thank you very much, Mr. Koido. And last but not least, completing our panel of speakers all the way from Costa Rica, over 30 hours flying to Indonesia, to Mr. Mario Vilches Madrigal. Thank you very much indeed for your inspirations. And to our wonderful moderator for today, flying in from the cold autumn of Geneva to the scorching heat of Yogyakarta, Mr. Suhail Resh. Merci beaucoup. And now a moment of group photo, please. Mr. Kai, front and center. May we have you at the center of the group, Mr. Kai. Mr. Tatsuro Kai, at the center, please. On the count of three, ladies and gentlemen, for session 3, 1, 2, 3. One more time, smile to the center. 1, 2, 3. Look at these faces. Let's give our biggest round of applause, ladies and gentlemen, for a wonderful session 3. Thank you very much, speakers and moderator and Mr. Kai. May we invite you to return to your seats. Thank you very much. Distinguished delegates, ladies and gentlemen, we have come to the end of our first day of the conference. What a day, what an achievement. We've been inspired so much throughout the day today and more to come tomorrow. And thus, may we kindly inform you that tomorrow we start bright and early. We wish everyone a restful evening. But if you feel like a quick stroll, just for your information, the notorious shopping street of Malioboro is just 2 minutes walking distance from this hotel. So feel free for a quick look. Spend your rupiah on some beautiful pieces of batik, one of the world's intangible cultural heritage from Indonesia that made it into UNESCO's list. But tomorrow, may we remind you, we start at 8:30 Indonesian time. So in the meantime, we wish you a wonderful evening. Thank you so much for your participation. I'm Rahmat Idris. We'll see you tomorrow. Good night, everyone.